Chandrasekhar. Dr. Chandrasekhar has been a pioneer in TEE imaging in mitral valve disease, both in the US as well as in India. Over to you, Dr. Chandrasekhar.
I think we all can come closer, we can have a discussion rather than me talking to. Art that you can pick up just by doing one day cath, other day imaging, other day. No, you have to give totally devote your time. But never, I think regarding the tricuspid transcatheter edge-stage repair of the mitral valve, the key important thing is, since it's going to involve the mitral valve, you need to know the mitral valve anatomy thoroughly. I think you should never be able to have any question regarding this. So this is an anatomical picture. If you counterclockwise rotate it by about 30 to 40 degrees, then it will look like the way the surgeon is going to be looking at. This is when the patient is lying on his back. When we do the echo imaging on left lateral, it's going to be similar to this. But whereas when the surgeon looks at it, it's not exactly the same, it's a little bit turned. So if you look at it here, the most important thing, what you're going to be seeing here is, mitral valve is not a circular structure. That's number one you have to keep in mind. Second, mitral valve annulus is not uniform. That's number two you have to keep in mind. Number three is iotomitral portion, which is called as a septal leaflet. That area is almost flat, or it may be even concave, turning other way, because the commissures are going to be coming like that. So people have to keep those things in mind in a normal person when you're looking at it. Then, for easy purpose, we are divided into anterior leaflet and posterior leaflet. But structurally speaking, it is not that easy. But for our practical purposes, you can see this is the anterior leaflet, this is the posterior leaflet. Thanks to Dr. Carpentier, not me. Certainly it's not me, somebody else. But anyway, thanks to Dr. Carpentier, when he started doing valve repair, he wanted to make the people. This is it. I'm sorry, it was me. Actually, this is it. It's quite sensitive. I think when the mitral valve repair. I'll use. That's fine. I think there's not many people taken here. I think. No, I'm not touching it. I never touch it. So you can look at the. I think for simplicity purpose, I don't touch it, man. I'm not touching it. I'll just leave it right here. How's that? Is it good enough? How about now? I think when, for the purpose of divided into anterior leaflet, where he wanted to see closer to the anterolateral commissure and closer to the posterior medial commissure, the leaflet that are there and opposing posterior leaflet, he classified them as A1 and P1 towards the anterolateral, and A3 and P3 closer to the posterior medial commissure. In between, it was like a large A2, and whatever that was there opposing is P2. So when you're imaging, you are supposed to look at A2, P2 area, that's the easiest one, and that is the 2 area, that's the easiest one, and that is what according to Srinivas Rao, it's going to be this green zone for you guys. If you want to do any pathology related to this area, it's easily amenable, easily doable, and if it involves anything closer to the commissure, it will be a little bit more difficult, but not always. sorry. So, if you look at the leaflet, when you open it up, the leaflet, the anterior leaflet, the posterior leaflet, they're not really separated. At the commissural area, there's a small leaflet which is seen. There are commissural scallops they see. Sometimes this area, the commissural area, the scallops may not be as well formed. Sometimes they can be very well formed also. And look at the caudal structures. The primary cardiac coming to the leaflet tips, the secondary cardiac attached to the body and the tip or the coaptation zone where it joins. And in the case of posterior leaflet, it also has cardiac going to the left ventricular myocardium. So these are complex structures. And if you look at them, they're not going to be like the same in every patient. It's like your palm of your finger. The fingerprint is going to be different. So some of them, they have a bunch of several cords, tertiary cords here. Some of them have a large 1 or 2 cords. So it's going to be quite variable. So when you are looking at a patient with a mitral regurgitation, you have to look at it with the idea, where is the primary problem? Does it involve the portion, which segment? Does it involve A1, A2 or A3, or P1 or P2, P3? Once you identify the segment that is involved, then you need to look at the edge of the leaflet. Is the edge of the leaflet normal or is it curled? And how are the chordates are placed there? Because that's what is not like a surgeon. Surgeon is very easy. All he has to do is cut, and he's going to, either if the tissue is large, he's going to cut it out and cinch it. If the tissue is small, he's going to put an extra cord depending upon what it is. And he's also going to modify the annulus so that the coaptation will be fine. But for you, you don't have that luxury. All you have is 2 flimsy arms. Some of them are larger, some of them are thinner, and they're not going to hold on to tightly. So you need to look at how much the tissues is going to be and how long it's going to be, and the bulk of the disease, what is happening. So those things you have to look at it in a multiple different views. And if you need, you also need to use transesophageal echocardiography. Here is a patient. You see that this is LV, LA, RV, RA, mitral valve. So it's a A2, P2. It's nicely seen, P2 leaflet, long enough, and there's a ruptured cord, and it's a prolapse. But even here, when you look at it, the part of the P2, which is 2/3 of the coaptation site, is prolapsing and flail, whereas the base of the part, a little bit of a base, and that portion that is adjoining the annulus, that is thick. So it is a diseased valve going on for a long time. And if you look at the MR is also coming from the coaptation site. So this is the site of the pathology. And you look at this is not the same patient, of course. So this is similar to this. You see the posterior leaflet prolapse. But look at the disease of the leaflet. So what we don't understand is that the chronicity of the disease causes adverse remodeling of the leaflet. Leaflet can lengthen, and surgeons can see it more often. When you send them, the tissue is going to be quite bulky, and also it occupies a larger area, so they can resect it. So this is adverse remodeling. You need to look at that. But if you look at here, 3D, this is a surface 3D. Look at nicely. It is able to demonstrate the panoramic view, all the leaflet, all the segments at the same time. You can see the ruptured cord coming here and there. And this is a solid, isolated P2, which is diseased, but larger surface area. And here, looking at it, the leaflet tip is fine. There's no calcium. And the coaptation length and width, all of them you're going to pay. So that clearly points out that here, if you could put easily 1 clip, which should be large enough to hold it, or 2 small clips, if you're going to put it, it'll be good. Because depending upon the length of the tissue, what you have, depending upon the thickness of it, you have to decide about your device also. So this is an easy one. This is what it will give you is, this will fit into the green zone. Anybody who is starting off, this is the case you should have, where you can easily try and do it. And TEE adds more to it, a little bit more, in that it also shows you the commissures better. It also shows you the slits or the folds in between. Sometimes the folds can mimic like a cleft, but one has to be careful enough to look at. So this is another patient. Look at here. Even though it is flailing, there's a little bit of ruptured cord, but most of the leaflet is funny. So this area is the degeneration, fibrocystic degeneration, and annulus is also a little bit of a fibrous calcium. And when you do a TEE, here you see this is the flail segment, and there's also this cleft-like thing. What you're seeing is a normal one. Once the disease is occurred, that area, as it prolapsing, it tears up, and we see the artificial or acquired clefts, which is resulting from the tear we see. And there is also what we didn't see here. This leaflet is prolapsing also, and here there's a small ruptured cord for that also. So TEE gives you more information. Even here, this also fits into the area where you can do it, because this one area which is large, when you put a clip and bring the two things together, this bulky tissue will become flat. So the other area will be covered. So that will be the easiest way. And this is another one where the pathology is related to the anterior leaflet. And if you look at it here, so it's an isolated large anterior segment flail, and posterior leaflet is essentially normal. Posterior leaflet length is fine. So in order to grab this, you need to have a sufficient amount of tissue. So here is also, even though it's anterior leaflet, is easy to do. So beginners probably should start with the posterior leaflet, like what the surgeons did in the earlier. Then you can do this also. This is also easy one, fits into the green zone. Whereas here, this another patient, easily looks like a P2 flail, but this is a mixed degenerative valve, fibrocystic degeneration. But in this view, when you look at it, it is bizarre, because the valve is thicker, but at the same time, the adjoining P2 and P3 area is not normal. When you put a color, the white jet that's going into multiple different views. So here, you have to be careful. Am I dealing with a disease? Say here, the 3D adds more. Look at here. So you also have a severe prolapse and flail of P2, and there's P3, which is going to be a commissural scallop here. This is part of the P3, or is in part of P2, which is separated out. So this is a complex pathology, what we see. But this also can be done by the experienced hands, because you need to put one clip here, as long as it involves the center area where you're seeing sufficient amount of tissue is there, sufficient amount of leaflet on the other side to grasp, you can do that. So here, it requires 2 clips and give a good tissue bridge. But look at the orifice area, it has become a little smaller. So one of the essential things what you also have to keep in mind is the essential mean gradient initially when you get it, and also the deceleration slope. Mean gradient may be 2, but the deceleration may be around 300. Then you have to be in the back of your mind, when you close it, you're going to develop mitral stenosis. So one has to keep in the back of your mind all those things, and majority of those cases are going to be with a small annulus. And here, this fits into a red zone. You really can't do it. This is like a Barlow's valve. I'm not quite sure how many scallops are there. So this is the anterior leaflet, this is the posterior leaflet, this is the anterior commissural scallop, the posterior commissural scallop, and the P2 itself has got its own 2 leaflets. So this patient, if you're going to, even most of the surgeons, I don't think that they can do it. When they try to do the repair is not going to be very good in this kind. I think ideal thing will be in a valve replacement. So, but people have attempted to do repair, and they have done repairs, which is not satisfactory result. And here is another one. When you're doing a transthoracic echo, you see the mitral valve, which is quite redundant, anterior leaflet. So look at what I said about the chordae. Look at all the primary chordae are quite a bunch of chordae and secondary joining together on both leaflets. And when you do a short axis, it looks bizarre. You see P3, you see P1, you see anterior leaflet, posterior leaflet P2, you're not able to bring it up. It should raise a question for you whether it has got a cleft. And here, when you do a typical 4-chamber view, that A2 portion is quite large and P2 is a little small. And here, the 2-chamber view, it looks like P3 is prolapsing, but you don't see the other one. But when you put the color, there's two large jets, one going across, the other one is coming across. This is a complex morphology. And when you look at it here, 3D nicely adds ventricular aspect. When you look at it, there's a large cleft of the posterior mitral leaflet. So here, it looks like almost like a tri-leaflet. If there was a papillary muscle and cardia going there, I would have called it a tri-leaflet. So this is a large cleft, and these tissues are redundant and basically degenerative. If you want to put a clip here, you can do it in a patient who is highly symptomatic and high surgical risk where you can't do it, and a very, very experienced hand, they can get it done. But not by a novice, but surgeon, if the patient is the ideal candidate for surgery, I think probably surgeon can do this. They can close it and put a ring and reduce the size. I think there's so many things they can do. I mean, the images can recognize, there's so many options are there with the current modern imaging modality where you can sort it out. The same thing, which I couldn't see very well with the other one, with the new technique, you can see that the cleft very nicely involving the posterior leaflet. Now, most of the patients in India, they come, they don't have a history and they might have had some surgery in the past. Now they're presenting at the age of 70 with the shortness of breath and with heart failure. Here is the classic severe MR, anterior leaflet is short and thickened, posterior leaflet is fine. If you look at short axis, it's a cleft. So you need to think that this patient must have had congenital surgery like ASD or something like that closed, like this, ostium primum ASD with the cleft mitral valve. But in this patient, we did the surgical repair. This is a before and this is after. You can see nicely. Surgeon can easily, we can't do that. We can't maintain the similar geometry with the clip. Well, one of the other area where you have to also pay attention is, this is the patient who are 83 years old, shortness of breath, significant MR. You can see here, mitral annulus is calcified, mitral valve is thickened, anterior leaflet is also thickened, long-standing hypertension. And here, if you see it, posterior leaflet is thickened, anterior leaflet is also thickened. It opens, but this doesn't open that well. And MR is severe. And here, when you see it, the opening posterior leaflet is totally ankylosed, doesn't move. Anterior leaflet moves, severe MR. So in this patient, the gradient is 2, but look at the deceleration time. Then when they try to attempt, for her sake, so here's the TEE, and see the MR here, MR. And this is annular calcium. Here the valve area appeared to be pretty good. It's about, it came up to, many numbers came, 3.9 to 4.5. So they attempted to close it. The annulus is like a rigid ring completely all around. So that is not compliable, not giving in. So once they put the clip to see, her gradient went up to 12. Then they have to take away the clip. So look at the pressure half time. So I think that is for the degenerative mitral valve disease. In functional MR, same way, A2, P2, the most important thing what you have to look at is the length of the P2, that your coaptation side to coaptation height, will you be able to pull it back? And how is the annulus? Sometimes the annulus is also dilated, then you can't pull them back. So you got to keep that in mind. And here is the TE again, clearly shows anterior commissure, posterior commissure, this is the area. And this tissue is large enough and this length is large enough, so you will be able to pull it and put a clip. This is the straightforward, easy to do.
Dr. Chandra, can you conclude, as we have to go for a live case?
I'm done. So this is another functional MR. I mean, it looks like a functional MR initially, but on the other hand, it's not. It's a flail tissue and also functional combination pathology. In this kind of pathology, you really can't use. This is also not a zone that you can use it. But anyway, I think to close off, when you look at the valve, you have to look at, one, what segment is involved. Number two, whether the calcification is present, how extent it is, does it involve the grasping zone. Third, mitral valve annulus, as well as mitral valve area and mean gradient is important. And flail gap and all are not necessary nowadays because the many clips of different sizes are there and the experience has improved. People can grasp anything they want now. Thank you.
Thank you, Dr. Chandrasekhar. We are running a bit short of time, so I'll invite Dr. Ramesh to take the next talk. I have just one question, Dr. Chandrasekhar. The second case that you showed, there were a lot of indentations. We are now with the use of 3D TE, we are seeing a lot of indentations in mitral valves, which are often contributing to the regurgitation. So do you think this will affect your mitral clip in patients who have a lot of indentations?
I think the indentation, what we see, if it is adjacent to a disease segment and the disease segment is flail and prolapsing, I would take a real look whether that is artificially torn, because it's like a shredded one, keep on going. We have seen artificial clefts. It's not like a cleft. Cleft means it has to go all the way to the annulus. It's not. Part of it is torn. So that could be the one what you're seeing. Sometimes the tissue thickening that is adjoining that area can also cause attenuation. So you're seeing that. The key is to put the color. If the color is starting out from there, then you know for sure that it's torn and it's a cleft. If the color is not coming from there, especially on the ventricular side, you need to look at the flow convergence. If it is not coming from there, then it's a dropout. It may not be there. But the leaflets do have folds and pleats, so that is normal. That's the only way it can expand. That's the only way it can close. Without the pleats, it cannot open fully. So that's the way it's going to be.
Thank you. Thank you so much. Please join us, Dr. Ramesh.
Thank you very much, ladies and gentlemen. So my talk is on mitral valve-in-valve, ABCs of screening and procedural steps. I have no disclosures. So as we heard from Dr. Chandrasekhar that I think all these valvular heart disease will increase with aging population and high risk for repeat cardiac surgery for degenerative mitral bioprocesses and failed annuloplasty rings can actually be increasing mortality and morbidity. So the transcatheter treatment has become standard for aortic stenosis, and that actually has extended into mitral valve replacement, whether it's valve-in-valve or in the future, Dr. Juan Granada will be talking about native mitral valve replacement. This has become a less invasive alternative. So as we see that first, actually we should recommend surgery, as Dr. Chandrasekhar mentioned about all these patients, but bioprosthetic mitral valve structural deterioration is about 30% at 10 years, and so this is a surgical literature showing that explant due to structural valve degeneration is increasing with age. What is it due to? Whether it is wear and tear, calcification, pannus, and endocarditis or thrombus on these valve leaflets as well. So there are several bioprosthetic surgical valves. I'll skip these two slides, but recognizing them on fluoroscopy is very important as you know how to identify these valves and how to treat them. So coming to accessing during mitral valve-in-valve, initially I think jugular vein was attempted, and then actually we started with transapical back in 2011, and now it's all mostly done at transeptal, and some people have done even direct left atrial approach as well. So transvenous transeptal technique has become a common standard now in most patients, and we'll go over that in the future. How you crimp the valve is very important, because transapical and transeptal, you need to make sure that the skirt is on the atrial side, and so I think that's very important to make sure that you're crimping on the right side. So this is in 2011, 59-year-old woman with the shortness of breath, repeated admissions for similar complaints, mitral valve replacement in 1982 for rheumatic heart disease with the bioprosthetic valve, and redo in 1995 for endocarditis with the 27 Carpentier-Edwards mitral valve by actually a very profound robotic surgeon, Randy Chitwood, at our institution at East Carolina University at that time. So this patient had actually, looking at this image, it is really severe mitral stenosis and mitral regurgitation. And the mitral regurgitation is due to a perforated leaflet, as you can see here. So there's a pinhole that is causing that severe MR. So this patient, obviously, because we are not able to get her off the table and off-label in hospital, Sapien XT was implanted with a transapical approach, and this is the final result after that. And a patient who had a cardiac output of 1 liter went to 5.2 liters, and from class 4 to class 1, and she could be discharged actually from the hospital. So, but this was in maybe I think 2019 as a live case in Chennai first CHIP CTO meeting we did actually, so this was transeptal, and as you can see, it, along with the mitral valve-in-valve, we also closed the paravalvular leak at the same time using the edgeless sheath, and this was done within a short period of time. So coming to screening, what is the most important is actually echocardiogram, whether a transcatheter, a transthoracic or the TEE is mandated in most of these patients to evaluate, and a 3D TEE will help us to identify what is the reason, as we talked about, whether it is vegetations, and I think even though some people have attempted to do an endocarditis, I would strongly recommend not to do a valve-in-valve in patients with endocarditis, because that is going to get again infected because the nidus is in the valve, and we have to remove that valve. Hemodynamic evaluations by both echo, here mean gradient is 9 and 11 millimeters, and by cath actually mean gradient is around 15 millimeters mercury. So this actually is very important to correlate both the hemodynamics in the screening process as well between echo and cardiac catheterization. Right heart catheterization is indicated, and looking at the right ventricular function is also very important in these patients, because even though we think that mitral valve is a problem, these patients might actually be admitted to our institution a day or 2 days early to tune them up with diuretics or low-dose dobutamine to improve the right ventricular function. And if PA systolic pressure is more than 70 millimeters on right heart cath, that's actually a poor predictor for outcomes in these patients. So that has been shown. And if they're are oxygen dependent, those patients are also don't do so well with the mitral valve-in-valve procedures. Cardiac CT is mandated. I mean, recently, actually, one of my colleagues posted a valve-in-valve without a cardiac CT, so we nixed it as in our multidisciplinary conference. We said, no, you need to get a cardiac CT first, and the cardiac CT is actually very important because it actually shows how these patients are going to be tolerating the mitral valve-in-valve procedures, because neo-LVOT, with the new virtual valve that you can see how much actually is the LVOT reduced to, will impact on their outcomes as well. So we'll go over that in a couple minutes later. The sizing with the valve-in-valve has become very simple from thanks to Vinny Bapat, but again in the mitral trial, based on sizing, only 57% were in agreement with the app, and the 43% actually either smaller or a larger size. And so I think it is better to do a CT to actually exactly know and understand what is the size of the annulus and what is the size of the valve that you want to place, and what actually happens if you place a virtual valve to the neo-LVOT, and anything less than 250 square centimeters millimeters is not recommended to do, in my opinion, a valve-in-valve procedure. So that said, let's look at, in the next 2 minutes, the procedural steps case setup. At our center, we use anesthesia, echocardiographer, and interventionalist or cardiac surgeon. Sometimes the echocardiographer is a cardiac anesthesiologist, and so it's mostly done under general anesthesia. We are still trying to do with a 3D ICE. We don't have much of experience except 1 or 2 patients, which I'll show it to you. But in general, TEE is what we recommend. And a single vascular access, radial artery is obtained by the anesthesiologist. We just place one access to the femoral vein and a single proglide, and if that fails, actually a mattress suture can be placed later. So the first step is actually transeptal puncture, appropriate location. For the valve-in-valve or mitral balloon mitral valvoplasty, similar to that, you should be mid to mid in position and not really posterior as it would be for transcatheter edge-to-edge repair. This is from my previous partner, Alcoli. He has actually nicely demonstrated in a JACC intervention article that where should be the puncture in the fossa. So mitra clip or a tear procedure will be more posterior, whereas the transcatheter mitral valve replacement is mostly like a mid to mid in the septum. So this is how you can do in case if you want to spend a little bit more money, using a VersaCross wire, and actually it is a radio frequency wire that can puncture the septum very easily. I actually still use SL1 and BRK needle as actually because it is a little bit cheaper. And so once you cross, you can use the same pigtail catheter that is actually with the VersaCross wire, and then you can cross it and make sure that the height is good, and then advance the dilator and the sheath. So the height of the puncture should be between 3.5 to 4 centimeters, and because if it's too high, then actually you're going to be struggling a little bit more. So then the next step is septal dilation. You can use anywhere from, I use large balloons, so usually about 12 or 14. Some people use 10 millimeters as in this case, but actually typically 10 to 12 millimeters septal dilation is required. And the same balloon is passed into the mitral valve to do just a flossing in the mitral valve position to see how the device will behave when you push this device, whether the pigtail will come out. So crossing, actually, before I go there, crossing into the mitral annulus, I usually use the edgeless catheter and a mitral multi-purpose catheter through the edgeless sheath and place a small glide wire through that, and then exchange the multi-purpose with the Safari or extra stiff amplats or Lundquist wire, whichever wire you want to use. The more stiffer it is, the more chances that it will be kicked out. So if you cannot actually get into it, it's difficult, then the anterior rotation of the catheter will help you to get towards the mitral valve. And then you can actually use an omni-flush catheter and then slowly replace it. Sometimes you might have to actually put a transapical puncture and snare that wire to create a rail. So that's another important part that we might have to do in rare occasions. So here is a patient with the mitral valve and degenerated mitral leaflet, severe MR. And this is done under ICE catheter, as you can see with the 3D ICE transseptal crossing. We just started using this in the Philips system. And once you cross, ICE catheter is placed in the left atrium so we can see very well. And we do this now actually for standard of care for all of our left atrial appendage closures amongst 3 out of 4 people. So then you cross the valve, as we said, and inflate it. And you can actually, with the ICE, you can see that it actually is working quite well. The mean gradients have come down in this patient from 11 to 5. And one word about neo-LVOT, this is what we are talking about. These patients have a higher chance of LVOT obstruction, and probably preemptive alcohol septal ablation will help in such patients. So this is how the septal thickness has been reduced with alcohol septal ablation, and we have done in some of the patients as well. So in conclusion, the transcatheter mitral valve-in-valve interventions are a great option for high-risk symptomatic mitral stenosis or mitral regurgitation. LVOT obstruction can be predicted by CT, which is mandated, and alcohol septal ablation or lampoon may be required in some patients to prevent LVOT obstruction. With that, I'll stop here. I'll be happy to take any questions.
Thank you, Dr. Ramesh. I now request Dr. Granada to deliver his talk. If we have time at the end of the session, we'll take a few questions.
Excellent talk, Ramesh. Thank you, Mr. Chairman, and thank you, everybody, for coming here on a Sunday morning. So my assignment for the next talk is to talk about innovation in the transcatheter mitral valve field. Going to discuss the current state and give a few words about future trends in this particular field. The first thing that actually I want to talk about is about the population that we're trying to target with innovative transcatheter mitral valve technologies. And I like this slide to highlight the current state of the people that actually we get during the screening process. This paper included almost 1,100 patients with 3+, 4+ MR and heart failure between 2000 and 2008. As you can imagine, most of the patients were FMR, 74%. And the patients on the DMR group, which were the minority, 226, as usually happens, actually underwent surgery, 60% medical therapy. By contrary, the patients with FMR, which actually were the majority, only a minority went for surgery, 36%, and 64% went to medical therapy. And the unoperated patients typically had lower ejection fractions and higher STS scores. So this is actually typical and reflects, I would actually say, most of the practice worldwide in patients with DMR versus FMR. The reality is the prognosis of unoperated patients is not very good. And you actually see that at 5 years, these patients have approximately 50% mortality, and 90% of the patients end up hospitalized for heart failure episodes. So the reality is, in the real world, MR patients today display complex anatomies, have limited therapeutic options, and are high risk for surgery. As you can actually see, a lot of these patients have MAC, multiple clefts, multiple MR jets, and bioprosthetic valve failures. And technically, these patients, the great majority, are non-surgical and non-TEER candidates. So we're not really talking about here about truly the patient that could benefit from surgery, which is without any doubt the standard of care. But the great majority of patients that actually are out there with degenerative and functional MR that actually are not good surgical candidates or TEER candidates is still, significant. One of the challenges about innovation in the transcatheter mitral valve field is that the application of the technology is highly driven by the anatomical needs. On one side, you have technologies like mitral TEER that require very specific anatomical criteria to be able to be successful. On the other side, you actually have replacement technologies that claim to be more agnostic in terms of the anatomy, but still also have significant anatomical exclusions, and other actually technologies in between that require specific anatomical defects to be able to be applied, such as transcatheter chordal replacement, leaflet extension, and annular reduction being actually kind of in between. So future technology adoption will greatly depend on simplicity, ease of use, for example, the complex use of imaging, and obviously long-term technical performance. Let's talk a little bit about TEER, limitations, and future perspectives. This is without any doubt a technology that is highly standardizable, but not necessarily reproducible. There's no question TEER is very simple to perform, achieving very high implantation rates that get close to 100%. But this is highly dependent on the experience of the operators. And you see residual moderate to severe MR after procedure varies, according to volume. And is actually reported to be 39% in low volume centers to, less than 15% in high volume centers. Performance actually in complex anatomies is also a balancing act. In low volume centers, this technology has an excellent safety profile. In high volume centers, it's got an excellent efficacy profile, but it all depends on how aggressive the centers are and how many clips they are actually willing to put. And there is actually a complex balance because the operator sometimes, has to decide whether accepting actually more residual MR or actually putting the patient on mitral stenosis by adding more clips. So the future of TEER and other catheter-based repair technologies, in my opinion, depend in developing more refined imaging-based prediction models of technical success, device evolution to allow the use in broader anatomical variations, and actually allow reversibility of the procedure, such as clip removal, to be able to do something else in these particular patients. Moving into actually another technology that actually aims to repair specific pathological conditions. This is an example of that, half-moon leaflet augmentation device that already achieved 15 patients. This is just a biological proof of concept. And you see that the patient can be deployed and implanted in a safe and efficacious way with a significant reduction of MR post-operatively. And this is the type of technologies that will continue to move forward, trying to address specific pathologies such as, for example, posterior leaflet prolapse or posterior leaflet problems in this case. PMVR started entering the field, promising something that actually we didn't have before with other technologies, such as ease of implantation, agnostic to the etiology of MR, reliable elimination of MR, and less recurrence of MR. But as we move forward, actually, we started to learn about the complexities of this particular technology. One of the first challenges was to actually make the device small. And the first generation technologies were around 36 to 40 French in what we call single-step technologies. And to be able to reduce the size, technologies actually became multi-step, and that was the reason to be able to essentially go this pathway and decrease the French very quickly from 40 to actually less than 30 French in actually matter of years. Right now we have multiple technologies with multiple anchoring concepts that I'm not going to expand on, but you can actually see the great variety of technologies with different technological approaches and actually concepts as well. But once we started doing these trials, one of the things that started to realize was the highest screen failures rates in TMVR trials related to the anatomical variability in the real-world patients. So the concept was very beautiful. We actually had multiple options, thinking about the shape of the annulus, the size of the ventricle, and so forth. But the reality of the real world was we actually encountered significant anatomical abnormalities and variabilities that we were not really used to. So who are these patients rejected from these trials? And we have done a lot of work on that, try to understand why these patients are actually so different than the ones that actually we conceived before for these clinical trials. And actually it turns out there are two actually phenogroups. One group is actually what I call more clinical, and is actually the minority. This is where the first generation devices actually fit best, and the most of the exclusions in these patients are clinical: frailty, life expectancy, large annular area, and afterload mismatch. The second group, which is the most common, is related to primary MR cases, and this is where the first generation devices have significant limitations, mainly anatomical: LVOT obstruction, severe MAC, a small annular area, and septal height. So over the last decade, we actually went over the premise that we were going to go primarily after FMR. And actually everybody was thinking about that these patients are going to have large ventricle, large annular sizes, non-calcific annuli, and low ejection fractions. Then we ended up with big valves, with big profiles, with big difficulty to actually go transeptal, low radial force, and diverse methods of anchoring. The resulting challenges right now is LVOT obstruction, percutaneous femoral access, MAC treatment, and myocardial performance in low EF. So one of the issues of the field to move forward so slowly is not the technological aspects of it, but is the mismatch between the clinical need, anatomical need, and devices we have today. But technologies are adapting, and you actually see significant improvement in valve design and delivery system design that I am sure are going to allow more treatment and more inclusion in these patients in the future as all these technological iterations are included. This is a brief summary of all the programs doing right now EFS studies in the US, a summary of the EFS data of the first 30 patients, that all the data is being populated. But you actually start to see interesting data as the Intrepid data at 1 year mortality of 6.7%, and conversion to surgery being very low across the board. All the studies, actually all the programs opted to do non-randomized controlled trials that are going to start actually very soon, and some already ongoing, having single-arm studies including around 300 to 400 patients in the primary arms and around 100 patients in the MAC studies. So just to summarize, how can transcatheter mitral valve intervention address the clinical need? The first thing, and I really think this is clear, we need to accept that all these systems, they need to be transeptal or minimally invasive. We need to define the target population and predictor of outcomes to understand which is the patient that benefits from each specific technology. We need to have adaptable device designs to the human pathology and the variability that it presents. Ancillary tools to improve the success rate of transcatheter mitral valve devices. And very important later on is strategies to manage the thrombogenic potential of these devices, especially lethal thrombosis and degeneration. So thank you very much for the invitation.
So we'll have time for just 2 or 3 questions. Dr. Chandrasekhar.
Hi. I think it's a great presentation. We should come here, actually.
Yeah, you're the chairperson for the next live case, so please stay on. Yeah.
It's a fantastic presentation showing exactly where we come. The key important thing I feel here is the lack of organized imaging criteria in most of these patients. Even functional MR, structural MR, even the devices we don't have, even in US with so many years of well-trained cardiologists, echocardiologists. Still, that's one of the, I would say, Achilles heel of the problem. once that is well defined and people have been exposed to doing that, like a core labs, if you have core labs which consistently can educate and train them, then this differences, anatomic differences, what we see may not be as much. What are your thoughts?
Look, I think the evolution of imaging is equally important. And I'm going to talk on my next talk a little bit about it, because there is a lag between the interventional development and the imaging development. I was looking at some statistics, and in the United States, of all the structural sites, only 18% are fully equipped to do structural imaging in the way that actually should be done. So one of the things is this is like training pilots without really having sophisticated GPSs or actually navigators that actually help you to go where you want to go. So this is absolutely correct.
I totally agree with you. See, at Mayo in 2003, Chetri Hall and myself, we decided that everybody can't be doing. So if we started an interventional imaging program, those are the only people who will go there, who will help, who will do. And now that has become initially from 4. Now we have about 30 people who can do the interventional imaging. I think that is the crux of the problem, because the outcomes depends on that. But still, pre-selection, there is quite a bit of variability, even in US, with all the echocardiographic training and things like that are being there.
Any concerns in patients who are having, who are planned for TMVR, and patients with the flail, leaflet and caudal rupture?
In terms of no. So one thing that is nice about TMVR is that the baseline, underlying anatomical requirements are actually way less than others, because pretty much essentially you put the device in and you get what you get. What people don't realize is that the different mechanisms of anchoring also limits the applicability according to the pathology. So for example, if you're using a device like InnoValve that actually requires integrity of the cords or the subvalvular apparatus, if you have ruptured cords, maybe that's not a good case for that particular valve. So this is where the classification and a good screening allows you to actually define. One of the things that people don't realize about the mitral field is that, unlike the aortic field, this concept of a universal device tool that you're going to use for all pathologies is not going to happen. It's never happened in the surgical field. And the market will be segmented according to the need. Some replacement devices, some chordal replacement for other pathologies, some annular-related things for others, as the surgeons actually do.
Thank you.
So Dr. Raghu, one last question.
Last question. Yeah. About 5 years ago, when TMVR had started, dense mitral annular calcium was regarded as a relative contraindication. Has that concept changed? Are you doing in dense MAC?
It is now the #1 indication.
#1 indication.
Is the hottest
So
actually area of
I'm hoping in the next 5 years, TER will be completely replaced by TMVR. Is that feasible?
No, listen, people.
Sai Satish doesn't
what?
agree.
5 years of what?
Dr. Granada, he was saying that in 5 years, TER might be completely replaced by valve replacement. But
No.
the reason why I looked like I didn't agree vehemently is because a simple question, I think finally the way these technologies will evolve is that each of them will settle for specific anatomies. Would you rather have a big metal cage or a tiny clip? I think the technology will stay. I don't know where it's going. None of them are perfect. None of them are perfect answers. Dr. Granada?
No, you're correct. I mean, I think every single technology is actually finding where it fits the best. As it happens in surgery. I mean, if you actually see in surgery also, they have a toolbox of technologies they apply to certain populations with the benefits and disadvantages of some of the devices. Some will be the need of anticoagulation. Some actually will be, related to the technical failures of the device itself. But I do believe in replacement. But this is not really going to be like TAVR, in which pretty much one device applies to every single anatomy.
I think we've started the live
Yeah,
session.
if you really want to
thank you
run-
very much. I thank all the speakers for a wonderful session.
Thank you. So it's a great pleasure to invite our next session, which is a live case mitral clip by Dr. Saibal Kar. I see you, Saibal. Just let me invite all the chairpersons. Please stay on, Dr. Van Granada, Dr. Sai Satish, and Dr. Chandra. I invite the chairperson, Dr. Krishna Reddy, Dr. Vivekananda Gupta, and the panelist, Dr. B.K. Sastry, Dr. Nirmal Kumar, Dr. Purohit, Dr. Saumik Ghosh, Dr. Akil Sharma, Dr. M.S. Aditya, and Dr. Shivkumar Reddy.
Show some baseline images, the ones that you could. Let's start with that.
So while they come
image.
on board, Saibal, good evening, Saibal.
Yeah, I can hear you.
Yeah.
Good evening. Yeah, it's almost night now. Yeah. First of all, I'd like to thank all of you guys to allow us to participate in the conference. I was hearing some of the conversations and the lectures all this time. And before I do that, I want to first introduce the team. Asma on my right side, and it's very important for Asma to be here today because she is from Hyderabad. She actually grew up there, and then she's been my physician assistant for almost 15, 20 years and is involved in all the clinical trials. Asma, it's good that you're here. Mike Limon. Mike Limon is our chief tech. He's actually Donald Trump's right-hand person. He's his wingman. And then you have Gabe Areta just behind. Layli, standing there. Layli's our cardiology fellow. She's outstanding, actually. Ali and Erin are from Abbott. And on my left side is Saro. He's actually a first-year fellow. He's going to do a mitral clip. And then you have Dusty Lloyd, who's actually going to do the case with me. Dusty Lloyd is a cardiac anesthesiologist, as well as an outstanding imager. And behind is actually my med student. I also want to acknowledge some people in the room, Tom, Sophia, and also Craig and Pedro from Medinbox, who's transmitting through Medinbox. So with that, can I just show the case? Start.
Morning,
next slide.
Saibal. Lovely to see you.
Yeah, good morning.
Please go ahead.
Sai, I saw you there. I saw you, and I also heard your comment about the 5 years from now. 5 years from now, we'll be still teaching people how to do mitral clips. And you'll be teaching people. Okay, I heard the comment. So, I heard that comment. 81-year-old lady. Sorry, I'll ask Asma to present.
Just watch out, okay?
Eberhard is in the
Okay.
audience.
Namaste, everyone. Adab. It's nice to be here today presenting this case for you. This is an 81-year-old female who has had increasing shortness of breath over the last 1 year. And she recently was hospitalized with CHF, and she's on maximal tolerated GDMT. She has a past medical history of a prior stroke, but she has no neurologic deficits from that. She's got a prior LAD stent, which was put in March 2012. She's insulin-dependent diabetes. She has a CRT device, which was implanted 2020, and she's on oral anticoagulation for atrial fibrillation. No history of smoking. She's a widow. She lives in a senior living facility, and she uses a walker for ambulation. And you can see her medications there. She's on good GDMT, as I said, sacubitril, valsartan. She's on metoprolol, Ozempic, rivaroxaban, and atorvastatin, and torsemide for diuretic therapy. And now we'll go over to echo and see some echo images.
Go to the next slide. So this is just the baseline which we did today. There was a transthoracic. You can see there's actually bilateral enlargement, moderate LV dysfunction, and severe functional MR. And actually, what I couldn't show is Layli, our cardiology fellow, is outstanding. She actually did a global longitudinal strain. And what she showed, I wish you could show the pictures of a classical base being more hypokinetic and the apex being slightly spared, which is actually a characteristic degree of amyloid. So we potentially think that she may be in a case of amyloid. So you can see the biatrial enlargement, the low voltages, and severe functional MR. So we plan to do a MitraClip for this treatment, but we do agree that based on the findings that you said, Layli, we may actually also work her up for amyloid. And we've seen
Next
that.
slide.
I think that's the last slide.
There's one.
And that's the T. You can see it's a wide jet. And the valve area is not very large. It's only 3.9 to 4 square centimeters. So, Dusty, do you want to show some pictures?
Yeah, these are some pictures I got earlier, about 15 minutes ago.
Yeah, can you transfer to Echo now? Echo and Fluoro, yes. Can you go to Echo, please? Pedro? Yes, good. Make it a two-screen thing, like Fluoro and Echo. Yes. There you can see, make the Echo larger. Yes, that's great. So you can see that it's a very wide jet, severe MR, and you can see one ground was on there. You can see how close the papillary muscles are to the valve. You agree with it, Dusty?
Yes,
And
very
that
short distance.
a very short distance. And do you want to show the
The
three?
left upper pulmonary vein, reversal of systolic flow, and the right upper pulmonary vein.
Okay, and you want to show a short axis, a 3D end face. And that's the 3D end face. And the calculated valve area, Dusty, what did you get?
I think we got 3.8.
Yeah, we got 3.8 to 4.
Yeah.
So what do you think we should do?
Saibal, there are so many questions here that I think will be pivotal to the discussion of this case. You have a borderline valve area. You have
Yes.
what looks like a mixture of both degenerative and functional, because that AML is not moving as well as it should, in my opinion. We would love to hear actually what you think is the best way forward for this case. From the way I look at it, you have one shot, you have a wide jet, you probably have only space for one clip. Even then, you risk a significant gradient. Saibal, the floor is yours.
Yes. So, you know, like there's a reason why I showed you the papillary muscles.
Yes.
And you can see the papillary muscles are very close in the biconventional view,
Correct.
very close to the leaflet. So there are very few technologies which will allow you to do a TMBR. So even if I wanted to do a TMBR, I don't think I can do it. So, so the only option I'm left with is trying to do a MitraClip. So anyway, since did any comments from anybody else?
Saibal, Ramesh here. So actually it just happened this last Monday, I saw a similar patient with atrial functional MR, and we thought similar on, as you did, your echocardiographer did, we did find that as amyloid. So once you diagnose with amyloid, do you actually give some time for the treatment, or actually proceed with what is the timeline for TEER versus actually treatment for the amyloid?
I think we haven't worked it up. We suggested based on what I just told you. I wish I could show you the global longitudinal strain with a classical, it's called a cherry on white appearance, but we will work her up. We will continue to work her up, and we will treat her, but I don't know whether this is going to go away. But MR is quite dynamic. It's very severe at some points. It gets mild at some times. I'm going to see what it happens. Like, let's do a clip and see what happens.
Yeah.
So we could always take it out.
Yeah, you're right. Because it's a wide jet, you probably want to do a XDW. That's what I would look at it.
I was thinking on XDW, but we are concerned the posterior leaflet is only measuring 9 millimeters. And so we are actually going to try an NTW.
Yeah.
And if we think that, if not, we go to an XDW.
But one thing we're going to have to start...
if not, we go to an XDW.
But one thing we're going to have to start, discussing and talking about in this type of cases is that, unlike, again, TAVR, in which we look at the anatomy and we say, maybe this is the valve we're going to use, mitral disease is a very complex, disease that actually goes beyond the anatomy, and you have to take into consideration longevity of the patient, myocardial baseline performance. I mean, like in a patient with a low ejection fraction with possibility of amyloid disease, I don't really think that actually replacement is a good idea at all. Number one,
Yes.
because the myocardium is not going to react very well to the implant, because the ejection fraction may deteriorate even faster, and you may actually have thrombogenicity issues to start with. If you put that with the high papillary muscles that actually only few technologies can really deploy well with a high papillary muscle, this is actually is the best option for transcatheter repair without any doubt.
So, Juan, I actually liked what you said. In fact, you agree that most of the summaries, if there was an amyloid case, they would actually exclude the patient, right?
No,
in most of the studies?
Absolutely.
Yeah. So even though we haven't proven it, but we are going to try an XT. Would most people try an XTW?
Yeah, just because the gap, I think, is larger in this patient, and I mean, you can try NTW, but I don't know whether you'll be able to get a good grasp. But that's what I was thinking. So that was my rationale.
We'll take one. We'll take one. We prepped the clip, and we actually are going down. Can you make fluoro and echo big only, so that they only see echo and fluoro? Can you see the LF pressure? You can see it's ranging between 18 to 22 prominent V wave. But I'm going to focus mainly on the clip and make echo large. Always make echo large, Pedro. Fluoro small. Yes. Okay, good. So what we're going to do is I'm going down on the valve. I've actually moved it slightly more down. And I'm trying to go in the middle. And he's trying to show me the middle. That's a very nice image. Dusty's an outstanding imager. He was actually trained by Burkhardt from Washington. I like that trajectory, right? I think the trajectory looks good.
Spot on.
I'm going to open the clip at this point. Let me just make it coaxial as much as I can. And then I'm just going to go. I see Dr. Chandrasekhar's on the panel.
Morning, Saibal. Morning.
Yeah, good morning. Do you agree with my assessment of potential amyloid?
Saibal, I think you should have become my echocardiographer, man.
Yeah, I wanted to. It's a better lifestyle, at least.
I'm not quite sure about that, though. I'm not
He's
quite
too
sure
hyper
anymore.
for that.
No. No, it's fine.
Okay, so let's do a 3D end phase. So we're going to do a 3D end phase and just see how we've oriented the clip. So we're quite off by a lot, so let's get it a little bit more. So clockwise is like this, hold it like that. And you see how the span of the clip is, that makes me encouraging that this size will be okay.
Yep.
You know what I'm saying?
Absolutely. The XTW would have been too large for this anatomy, I think.
Yeah, for this annulus, right? So I think for this annulus, this is reasonable. So I'm just going to transmit the torque. And I think this looks good. My plan is to put the clip right at this position. Do you agree with that, Dusty and Dr. Chandrasekhar?
Put the color there, Saibal. Put the color there.
Put color there.
Yep, looks
Yeah,
good.
I think so. Yeah, it's perfect. I agree with you. Yeah.
So I'm just seeing the grippers. Can you see the grippers? Just go to explain once. Okay, so let's put the color off for a second. And yeah, so I'm just going to see which gripper is what. So this is anterior. So the blue is posterior. The dot is anterior. Okay. So what's happened? So Ali's whispering and telling me, should we give a little bit of plus? I think it should be okay, right? I think we can try this. We can try a little bit of plus. It's okay. A little bit of plus is okay. I agree with you. And then bring it down a little bit. Okay. So I think we went a little bit medial. So I'm just going to take off a little bit of M. And let's put the color here. I'm actually going to move a little bit more lateral, somewhere here. Let me try. I think I'm going to go right in the middle and see what happens, right? We have LF pressures. We have everything. So let's see what happens somewhere in this spot. So I'm going to close the clip. And I'm actually going to go down in the ventricle. You can go into explain function. And then we go, right? Okay, and I'm just going to go just below. And you can see, as you know, you can see the papillary muscle is very close.
Yeah.
I mean, you see, it's such a high papillary muscle. Would have been a real challenge for any of the TMVR platforms. And so now I'm opening it on a V, and I'm actually going to come more closer to the clip. And let's look at 3D. And you can see it's slightly off, right?
Yeah.
So we should counterclockwise it clear. Dusty, you agree with that?
Yes, counterclock.
Yeah. So let's go down.
Yeah, looking better.
I like that. Now let's go to Bicom LBOT. And let's see where the color jet is. Because what color they're on?
You're right on.
I actually like this position.
Yeah.
Right, guys? Do you agree with that?
Yeah, looks perfect.
I think this is a reasonable position to
Yeah,
try.
looks good.
Okay, good. And that's where you can put the clippers down. So you get color off. And both the leaflets are on. Looks nice. And I'm going to drop both the grippers. And you see both the grips are bouncing. So then I always check 3D again before closing the clip. And you see the orientation looks, I think, almost perfect, right?
Yeah.
Should be oriented slightly counterclockwise.
That's the only thing I would say was counterclock.
Yeah, decrease the gain a little bit. Yeah, let's go a little bit counterclockwise. Decrease your gain. Go back to, I think it's okay though.
Looks
Yeah,
great,
looks pretty good
Saibal.
there, yeah.
Looks good.
Huh?
Looks great.
You like it?
Yeah, it looks
Okay,
good.
all right. So if, Sai says great, I'm going to take it. What does Ramesh say? Ramesh wanted an XTW into two. Okay, so let's go down and let's close it. Explain that.
I think the length of the leaflet clip arms look good on this one, and I take
Yeah,
it back that NTW is doing well. So let's close it and see. Maybe I don't know whether we need to be a little bit lateral. We see that already left atrial
Yes.
pressure went up, so XTW would have made it definitely worse.
So let's look at LA pressure as it goes down. I'm closing the clip. Asma, you want to close slowly? So closing slowly, very slowly. Close. Do you see how the LA pressure went down?
Yes.
Oh, sorry. Oh, sorry. Let me just open it up a little bit. Sorry. I go to 60 and then lock the, and then close it a little bit tight. And so the LA pressure came down dramatically, right?
Yeah,
Did you guys see that?
At least by 10 points, yeah.
Yep. So let's close it more and then let's have a look at the MR assessment. So at
Yes.
least LA pressure wise, it looks good. So you see, going more laterally would not have helped because the jet is actually more medial, correct?
Right.
Correct.
Okay. So I think that's a good position. Now let's look at gradients.
Moment of truth.
So the gradient is not too bad. You know, Ramesh, I also was thinking of XTW, but when I measured the leaflet length and the annulus diameter, I thought this would be. So it's 3, it's not too bad.
Baseline was 1.
1. And now let's do pulmonary veins.
Yeah, no, initially in one view it looked like that the gap is more, but in these images doesn't look that the coaptation gap is that bad.
So she was almost reversed or blunted, and actually it's staying like that almost, right?
Yeah.
Can you get a better signal? Okay.
Look at it right.
Yep. So it was reversed when we started the case. Sorry we didn't show it to you.
We showed it.
No, we did. We saw that systolic
saw
reversal
that?
was there, yes. Yeah.
Yeah.
Now it is
Okay.
systolic dominant and
No, it's not dominant. It's blunted.
It's blunted,
Blunted,
yes.
It's severely blunted. So the question is, should we leave this here and put another clip? Let's look at where the jets are from.
You want me to get it left upper again?
Yeah, you can do left upper.
Same, yeah. Blunted.
Yeah, it's blunted now.
All right.
Okay. And the LA pressure is 24, but it's because, and the blood pressure is 134 by 74. So that's nice. And then let's look at it, explain. So let's look at each of these jets. So the two options that we can do is 3D NFAStat. We can put a one clip, explain. So Ramesh, you agree that this is right in the middle, right?
Yeah, this is right in the middle. I mean, the question is, it looks still, on color flow, it still looks mild, MR, on either side. So if you want to do it, whether you want to move this clip first to medial and then put a second clip lateral, or do you just want to get one of the, leave this here and put another clip medial to it, is my question.
Okay, so let's do one thing. Let's look at the, explain those color jets.
See, that's what I put on my slide.
So the P's are big, it looks like medial, right? So explain the medial jet.
I mean,
Saibal,
Yes.
just a small comment. She's got a 3.9 valve area. You've got such a beautiful
Yes.
result. Gradient is 3. Do you want to even consider, I mean, for the benefit of the house, do you want to even consider
Yeah.
just leaving this here and leaving her with this and optimizing GDMT
No.
instead of the second clip?
I'm thinking of that. I was thinking about that.
Yes.
Laterally, let's see the lateral jet.
I feel terrible moving this clip.
Right. This
Yeah,
is
it's a
excellent.
good grasp.
so this is, we were talking, you know what, I mentioned in my talk, right, that this is the operator's paradox in mitral tear, in which, you know, if you stop here, you get a good result and you're safe and you accept a little bit of residual MR. If you actually go more aggressive, you need to put more clips, you end up actually with a higher gradients. And, you know, in a patient like this, especially with such a great anatomical and technical result, if you optimize therapy, you're going to be able to decrease that MR even more.
And,
So.
and you have a non-compliant LA. She's not going to
Exactly.
tolerate a higher gradient. She's
Exactly.
84. But just for the benefit of the house, you can see how, I mean, Saibal, of course, is a master. He makes everything look easy. But you can see how graceful this procedure is. There was absolutely no hurry. He took his time, which was about 5 seconds, went exactly coaxial, opened the clip up, looked at the orientation above, looked at it below, let the leaflets fall on it, and there's nothing chasing you. He checked all his data points, then he put the grippers down. He still didn't close the clip because these 84-year-old leaflets are like muslin cloth, and you know, you don't want to damage them unless you really have to. So he took his time, he looked at the orientation, and in case you're wondering why he was so dogmatic about having it perfectly coaxial to the plane of coaptation, because if it's not, if it's slightly twisted left or right, it distorts the valve and they don't do well on the long term. So it was just such beautiful images. Credit to your echocardiographer and such excellent maneuvering, Saibal. It was a pleasure to watch as usual. I'm going to give the floor back to you. I had to mention it for the house.
Thank you, Dusty. Thank you very much, Sai. Sai, I think we were oriented correctly, right? I don't think we had an orientation issue, right?
No, it was
I
perfect.
don't think there was.
Perfect and
Yeah.
central, and the one clip procedure is quite decrease in the MR jet, and another clip will increase the gradients. It will be a detrimental.
So there's two options that I have. I mean, I think I should leave it here. I agree with you. We've got a very good grasp, right? We should leave it. Dusty, you agree with that? But do you mind if I just deploy it and then try an NT beside it?
Yeah. So the panel actually thinks leave this alone and optimize guideline directed medical therapy. So either way, I think deploy it, and maybe you said the blood pressure went up, right, actually? After.
Blood pressure is 138 by 77.
So there's room for GDMT, that's what they were saying. So it's up to you,
Yes,
Saiba. You can
Saiba-
try it, but you can take it out as well, you know.
Saibal, we can do what you've always told me to do. Deploy the clip, look at the pressures, assess everything, and then take a call.
Yeah, we can do we can do MPR and measure the valve areas. So let's do that. Let's just deploy this clip, right? So I'm just going to deploy the clip. So do you want to open? Asma, do you want to do that? Or Mike, do you want to do it? Mike, try to open it. So Asma sped. It was thrilled to come. Okay, come here. Good. And then just to do it, close it. Let the positive side and neutral. I think this is neutral. So we're going to deploy it. Okay? So take this out. The clip looks quite closed as I can see. Okay, good. Turn it around. Oh, yeah. The best way to do it is actually not like that. Best is to take it just counterclockwise around.
You have 30 more minutes.
Now separate. Huh?
You have 30 more minutes. So you can, I don't know, I feel the MR might slightly increase. So you have 30 more minutes. If you want to take another NT, I mean,
yeah.
As far as I'm concerned, I'm okay with it.
I would try another NT. The floss, they're good. I'm going to try an NT anyway. If that's okay with you guys.
Yeah, that's why I said, please entertain us.
Okay. It looks quite close, the clip. I always have this superstition of closing the clip once again. And then now trying to open it again. To neutral. So the clip hasn't moved at all. So that's nice. And positive side neutral. And take this boy on it out. So we just, okay, good. And now try to open this out. 5 times. 5 times. Go. Yeah, counterclockwise. Keep rotating. Okay, keep coming more. Good. Now 8 times this one. Counterclockwise 8 times. Okay, good. Pull it out. Okay, good. Put this back. All right, the clip got deployed. Actually, the MR group less now.
Yep.
Now we'll understand a little better. Let me take the clip out. It'll take me a couple of minutes to just take it out. So let me do this. Let me do that. Is the clip in? Do you have enough clip inside? Like a guide inside? Can I look at the guide?
Yeah. I'll look.
Just show me the guide. Okay, there's enough guide. And then let's get that this thing, the suction. So we deployed the clip, and you know, this is as Sai mentioned, there are very few procedures which you can do so relaxed without any changes of blood pressure, with any arrhythmias, nothing, right? You know, you do a TAVR, you do a PCI, all of them have hemodynamic consequences when you're doing them. This one doesn't seem to have anything. That's a nice tissue bridge, right?
Very.
Looks great.
Looks very nice.
Okay, let's do color now. And can you show it from dual view?
The jet on the right side has disappeared.
So we were right in the middle. We took care of A2P2. The question is, should we try one? The valve area is not very big. Okay. I'm almost thinking of not doing anything. All right. Let's look at the 2D color, which is a little bit more exaggerated. What do you think, Dr. Chandrasekhar? Do you think I should try one?
I think it looks pretty good, and I think you can put another one and try and see whether
on the medial side.
Medial side, yeah. Adjoining the clip.
Can you get an NT?
Yeah.
Can you get an NT?
There, yeah.
All right, we're going to try an NT. Can you explain the medial jet?
There it is.
Yeah. I think we can. Let's try to put one very close, and hopefully the gradient doesn't go up.
Sure.
But you did see how the LA pressure went down when I. What are you doing?
Yeah, from what it was, actually, this is an excellent result. And, you know, I think
NT.
you can try it, but you can also leave it. I think probably if you're starting off, if you're Saibal, you can try it. If other people probably can just leave it. What?
So most other people would say just leave it alone, right?
Yeah, that's what
I got a mean gradient of 2 now.
I think
So he's getting a mean gradient of 2.
I think in a patient.
Mean gradient is 2. Mean gradient is 2, Saibal. You should try. Put an NT.
Okay. And on the medial side, right?
Yep. If it was 4, I would have left it alone, but It's 2
No,
after
no,
you
no. 4 I
release.
would not. 4 I would not do it for sure.
See, by and
So he's
large,
trying to do an MPR and see whether he can assess the valve area, which I think is reasonable. But I think what we've done is that we've got the main body up. And one more thing that we should discuss, that, you know, MitraClip is not just an edge-to-edge repair. It is a type of annuloplasty also, because it actually stabilizes the anteroposterior diameter. And so we know that with changes of blood pressure, it will not change too much.
I think Saibal, the better part of the valve is probably it's a good clinical result. I think she's on optimum medical management, and I think there's nothing wrong in just leaving up.
Yeah, Lily, can you do me a favor? Can you show your phone with the pictures? I want to show it to the audience, what you did. Can you show it in large? Can you bring it here? Can somebody do me a favor? Pedro, can you focus a camera on Lily's camera? I'm sorry we couldn't put it on the PowerPoint. Is this camera working?
Yes, yes.
Okay. Yeah, can you see this? Can you see this more larger? No.
No.
Yeah, go this camera right here. Go closer. Yeah, 233, 2000 of heparin. Can you see the global strain?
Yeah.
Yep.
And you see it's minus 14, and you can see what is impressive is that the middle, the apex is actually slightly normal, and the base is abnormal. And that's the characteristic, what is it called? The cherry on top appearance. This is a very characteristic of amyloid, where the bases get more affected than the apex. And that's why we were just doing echo. And this is a good thing for teaching sake. There are three things which bothered me: biatrial enlargement, EF which is moderately reduced, and this global strain pattern. And as what Juan Granada mentioned very nicely, he said amyloid is actually a tricky thing for replacement, because the base of the heart gets very affected by amyloid more than the apex. And now when you put a TMBR in, you actually immobilize the base. It actually makes things even worse. So that's why you rightly said that you have to be very careful when you're doing amyloid cases for any form of therapy. Am I right about that, what you said, Juan?
No, absolutely. I mean, what people don't realize is most of the mechanisms of anchoring in TMVR affect the base of the ventricle. And especially in cases like this, you could predict a significant impact on myocardial performance by putting a TMVR device.
Okay, so I'm just going to go in with the second clip. Dusty, are you measuring it? Okay, you can measure those two, yeah. So Dusty is measuring those areas separately by MPR. Dusty is an outstanding imager. The problem is that on the weekends he prefers surfing, and he's not happy coming here at this time of the day.
Yeah, you're making them work hard in the night on the weekend.
Yeah, yep. And his manager Tanya's over there. She's upset because we are in STEMI diversion now.
Oh.
Tanya's very upset. She's looking at me and looking at... Tanya, are you still upset?
You have to take her out for dinner later.
Oh no, she's like shouting at me, screaming at me.
Yeah. So Dr. Raghu and Dr. Chandramukhi, I'm sorry, you can join us as the chair and panelists, right? Please come.
I wrote clips. So we are advancing the second clip. Okay. So you want to do this? So just do 1/4 turned. Go. So Sai is, keep going. He's a first year fellow, but he's really impressed in interventional. He started with MitraClip training and then TAVR, and then he's going to do diagnostic angiograms. Keep turning more. Keep going more. Go more. Pull 1/4 turn. Good. Yep. I do a little bit more. So I use fluoro a lot when I do them. Keep going. Just quick, just fast. Good. Okay, good. All right, can I see bicable, bicom? So I'm just going to come a little bit here.
So
Okay,
for the
good.
benefit of the house, he has to come under the clip in fluoro because he wants to get this clip in medially. So what Saibal is doing now is he's lining it all up nice and coaxial in the LA. So there's the least amount of movement when an interaction with the clip when he's just crossing.
So I'm going to open the clip now. I'm nice and parallel to the clip. 3D end face. You know, I actually rotate the clip before coming down because I can make the two clips parallel almost just by fluoro.
Mm-hmm. I saw that.
Right? You agree with it? So I'm just going to go down. I think this orientation looks good, right?
It looks perfect.
Okay.
Maybe
so let's
little
go like
clockwise,
that.
Saibal. Maybe just
Okay.
a tad clockwise.
I did that. Okay, good. I think it'll go a little bit more clockwise when I go inside. So do you want to decrease the ventilator speed?
So what Saibal is doing is when he goes lung down, the clip will sail medially. So that way, once he's lined it up, he doesn't have to do anything else. He can go lung down and then it'll give him a little space to go in.
Just to give you an idea, I mean, I'm getting second thoughts of putting a clip. His LA pressure is now 15 and the blood pressure is 145 by 62. So you can see how the heart remodels with this clip, okay? So now let's go to Biocom LVOT. He's decreasing the tidal volume so that there's less movement when I go down. And I'm just going to track the grippers. Can you put this on the arms? So the blue is posterior, the dot is anterior. All right, I'm going to go very close to that clip. So what I'm going to do is, when we do second clip procedures, fluoro is quite helpful. You agree with that? So that's exactly what I'm doing. I'm trying to use fluoro. I want to come more closer. I actually want to go even closer to the clip than possible to put color on. Oh boy, the MR is getting better now. The lateral jet's very small, so I think we should go very close to that first clip. I'm going a little bit here, taking off a little bit of gain. I'm going very, very close to that first clip. I want to go even more closer. You see how close I'm getting?
Mm-hmm.
I'm being as close as possible. So I just went right below.
Beautiful.
And then I'm going to open the clip.
Amazing. Saibal, I love watching you.
Thank you. So you agree that it's close, and we're just going to see 3D end face.
Can you show the echo now? Yeah,
seeing the
thank you.
echo.
We
Yeah.
can see it now.
The orientation looks okay, right?
Maybe counter.
I think it's okay.
Yeah.
If I open the clip a little bit more, you'll be able to see it. Yeah, its orientation is perfect, right? It's up and down.
Yeah.
Right, Ali? Ali's not happy.
It's 12:05. That's why he's not happy.
Yeah, 12:05, right? Okay. All right, we can go a little bit clockwise. How about that? And let's go back to Biocom LVOT. And let's try to see whether I can see that. You see the leaflets? How nice they are on it? So we can do 3D now and just see the leaf. And as Sai said, I take my time. I orient it before I drop the grippers. Decrease the gain. Okay, so I think I can go a little bit of counterclockwise, right?
Yep.
Right?
Yes.
Okay. Let's go to grippers. 15 pressure. Both the leaflets are, there's a nice posterior leaflet in. I'm going to take as much as posterior as I can. I think there's enough anterior too. Yep, there's enough anterior. So I want to go as much as I can, take as much posterior as I can. And then I'm going to drop the grippers. And the posterior is down, anterior is down. Let's see 3D end face again. And then we'll close it.
Wow,
oh my God.
Big bridge.
Okay, nice range. Can you see can you decrease the gain? Okay, now start closing, Asma. Hold this. And no, let's go to, no, very slowly. Can you go back to, yeah, that's good. Start closing very closely. And we never try to, there's no rush to close it. So we let the leaflet go down.
Lock at 60?
Top. Yeah, we locked already. We actually locked a little bit earlier. And then go down, Asma, a little bit more. Okay, go down a little bit more. You ready? A little bit more. Go. You can go more. I like to close it tight. So there was no, LR pressure is 14. Did you guys see the LR pressure? Can you show the LR pressure? Sorry. Pedro?
Yeah,
can you see the LR pressure now, guys? Mm-hmm. Look at the MR now.
Pretty good, actually. Very good.
The medial jet is almost gone. The blood pressure is 128 by 61. There's a small lateral jet. And I think we should just deploy this, right? You want to measure gradient?
Gradient.
Yeah. I mean, by doing so close, I think the gradient will still be maybe less than 3 in my opinion.
Yeah. Yep. So, Dr. Chandrasekhar.
Yeah.
I was thinking of changing career and becoming an echocardiographer.
No, I'm just kidding. See, listen, we need everybody, and I think you since you've been doing this for a long time, you've acquired this imaging skills that you need.
3 millimeters. Do you see that?
Yeah, it's very good.
Now let's see 3D. Let's look at pulmonary vein. Oh, look at that. That looks beautiful. I think, Dusty, you're getting the hang of it finally. All right, so let's do the pulmonary vein. Where's Gabe? Is he gone to the restroom? No, we have one of our techs. Whenever things go really bad, he says, can I go to the guest room? I think he's gone to the restroom. Oh my God. So that's the red flow. And this is very nice. You see how the diastolic flow has reduced in amplitude? Yeah. And the systolic is right?
Increased, yeah.
Right? And that's a characteristic of this thing. So let's do the other vein. And that's a nice, good sign. You see that? And let's do color there. Look at that.
Increased systolic amplitude.
Right? So the systolic amplitude, but there's a decrease in diastolic amplitude. Right. Am I right there, Dr. Chandrasekhar? Am I talking sense or I'm just talking nonsense?
No. I think you're talking pretty, I think you make sense. Don't worry. I think you're good, man.
And can you look at the LA pressure now, large screen? It's 15 now. We started with 20, 24, 23, and now it's 15. All right, so I think we should, and the V wave is down, so I think it was right to have deployed the second clip. Juan, do you agree with that? And also, I want to show you something fluoroscopically. Can you look at the grade MR? It's much less now. There's just a medial commissural jet, which is from the commissures, which we wouldn't have touched anyway, right? And the lateral jet is very small. So, if you look at fluoroscopy, do you see that the lower clip is more atrial than the clip up above? Can you see that? And that usually indicates I've got more tissue inside it, because there's more tissue graft. So I think we should just deploy this. I don't think we should waste any more time. Let's go and deploy this. Okay. All right. Yeah. So let me get a view. So usually I try to get a view where you can see the clip very well. Let me find a nice LAO angle. Okay. 1 minute. Okay. Now, close it. Tight. Close it. Yeah, close it. What's good? Yeah. Yeah, I think the MR is really mild now, right?
Yeah, I agree.
Okay. Okay, now try to open it, and you do the thing. So you see that she's opening it. Good. Very good. And you see the clip is not opening at all. That's a good sign. Good. and then go to positive side or neutral. That's it. Yeah, good. All right, Ali. Good. Now open that. So I do want to acknowledge something else when we do a case. You know, we have Ali from Abbott. She's been working with us for many, many years. They really play a very big role in this procedure. You probably can't hear her voice now because she doesn't have a microphone. That there are two of them here, and I want to tell that to all the members of the audience that this procedure is one where you really need to listen to them because they actually know this procedure very well. Do you guys agree with that?
Well, there's no question because see, they have several important role to play. One, they see the case from the beginning, and also they know the product, and they've also seen many cases and many complications, many mishaps, why and what not. So their knowledge repository is quite enormous. There's no question about it. I think they do play a significant role.
So, Saibal, from the technological point of view, from
yes.
the technology
Yes,
development
please.
point of view, every single time I see people put in a second clip, it makes me
Yeah.
think that there is an opportunity for innovation and development
Yes.
of clips that actually have more capability to adapt to the anatomical variability that actually you see in these cases. Do you agree with that?
Yes. Yes, actually, I have been telling Abbott, I think you got more pull than me, you should tell them. One of the biggest problems, you saw how I came with this clip very close, right? And when I got it up, it's okay. But if I had to take it out, the grippers interact with the leaflets. And it actually makes it sometimes difficult to come out. So I agree with you that for a second clip procedure, they have to modify it to make it safer to easily go in, and if it doesn't work, come out. Is that what you're saying, Juan, right?
Saibal, let me ask you a question.
Yes.
Instead of mitral clip, if you had used Pascal, because the
Could I have used Pascal in this case?
No, Pascal, the wider paddles, you think that you would have required the second clip?
So it's very interesting. You know, like the Pascal, there's two devices, Pascal ACE and Pascal P10. It's interesting that even the company is moving away from P10 and asking us to do more PACE. And PACE is actually 6 millimeters, which is equal to a wider clip. So I don't feel that there's too much of a difference between the two technologies. So I think it would be okay with either. I'm not trying to say say one thing's better than the other, but I think they're reasonably good technologies. They do the same thing. They're just a tool. And for me, I've had more experience with MitraClip, even though I was one of the first people to do Pascal. But I'm not going to say anything negative or anything. But all I can tell you is that one thing people has to know, that the Pascal is the best form of complement is imitation, correct? And the Pascal is an imitation of MitraClip. It is gripping two leaflets between two metal plates. In fact, that is the patent of Farrell & Powell, is gripping. She's unfortunate she's not alive to have seen where her technology has gone to, but that was her patent. Anyway, going to that, I think I agree with you. There is another advantage of Pascal over clip, which I think is that, as Juan said, that when you try to advance Pascal into the valve and you want to take it out, you can elongate the Pascal, and actually when you elongate the Pascal, it's easier to come out. So that, I think, is one definite advantage. I do want you to focus on the LA pressure right now. The blood pressure is 128/56, and the LA pressure is 14. And so the MR has reduced, and so I think it was the right thing. Thank you for your advice to have gone ahead and done the second clip.
Yeah, thank you. I think the other limitation of P10 also with Pascal is imaging, right? And that's one of the reasons that we always have a tough time imaging that device.
Exactly.
Yeah.
So So Dr. Chandrasekhar, that is one classical, what he said is absolutely right. Because it's got a little bit more fabric, it sometimes imaging becomes a challenge. But before I end, we have finished our case away in time.
Yeah.
And actually we only have 5 minutes. I want Dusty to show a couple of last images because Dusty is almost falling asleep. I don't want him to fall asleep.
And your groin closure is a ProGlide or a mattress suture?
A single per close.
Yeah.
And so measure the air pressure final. I'm pulling out the guide and I just want to show the final result to people. Yeah, you saw what it was like before and you can see what it looks like now.
Yeah. Can you look, for the audience who have just walked in probably, can you show the pre and post?
Yes.
Sure.
Dusty, can you show the bad MR before and then post? That'll be really good. Yeah.
That'll be great. Thank you.
All right. So we just pulled out the LA pressure, and I want to show this to you. One, this is for you guys. Does shunt? Oh, that's the MR. Can you see that?
Yeah.
Here's pre.
So that's pre.
Look at that jet. And
And reversal of systolic flow in the left upper pulmonary vein.
Yeah. Wonderful result.
And then let's show the final. And look, that's the final.
Yeah.
And I want to show something else. Can you show the LA pressure now? Can you show LA pressure, Pedro? LA pressure, Pedro. Yes. Can you make Pedro large? Look at this. I pulled out the guide catheter.
Yeah.
And look at the left atrial pressure. It's 8. So on 12 to 14. The reason why I'm showing this is that people are aware of this new data of shunts in HFrEF and HFpEF patients. And in one of the studies, and one, you can make a comment about this, it actually showed a benefit. And this is a patient with HFrEF. And you see, as soon as I brought out the guiding catheter, there's obviously a 4 millimeter hole. The left atrial pressure is now 8. And so we went from 23 to 15 to 8. So maybe shunts do work in some patients. So that's the final result. And I want to thank Srinivas for allowing me to show this case to all of you guys. And the panel was obviously extremely esteemed. Very difficult people to deal with, but who really appreciate. I have a lot of respect for all of you, especially I've had a great experience working with Sai in Apollo, and I'd rather be in India right now. And I've also learned a lot from Dr. Chandrasekhar. And before I end, I would like to acknowledge people again. Tanya, I want to thank you for allowing us to do this case. Thank you for arranging everything.
Yep.
I would like to attend Pedro and Craig from MedInbox. We transmitted this whole case through a Zoom system, which is inbuilt into the hospital, and we can go live. So this is actually a new system that we allowed. I also want to thank all the staff who have come here at this late age on a Saturday, when you could have been drunk by now, but instead of you're here. Or you could have been in a Trump rally. You could have been in a Trump rally, which you're not here for, okay? And I also want to thank Gabe that you didn't go to the restroom when you need the most. And Dusty, thank you very much for those amazing images. Dusty, those are the Dusty Lloyd is an outstanding anesthesiologist, and I actually agree that if you're a good cardiac anesthesiologist and you can image, I think it's okay. You don't need a separate imager if necessary. Even though I know there are some exceptions, but usually in a mitral clip case, it's okay. Not maybe in a TMBR.
No, he did an excellent job. I don't think there's any question about it. I think the way the images are shown is perfect.
Thank you. Saibal,
Thank you very
comment
much.
from Dr. Eberhard Grube.
Saiba, that was masterful, and maybe we can discuss, I have a question looking at the case back when you started.
Yes.
There was a little bit of a split jet, and I'm just wondering, obviously it was masterful, as Sai said, and you couldn't have done any better, but, looking for a less experienced operator, thinking that you would not be able to do with one clip, would you consider or would you advise for a less experienced to start a little bit more lateral and then move to medial instead of navigating very, very close, very skillful, 2 clips side by side? Would that be a consideration?
Usually, Eberhard, when I decide to do 2 clips, I often go the first clip either slightly lateral or slightly medial to the midline. In this case, I chose 1 clip because all of us as a group thought that this case would be as a smaller valve area and we would have to do it with 1 clip. That's the reason why I did middle.
Yeah.
But otherwise, if the valve area was larger, I would have done what you said. I would have gone slightly medial or slightly lateral. Actually, I would have gone slightly medial.
Yeah.
And then the first clip's there and then gone slightly lateral.
Okay, thank you very much.
And by the way, Eberhard, I just want to repeat that MitraClip is a very good Band-Aid.
That's what I was... That's why I warned you. You were just starting that I'm in the audience here, so I'm glad you didn't say it.
That's right. And as you also know, that Band-Aid is the major income for Johnson & Johnson. So Band-Aids work.
Well, thanks very much. I can see you in a good mood.
Yeah.
Why don't you just
On Saturday
stop
night.
and get drunk?
Saibal, thanks
And
to
once
you
again,
and
I
your
would like
wonderful
to tell
team.
the organize.
Yes. Thanks to Tanya and her team. Thank you very much for entertaining us for the past 1 hour with a wonderful result on MitraClip. 2 NTs placed right next to each other, and reduction of severe MR to trace of 1+ MR. Thank you.
Thank you. Bye, guys.
Saibal, bye. Thank you. Thank you for all you have done for India's MitraClip journey, Saibal.
Thank you. Thank you.
Sai, okay, so now he's off.
Yeah.
Would you briefly, because you are as experienced as Sai is, you know, if you look at the initial jet, it was a split jet, and I think it would have been it's quite challenging to start to close it with 1, and because you know obviously the team thought they could do it with 1. If you look back, would you think this was still the right strategy, or would you say, well, maybe a little bit more media and then room for the second? Because I was questioning, obviously I'm not as experienced as you are, but I was questioning whether a 1-clip approach would have been the way to go.
So,
and now you can speak openly.
Yeah. So, if we are presented with a case like this, I guess the experience of the operator matters a lot, Professor Grube. It's a very pertinent question you asked me. But if you are, say, about 50 clips journey, and you have an 84-year-old lady who's limited ambulation, who's in a home, who needs a walker, who's post-CVA, CRT, and her pressures were 130/80 with that MR, you have a 3.9 valve area, I would just take 1 clip, go for the slam dunk, finish it, accept the result, get out, manage her medically.
Totally agree.
If I've decided to put 2 clips, I would probably give myself a little wiggle room and put 1 clip slightly medially and then put the second clip laterally, because it's easier to go over the clip initially than under the clip. But yes, it's a...
No, I mean...
It's a very astute question.
This was an impaired ventricle, and by having a perfect result, you increase afterload. And I'm just worried if you do this, that the ventricle, which is sick,
which is an amyloid ventricle
in the first place, that wouldn't be able to handle it that much.
You're at...
Thank you, Sai, and thank you, Ramesh, for conducting that live case and this first session, Micra, very well. And a lot of youngsters wanted to learn this, so in spite of companies' reluctance to be part of the education thing, still we wanted to have it. And thank you, Saibal, for an excellent demonstration too. Now we requested Juan Granada, who is there fortunately with us, the CEO of CRF. A lot of new things happen regarding the development innovations on the CRF front. So we wanted to share his ideas and thoughts of concept creation, commercialization, clinical use of new devices. So we gave sufficient time as a keynote address for 25-30 minutes. And so we request Dr. Ajay and Dr. Akiko also to join. Other cardiologists who are here, Dr. Pratap, can come onto the podium, and Dr. Krishna Reddy, Shastri, Saumin, Shivakumar, Aditya, all of the panelists listed. Please come over if you are here.
Thank you, Srinivas. And thank you again for putting together this beautiful, meeting and getting us involved in the meeting. What I'm going to do in the next 15 minutes is something that I hope you find a little bit fun and refreshing, because I'm not going to talk about the regulatory environment and how to invent devices and things like that, but instead provide a little bit of insight about the future developments of our field and where our field is going, considering the significant amount of changes that we have, the social, political, and healthcare changes. So I want to start with a little bit of a historical context, because I see that in all the meetings, everybody quotes, Andreas Grunzig as the person who, truly started, our entire field, and they show the first coronary balloon angioplasty in 1977, which no question was perhaps the pivot point of our field, and created something that is very special that, we all benefit from at the present time, which is the interventional cardiology field. But I am never tired of actually learning about the true innovators. And for me, at least personally, the biggest hero is actually Werner Forsman, which at the beginning of the 1900s, actually against his own institution, put a catheter through his arm, essentially took an X-ray and went to document the first cardiac catheterization. And I really think he's the one that we really need to, say thank you for, because he was a real pioneer that essentially showed, as he called it, the gate, to the heart. So you guys know he's perhaps the only one that actually got a Nobel Prize, and perhaps the only one that is going to get a Nobel Prize in our field for these, development. Later on, one of the things that, I feel that we have lost a little bit is the basic science and translational research behind what we do. And I'm quoting 3 beautiful papers that were published in the 1980s and 1990s that essentially showed, with a high degree of, exquisite taste, the mechanisms of failure of balloon angioplasty. And were these results that essentially inspired, innovators and inventors to develop the stent. And you actually see 2 amazing moments in our field that happened in Brazil in 1988 and 1999 with the introduction of the bare metal stent and the drug-eluting stent. Since then, a lot of things actually have changed, and it's something very interesting happening right now in the management of coronary disease. And I really think has to do with imaging and the introduction of artificial intelligence. And is the capability to essentially have a very highly accurate, non-invasive diagnosis of coronary disease. And more we see the diagnosis, staging, and planning of coronary disease is happening as an outpatient basis. So the need to take patients to the catheterization lab to at least diagnose disease is going to actually decrease substantially over time. Also, the use of wires and actually medications to assess physiology in the patients is actually also decreasing significantly. And with the amount of tools powered by artificial intelligence, we see more and more use of wireless physiology assessment tools that simplified the cath lab management and diagnosis of these patients. When you go to the interventional side of things, we see a massive amount of development on software automatization, in which pretty much the idea is to provide a full analysis to the operator, so the operator selects the right stent, the right diameter, and the right application of the tool they're going to use. So we will see and continue to see a revolution on imaging that is going to really make the diagnosis simpler, faster, and actually more automatic. One thing that we started to see, and is actually quite interesting, is that coronary intervention is finally embracing the concept of leaving nothing behind. And latest numbers coming from strategic companies started to see there is a decline of metallic stent use in certain parts of the country, especially actually Asia. And the reason is because now we have improved performance of lesion preparation devices, such as actually intravascular lithotripsy, and we have already at least 3 or 4 companies coming behind with advanced systems that actually can produce better and actually more efficient and safer balloon angioplasty than we had before. We also have better assessment of PTI outcomes, and we can really discriminate if the patient has an occlusive dissection or actually, where the patient essentially needs to be stented or not. And we have now a wide variety of advanced drug delivery balloon platforms that we didn't have before in the 1990s. So I would actually say that the PCI definition is going to slightly change in the future, and this is actually kind of my proposal. Prepare the lesion, confirm physiologic patency, and individualize the use of a stent. I really think in the future, I predict spot stenting is going to actually be a very interesting option, especially for patients with significant calcific or diffuse disease. The invention of the stent was the catalyst for the development of other catheter-based technologies. And if you actually look at the history of our field after the invention of the stent, pretty much everything came behind. If you look, the first percutaneous aortic valve was essentially developed by a group of stent developers and was inspired by a stent technology. And everything started actually from there with the idea of actually making interventions less invasive, less complex, and actually improving of procedural outcomes, fast procedural recovery, and early hospital discharge. And for all these technologies, in order to be successful in the future, miniaturization, making these devices smaller is a must. Simplification of the procedure is extremely important, and standardization of the procedure as well is the final goal. And as I said before, TAVR was a spin-off of the stenting era, and actually everybody here knows the story. After more than 2 decades of research right now, the technology actually has grown and expanded into areas that we never expected before. But you see the field continues to essentially evolve in this field, and now you see systems that actually are tested and right now already in first-in-human studies, like this Seagull system that is an 8 French fully loaded TAVR device that, as it happened in stents, using a dedicated different type of metals, in this case is rhenium, that actually is a very strong metal that allows the frame to be extremely thinner and achieve the same radial force as conventional devices, and they have been able to go down to 8 French. So imagine in the future being able to do full-blown TAVR procedures with 8 French fully loaded devices. Also, these technologies allow us to go into areas that we never explored before, and one is the possibility to treat mitral valve disease with a fully blown valves. And this is actually a remarkable achievement that has still a lot of challenges, ahead of us, and actually a lot of studies need to be done, but essentially promise the potential to be able to treat patients that are high risk for surgery with fully percutaneous technologies. And you actually see how these catheter-based techniques have expanded to areas that we never thought before. And I here put a simplified list of the mitral and tricuspid technologies that right now are under development. That actually shows you, the creativity of engineers and inventors, but actually also the aggressive appetite of investment in fields that are extremely exciting for this type of people. Also, the catheter-based field has migrated into a new field that we call interventional heart failure, trying to replicate some of the surgical techniques or interventional techniques to improve myocardial performance. And this is actually another completely different field with extremely exciting, ways to essentially try to treat the failing heart with mechanical methods, including mechanical circulatory support. But one of the things that actually happening that is very interesting is the adoption of these catheter-based procedures highly depends on the evolution of cardiac, imaging. And the introduction of new imaging technologies that are simple to use and interpret will serve as the expansion platform of catheter-based technologies. The reality is there's limited access to highly skilled imagers. And if you actually look in the United States, you know, across around 2,000 departments with interventional cardiology, only 18% of these sites actually have very well-developed structural imaging departments. So you see there is a big gap in terms of what is actually available right now and what is actually needed. This gap is even larger if you go out of the U.S. In areas like Latin America. You know, to find real expertise on imaging guidance is extremely difficult. So the technologies are actually evolving, you know, trying to close this gap, and this is one of the examples of how this is actually happening. This is a company that essentially is teaching people or guiding people to do echoes, you know, high-quality echoes without the need of actually having a skilled operator, you know, to do the procedure, you know, for the patient. Essentially what it happens is you activate the software, and the software essentially tells you exactly where to go, what to do, what images to capture. So pretty much a nurse, a technician, or anybody can actually capture all the images that you need. These images can be transferred, and actually also there is a component of automatic, you know, software that can read in a high level of accuracy the echocardiographic findings. So as you can imagine, this could potentially really be helpful in areas in which skilled operators are actually needed, but they are not available. So you can actually upscale the number of procedures that actually are done in these particular areas of the world. Also, this is another way to essentially replace the skills that we don't really have right now.
Keep on banging against that front door.
Concrete, yeah.
Yeah.
I think the problem with it, you know, even it's really not a.
Hey, Ajay, how are you?
Hey, actually, it's great to see you. I was just
Yeah,
gonna
how's it going?
It's great. I was just, you know, the problem is that in theory you can try Carlino, but if you're not in the subintimal space, it's just an injection of the vessel. And I think what's happening here is you have to get subintimal somehow, and what he's trying to do is do that either with knuckles. And so there you
Like
go.
so. Nice.
So that
was
worked.
awesome.
But
you floor store that. That was nice.
without that, you have to solve the problem somehow, and that is either penetrate, de-escalate, or then do base or do scratch and go or something. But thankfully, in this case, it broke through, and now you don't have to worry about that.
That was great. Although you're, I mean, it's
quite far away.
It's well, it's also very tortuous, right, Ashish? So it's harder to tell exactly how far that is.
Yeah.
Right? Like it's that you may be right on a bend there.
It's so crazy. I think I'm in the vessel.
I think you're there. Nice.
I know, but I think my wire dystrophy is in the truth.
It is a challenge to see it for sure.
I don't know for sure, but it sure has that tactile feel like I am. I'm going to
Can you, I think I saw you enter a branch. So are you able to enter a couple of different branches off the PDA? Just gently with that wire. It's not a.
Let me look at the first. Let me take a first shot and see how it looks, though. Let me just go back and play this and see how the.
Yeah, and I think the other way to do this is to change it because there's so much tortuosity down there. Is to do RAO and see because you just want to be sure.
Because the other option.
This is the aleocranial. This was the way it looked before. So let me just see how it's. There are not that many branches except. One that comes
the other option, Ashish, was you remember where the Pilot 200 came out and looked like it went true? It was still within the distal RCA. So you can bring your microcatheter down into the distal RCA, then switch for your workhorse. So you don't cross the distal bifurcation. You don't jeopardize
that's bend. That really is.
That looks, it sure looks true. But you know, if you really wanted to be sure and couldn't see, you bring your microcatheter proximal to the distal bifurcation and just swap for the workhorse.
No, I feel
which you're
very
going to need
confident.
anyway.
Yeah, I feel very confident in that, man.
Yeah, you're tracking right along the vessel, and you're also not bending as you go, right? You're not spinning the Pilot 200.
Nope.
You're not drilling. It's just kind of
Just
proceeding.
going. This is the Mongo, yeah.
Yeah. So even more, right? So a Mongo has a core stopping back of the tip. That Mongo, if you're subintimal, will knuckle on you fairly quickly.
Yeah. Okay.
Nice.
we're past the bifurcation at this point. I think I'll try a workhorse here and see what happens.
Agree. And do you find when you spin the spiral, which is, so the turnpike spiral has been relatively recently introduced here in India. It's a very, very effective antegrade microcatheter. Do you find that when you're screwing the spiral in, you turn slower than you do with some of the other microcatheters?
No, not really. So I'm getting brisk blood return. Not that it means anything.
So it sure looks good.
I'm getting almost like it's almost filling my microcatheter hub before I even. Yeah. So
that sure looks good.
I'm just gonna get this down there, and then ultimately I think I'm gonna need to image and roto. So we can.
Well, we've got a Kiko sitting here on the panel as well. So that image.
Oh my God! I think so.
We all want that image.
Yeah.
Yeah, that looks pretty good, man.
Okay.
Is it going?
All right. Yeah, it's going past. It's actually not much to go.
Huh.
So.
What's your workhorse? Is it Xi'an Blue?
It's a run through.
Run through. Okay. Because that's the other thing, right? Is the run through is a very floppy tip. So if you're hitting tortuous segments and plaque, you will collapse on the tip versus like a Xi'an Blue where it's going to be a little bit more directable.
I'm just gonna bring my micro back and see what it looks like. Take a retro test again and see if it helps. Okay. All right, let's take a retro test. Inject.
It is very difficult. So what it tells us as well is that the dominant septal through which you're filling is probably plugged by the microcatheter.
Yeah.
Right? Your pressure heads are lighting up because that PDA is big.
Yeah, let me try to change the angle and then see if I can.
You're sort of in an LAO view now, right?
Yeah. How about going RAO cranial?
Yeah. Yeah, or even just straight RAO where you see the septals cascade down right into the PDA.
Yeah.
You might see the distal end of the PDA that way because you're already in it.
I think this is a good view.
This is a
great shot. You're right.
Yeah, this is a good view.
This is a great shot. Yeah. All right. Let's take a send. Yeah. Inject.
There, okay. But you know when you've got the cine going and the contrast is coming up.
Yeah, I'm gonna.
And you wire while that's full.
Yeah.
Right?
That's what I'm gonna do. Right. Yeah. See. Yeah. Okay. Cine.
That
just feels like it's gritty. Doesn't look right. Yeah.
That doesn't look.
So maybe it's fine. Yeah. All right. So it's fine. So we have retrograde.
You have retrograde access to the true lumen.
Yeah. So we're just going to do
reverse. Just take your retrograde wire and let's just do reverse card.
Yeah. Exactly. Let's not screw around. Yeah. I agree.
But I think therein lies the case for why you have to be sure. Right?
Yeah.
Looks like subintimal.
Yeah. It looks subintimal. Correct.
Interesting. Look at that.
Yeah.
That's just a Xi'an black, right? Oh no, that's your Pilot 200.
No, that's a retrograde wire.
Yeah, that's your retrograde Pilot. Okay.
Yeah. Okay.
Yeah.
I'll just get my retrograde gear to a place where the knuckles are, where the micros are touching, and then we should be in business.
So lots of calcium. What's your sort of reverse cart strategy going to be here? Where and
straight part of the vessel. That's going to be the first thing.
Yeah. So right about where you are with your retrograde microcatheter now, yeah?
Yeah. Right. Exactly.
Yeah.
Exactly.
Well, either above the bend or below the bend, but not at the bend, right? Yeah.
Correct.
Yeah.
And then be flexible.
Mm-hmm.
If it doesn't work.
Yeah.
There.
Would you track your trap liner down at all? I admit,
I'm
like sometimes
come back to that LAO cranial view.
Sometimes I'll track my trap liner down pretty distally in these situations, just to make that.
Yeah, it's already. I still have pressure.
It's quite a ways down. Yeah. But I mean, I'll track it down not to block off pressure as much as Because you don't have a ton of branches you're protecting there. It's more just to make your reverse cart life easier.
Yeah. Okay, super. Come back to that RAO view.
Nice. Oh, that looks nice and close, yeah?
Yeah, that's the spot, I think. Yeah, super.
I would be very careful, though, to make sure you're well proximal to the bifurcation.
Yeah, I think I am. The PDA is actually, I looked at it in relation to the spine,
okay,
and I think I'm okay.
That's good. I think had that antegrade cross been true, you would have disobeyed all of the rules that we work so hard to establish.
I know, seriously, yeah.
Isn't that?
Here, can we de-escalate to pilot 50 so that it will, whether false or true, we can see?
Well, I think he's committed to reverse cart now. The question was, can you just change over to a pilot 50? But I think at this point we're committed to reverse cart. So we're just gonna do with, you know, you've got your knuckles up now. He will be switching wires to make the connection, I'm sure. But you know, and
I'll take a 3.0 balloon, 3.030 balloon.
Yeah. Right, because he's going to end up stenting that segment anyway. So I guess the comment was 3.030. That's a pretty long balloon, but that
but the whole
segment's
thing is
going to be
diseased.
dissected anyway.
Yeah.
Do you think it's going to be bigger than 3.0, Ashish?
It could be. 3.5
I think it's going
is
to be
kind of what I
bigger.
thought
Like, I think
based
you're
on the
going to need
knuckle
a
size.
3.5.
Yeah, but I wasn't sure I'll be able to. We'll see how easily this goes down there. That's why.
Any use of anybody has experience using Wolverine to facilitate destruction of the tissue between the antegrade retrograde wires? Does anybody have comfort or experience doing that? So admittedly, I've done that a bunch of times. I have not. Yeah, I've never perforated. Having said that, you do undersize, and for what it's worth, I don't find it has been all that helpful. Right, and I think it just speaks to the mechanism of action of some of these cutting balloons, where ductile materials will bend, brittle materials will crack. Right, and that's why they don't do anything to normal tissue, but within calcium, they really do split things. Dr. Tiwai.
I have a couple of cases last month that Wolverine get bust, you know, with 2.5, even such a heavy calcium.
Is your balloon tracking? Is it tough to get it down?
Yeah, it went down. I was already down. I'm just getting the trap liner further down. Balloon is down. Yeah. Go up. Down. Perfect.
Nice.
Another inflation here. Go up. Down. I'm advancing my trap liner. It won't go much further. That's fine. We leave the balloon there. Okay. Taking my retrograde wire back.
Oh, up you go. Yeah.
No.
This is that bit about, trap liner down as far as you can to make your reverse cart life easier.
Yeah.
It's tough because you're coming around a bend. There you go. You got it now, right? Yeah. Nice job.
Laura, save that. Yeah, that's it. Yeah. Thanks, guys. That was great. Yeah.
That's great.
Okay.
That was your Pilot 200 that you had retrograde, right?
Yeah, that was a dinged up Pilot 200, not even just a Pilot 200.
It's the dinged up Pilot, right? No, but that often works, doesn't it? Even the Mongo, it often works, right? Because you've just got a decent sized space, and if you make the right connection, you're done.
Yeah, I'm just going to manage my retrograde guide here a little bit. I need to back out. Getting my microcatheter into my.
Same pilot he used.
Yeah, same pilot.
Getting my microcatheter into my.
And so, Dr.
Trap liner, and then I'm going to R3.
Do you have an externalization wire preference? Are you an R350 guy? Are you an RG3? Do you have a particular reason why to use which one when?
Yeah, well, it's an RG3 300. That 300 is the one which we use normally.
32
like
minutes. That's a
this,
lot of
that's
time.
the one which is commonly available.
Anybody else have any other preferences? RG3 all across? I'm an R350 kind of guy, to be honest. I like the nitinol, particularly in these larger main vessels. I think the RG3, for me anyway, I prefer that wire in more tortuous epicardials because of the ability for the non-kinking nitinol to create a bunch of pseudostenosis across big dominant epicardials.
So we're going
That's
with the,
just my
we, like you, Sanjog, we have the R350. So the R350 is what? It's a little bit better body. And
yeah, it's got body to it, right?
Yeah.
The other nice thing is, Ashish, as you will put your externalization wire through, you're going to put that out. What's your process at this point to
show the guide, you mean, at the other side?
To get your wire out and do you do the disconnect the TUI and put the wire through?
I just clamp it proximally and then right here, and then I just, Go ahead.
Yeah. Arun Kalyanasundaram is joining us as well, Ashish. Arun says hi.
Oh, hey, Special K, how are you doing?
So one interesting approach is to pull the trap liner back so it's sticking out from your antegrade guide. And what it ends up doing is filtering your retrograde wire right out through the trap liner and into the world without having to clamp the antegrade guide.
Yeah.
I picked that up from Bilal Iqbal recently, and it's a peripheral trick, right? That I'm sure you're very familiar with when you're, sort of sheath and sheath.
It's good, but he fought to get the trap liner where it is, and there are other ways.
Yeah, exactly. Thanks, Ajay.
Can work, so come on. I mean, everybody likes tricks, but the position's so good right now.
Thanks, Ajay.
Oh ye of little faith. You're gonna have to take that out in order to get an IVUS in anyway. So you got to take it out. You're gonna have to balloon it, take it out, and probably rota through it, right? So that's coming out one way or another.
But not now. I mean, he's good now.
Oh ye of little faith. He's externalized. He has a fellow-proof rail right now.
Well, we've done it too, but I just think that the problem is in this space and in general in complex PCI, everybody's enamored by tricks.
Yeah.
And many times tricks are good. Sometimes they become dominant and they should be used, and other times,
No, for sure. It's all good points.
I mean, it's style. Those are style points, right? I mean, ultimately, I don't think.
Yeah, I mean, I do it the same way you do. I just this is something I saw recently, and I thought that was kind of
cool. No, it's good. It's always good to have good ideas and learn new things. I'm not opposed to that. I just think that. All right, so I'm gonna just take this antegrade stuff out. I'm gonna just back my retrograde wire, retrograde guide back. I mean, retrograde microcatheter back, and we'll get an IVUS down. Yeah.
And how do you? I see you're controlling your retrograde guide carefully as well, right? Making sure that you don't.
Yeah, just backing it out a little bit. That way you don't have to worry about it. There you go. I'm in the propagate here. All right.
Nice.
So we have the poor man's IVUS, not what you're going to see with at Columbia with 60 megahertz and with AI-based imaging.
That's okay.
We have elegantly shows over that. No, but that HICC so elegant.
Are you telling us you're going to use the volcano? Is that what you're saying? Because not even a Kiko can overcome the limitations of that device.
I know.
But you also feel comfortable it'll cross, because that's the one thing is that sometimes ballooning it first.
I think I ballooned it.
I mean, he took the 30 through the 3030
all
right
the way down.
The distal segment, right?
Yeah.
I can't read these.
So we have the the 4H platform here.
Kiko's looking at your IVUS carefully now as it comes up.
Yeah. Here it comes. So I'm going to get it out and extend it as far as it'll go, and then I will back my trap liner up. Okay. I'm going to back the trap liner out.
No, the thing I was talking about, the ballooning part, is down there because the wire was subintimal down there, and you want to see what
Yeah.
the distal landing zone is going to be like.
Yeah, but
It
look at
looks
the
okay.
image
It
right
looks
now,
okay.
Ajay. Yeah, it looks
good.
like
It looks
we're in True Lumen here, and it looks like it's a nice.
To be honest, I don't know we are True Lumen.
Yeah,
Seriously.
Okay.
but this was
No. This is the artifact. Yeah.
yeah, this came up
Yeah.
retrograde,
No, that's
right?
the
At
ring
this
down.
point.
That's the ring down. Yeah, yes.
Yeah, it's okay. If you can go more to be sure we.
Distally?
Yes.
More distally? Okay, I'm going to try to advance it.
This is into
has
the
to be,
PDA.
yeah,
it has to be true here, right? Because you came up retrograde.
Yeah.
Sure, but
Yes.
sure. Okay, okay. That's I buy it. But okay, let's start. So assuming
Okay, I'm going to do the
pull
Go
back.
ahead, sorry.
So assuming
Yeah,
this
pulling
is-
back, starting now.
Go ahead. That's
Recording.
assuming this is true lumen, even though I don't see any intima yet. Okay, so that's, to me, that's the tissue. That's 9 o'clock. That's, what is that? Okay, to be honest, it's very difficult to interpret it. Okay, that's a true lumen in the 9 o'clock, and we are very sure it's subintima. Go ahead.
Yeah, which is where we did all the
That's
knuckling.
fine. That's
Yeah.
perfectly fine. And
Interesting.
oops. No, that looks like intraplaque. That's subintima. Subintima.
Yeah.
Yeah. Go ahead. Go ahead. That's all subintima. Yeah. Still subintima. Yeah. Subintima. We are intraplaque. Actually, this is the proximal portion of the CTO.
Yeah.
Okay, that's a proximal
And this
portion.
is the proximal
Yep,
vessel.
yep,
Yeah.
Yep. That's dissected, but that's fine. This calcium was not
Yeah.
too bad compared to what we
Yeah.
thought. Not three. Okay. By the way, can you go back to the IVAS by recording the image? Okay.
Yeah, sure. Just to play it back. Yeah.
Yeah. Because I
Yeah.
may make the mistake. So go back to the very beginning. Let's go through one more time where we are.
Sure.
So the very
Okay, so
beginning.
here we are all the
Okay.
way back there. Yeah.
So that's a true lumen. Go back. Bring back
keep pulling.
proximally.
Yeah.
Yeah, that's true. Go back. Go back.
That's
Then-
false.
Yes, like 9 o'clock, you see the tissue that's collapsed to lumen. We are in the fourth
Yeah.
lumen. Do we agree?
Yeah.
Yes.
Yes,
Okay.
I think so.
Okay, go back. Okay, go back. So, but it's
Yeah,
okay
he's-
because we are true lumen in the study. So who cares?
You know that tissue plane, Akiko, is it above it? We were wondering whether or not it was true or not. Is that potentially the hematoma
Yeah, no,
or
no, it's
subintimal
good.
space created by the antegrade microcatheter when it was subintimal in the first place?
Just play
Remember
that
where you
last.
tried to wire in?
Just the diameter, David.
Yeah, that's
Right,
about
that right where that plus sign was, that's sort of false there, but you're actually the catheter's true, and that's just a tissue plane.
1, 2, 3, 3. Yeah.
To be honest, I'm very unclear this
Yeah.
picture. I need to see
Yeah,
that.
not good. Terrible image. Terrible image.
Yeah.
Yeah, exactly.
But I think it's okay as long as we are confident of the distal portion, whether we are true or false,
Yeah.
it really
Yeah.
doesn't matter.
Yeah.
And importance
Yeah.
is because we are soft blind.
3 or
Even
40.
we are false lumen, we pushing enough, we are no problem at all. So coming back,
1 second. We're just having some issues with our PIM, as usual. David, are you able to show the images or not?
can you come?
Is it?
If
Yeah,
impossible,
he's
it's okay.
trying.
Okay.
He's got some configuration issues right now with the PIM, but we're working on it.
Okay, come back. Come back. Okay, it's okay.
You know what? Let's do a rerun. Just can I hit a rerun? Yeah, let's do a whole run again.
Yeah, I think the point of this IVAS picture is next one is how to deal with the calcium. So the bunch of the place we are subintima and we are looking at the calcium from the subintima space. And recently we evaluate what is the key of the stent expansion where you are subintima. What is important is number one, look for the subintima calcium. If that is very consistent shadowing, that's bad calcium. But number two is the vessel size. Number three is the proximal intraplaque calcium, because that intraplaque calcium identifies the true calcium, and if that is big, we expect the subintimal calcium is big. And this case, with actually big calcium, it's not 300, but enough calcium. So I do expect this stent expansion into subintima is bad. I'm not saying bad, but I think we have to be careful, otherwise we are chasing the perforation.
Yep.
Sure.
Yep.
Thank you.
So from a prep strategy perspective, given that you've got dense calcium through that subintimal segment, but proximally it's not that bad. And
yeah,
Still, that's more than 180.
Yeah,
So we
yeah.
consider in the region should be larger because always the difference site is smaller than the maximum region site. So if that is our cutoff is 180. If the proximal intraplaque or proximal to the CTO segment is larger than 180-degree calcium, we expect inside of the CTO segment should be really large, and we really be careful.
Can IVL is useful in this setting for fracturing and stent expansion?
Ready, David?
So,
can I go? Can you take pictures? Yeah. All right. So Akiko, we are back. So here we are in the distal lumen. So you think a 3.0 is the appropriate vessel size distally?
So yeah, for sure.
Yeah. All right. So then I'm gonna. So this is the true lumen here, and then here we keep going back.
So you're in the PDA there.
Yeah. Yeah.
Right?
Exactly.
And you
then
can see little
here's
branches
the beginning
coming in
of the
on the
false
sides.
lumen. Yeah. And there's the false lumen starting right here.
Okay.
And then keep going, keep going. This is all that calcific subintimal false lumen in the knuckle segment. And then Akiko here was suggesting that we may have gone in and out, where she suggested that it might be some intraplaque wire cracking, right?
Yeah, a little bit distal. I may thought that's actually intraplaque. But anyway, we really couldn't understand how it is. So I think this calcium is very dense. So I think by looking from the subintimal space, I do consider this is very dense calcium. But when we measure the vessel size here, it's almost like 4, right? Our cutoff is 4. If the 4 at the subintimal space, actually more likely okay expansion. So
yeah, okay. So basically, take a 3.0 balloon NC, then to get a 3.0 stent, and then post dilate it, and then proximally go with a 3.5 or a 4.0, depending on how things go.
And
All right.
importantly, your proximal is.
Sorry, go ahead.
I think that, the proximal vessel will be an assessment after we get the distal secured, right?
40. Where's this? Where's this? Okay. Oh, really? All right. Let's test the retrograde test.
I guess it's interesting though. We look at the amount of calcium there, and the upfront plan was doesn't look like that's what you're going to need to do.
Yeah, wires come over the back. Yeah. All right. Yes, I don't think so. I agree with you. Just having a little issue with pressure, so I was just figuring out if it was the guide, but just had a little drop in pressure.
Sanjog, while they're working on it, Sanjog, do you want to just comment on, like, okay, you have the IVIS images, right?
Expansion, so long as you have a reasonable MSA. And that, I think, is what the goal is here, right? So as far as a prep strategy goes, there's nothing in here that's going to require IVL or really aggressive therapies within the CTO segment. Proximally, maybe, but we haven't really seen that in all that much detail yet. Yeah. And I mean, frankly, IVL in this scenario, I'm not sure it's going to be all that helpful because you've got a very distensible side. I think this is, the simple, straightforward strategy here is what has been taken, which is a simple long NC balloon where we observed full expansion and we move forward.
Yeah. Other comment was, I do think the cutting balloon, you have to be very, very careful.
Yeah.
We are sitting.
Yes, I agree. I've had some bad perforations with that.
We are sitting the adventitia. That's number one.
Here, definitely.
Yeah. Number two, in terms of the stent choice, we submitted some paper. If we look into the serial OCT baseline follow-up, and if we look into the only instant restenosis cases, we see 30% of the cases is actually chronic stent recoil. And the important predictor of the chronic stent recoil is calcification.
Yeah, for sure.
So asymmetric stent expansion, you are stretching only one side, you are more likely causing the chronic stent recoil. That's we are going to publish. So I think this case, once we go through, I recommend not super thin strut like the, So regular stent strut, that's, that's I meant.
Yeah, recoil I think is an underappreciated issue in the CTO space. We've been very concentrated on the distal vessel growing, But what we don't realize is that these long subintimal segments with dense calcification, where we've effectively gone around a solid tube, there's a lot of recoil there. You know, and I think those of us who do a lot of CTO work, we're all guilty of having pushed the stent too hard in that segment and blowing out the wall. It happens to us all, right? And so that I think the community has learned is probably a fool's errand.
Going up with a 3.5 now, approximately.
The comment here is, is IVL helpful in this scenario? In my experience with these, I don't find that because the idea of
if
that,
an NC balloon doesn't expand,
I mean,
other
if an
evidence
NC
of
doesn't
deep
expand,
calcium,
it's different,
yeah,
right?
yeah.
But if it does, what you're talking about then is fracking addressing a half of the vessel, which doesn't make a whole lot of sense to me if the other side of the vessel is
I'm
principally
not taking
distensible.
acute result. It is a chronic stent recoil. You can prevent by the IVL.
The problem is I don't think you're actually going to modify the segment to vessel that you've gone around with IVL at this point. Maybe later when there's a new intima and there's more structure on the other side, you can actually get that impulse conducted. But at this point, you're just going to stretch one side of the vessel and the impulses are going to go out that side, right?
Get a 4020 NC.
That's great. What size of NC was that?
No, this was a stent.
This was
was a 3.5. Now we're going up with a 40 NC approximately.
That's great.
All seems like everything's well expanded.
Long. Very long. Yeah. I guess the other thing, Akiko, to your point, is we don't have to, in most of these cases now, we don't have to aggressively size distally because the stent platforms are so hyper expansible now, right? Where you can realistically take almost any modern 3.0 stent to nearly 4.0, right? Recognizing that those are third generation, fourth generation DES where the struts are thinner. And so there is that stent recoil issue.
And the other issue
Here's
is
our 4.0 NC.
actually like the fracture things. This is very bending portion and calcium. That's really high. But we cannot
overstitch.
Perfect.
The other thing I noticed, Ashish, is that you've taken very few pictures, which is commendable, right? Like that's the point, is you're not ruining the vessel in front of you by antegrade contrast over and over. And from a retrograde perspective, you really don't need it.
What purpose does it serve? Yeah.
The only thing, arguably you might make the argument for is a picture when the pressure starts to get south. Retrograde to make sure you don't have an injury.
It's better now. I don't know. We think Roger's
we see that. We see that it's come up a little bit. I think I wonder if your retrograde guide was sitting on the aortic valve.
Might have been, but I don't. It wasn't the.
Or not retrograde. Sorry, your antegrade guide was sitting on the aortic valve because it's well backed out now, right?
Well, yeah.
Is the most common reason I think we'll see for.
Yeah, the diastolic pressure wasn't low though.
Yeah.
Down. I'm at a spot that I can at least take an antegrade puff and see what's going on. Remember to flush the guides, yeah.
Just for the audience, and just to reiterate what Sanjag had said, it's critically important when you use a dissection reentry strategy not to take pictures. I mean, especially antegrade, because his finishes stenting now is when he's actually testing it out.
Right, I'm going to take a cine.
You have to stent a bit more distally.
Yeah, little dissection distally, yeah. But flow is good. I think we're fine.
Yeah.
Eleocranial.
I think the issue was that your antegrade wire probably was subintimal.
And it roughed up the distal.
And it roughed up the distal, so you're just going to have to stent past that.
Yeah, I think you have to a little bit like.
You're just going to have to extend with another 12 or 15 or something into the PDA, which was a nice healthy landing zone, and that's that.
This is a good view actually that shows it.
Okay.
Yeah.
Everybody's saying that we need the image one more time. This started the stent.
Interesting. So that this tells you where that antegrade wire was.
Yeah.
And
exactly.
I would not be taking any more antegrade injections because you still have a track there.
Yeah. How about if I just take a 15 or an 18 millimeter stent distal to that? And
that's
deploy it. Yeah.
I think that's a good idea.
Yeah. And I just take like a 3.0 or even like a 2.5 and post dilate it if I have to.
Something gently.
How about a 2.5, 18, and then we'll post dilate it with a 3.0 NC.
I think
And you know, for what it's worth, when I get these sort of things, Ashish, what's your opinion on taking a just gentle 2.5 balloon inflation before you put that stent in to evacuate whatever's in that subintimal space? You've got all kinds of entries into the true lumen, right? You decompress the stuff that's in the subintimal space so that when your stent goes in, you're not, you know, you don't have these big collections of stuff that you're over. You get a little bit more security there.
What do you guys think of the segment in the mid right that looks?
That's we discussed. Meaning this view looks worse, but
Yeah,
the
looks
other
clearly
view
worse.
looks better.
Doesn't
I
look bad.
hope because of the stand was very oval shape. It's not like round shape. That's a typical picture.
Got it. Got it. Okay.
Niche put an expanded stent.
There was a question here, Ashish, about the use of cutting balloons distally to deal with those subintimal hematomas.
Sorry, what was it about?
I said Dr. Kaiser Nasrullah Khan was asking the use of cutting balloons in the PDA to release the hematoma.
I don't know if this is a hematoma. This is a dissection. If it was
agree. Yeah, I don't think. I think that was probably in and out from those wires. And you have exit points within the true lumen. So this is one of those things where if you gently balloon it, release whatever's in there, you stent over it, you're done.
Sure. Going up with our balloon here to just get my guideliner back in so I can.
And just for that particular question, if you're in doubt whether it's a dissection, whether it's a hematoma, etc. I mean, we were just talking about it. The easiest thing, you already have an IVUS catheter.
Just look.
Put it down, take a look,
100%.
confirm before you decide on your strategy.
You're going to have to IVUS those stents anyway, right? So you're not losing time.
Get us a new balloon. New balloon there. That's okay. Got it. It's gone.
Which one are you taking down into the PDA there?
No, this is just a balloon
just
to
track
get my
your drop
guideliner, draft liner down. Yeah. To all those stents. Wow. Down. Go up. Down. Get us a balloon now. A fresh 2.5 balloon. Fresh 2.5 balloon. 2.5/20 balloon.
I'm happy we came in a little bit early to you, Ashish, because we've got another 7 to 8 minutes left before we have to switch over. So I think that.
I mean, this is just finishing touches. I mean, I think the teaching points of the case were well illustrated and demonstrated and talked upon. So I'm happy that 1 hour is good enough for.
I think we're all excited to see your final result, though.
Yeah, we've sort of seen most of it.
Yeah.
Just a distal touch up at the end.
So what are you putting down now?
This is just a 2.5 balloon.
Yeah.
Like
just
in the PDA to massage it.
And massage it and open
Yeah,
up,
and then
decompress whatever's stuck in that.
Yeah, and then just make sure that the stent travels past that tortuous segment.
Nice. Yeah, that's right about there. Right? Gives you a nice measurement tool as well for how far you're going to have to go. Just gentle pressures down there. And
Yep. All right, I'll take a stent next.
I think he kept the pressures pretty low. There was a question about what the pressure was that you used with your 2.5. I assumed you were pretty low.
Just massage like normal, like 8.
8. Your pressure's back to very much normal now.
Yeah. Yep. Yeah, exactly. I don't know what it was.
Yeah, me neither.
Probably you're right. Something to do with the guide.
Either guide or because I mean, what else reverses that quickly? Maybe sedation if you got a bunch of sedation just prior.
Yeah, maybe. How's been the quality of the transmission? Has it been good?
It's been perfect.
Have you guys been able
to?
It's been perfect. You have a room entirely focused on you as you load that stent onto that really fun externalized wire. We've all been there too.
Yeah, which I'm struggling in the middle of the night here. Yeah, I got it. Yeah.
We all suffer there.
Yeah. It gets worse with age, Sanjog. Wait and watch.
That's funny. Oh, look at that track so nicely.
Nice.
That's great. You could even potentially you might get some filling retrograde. So you can see your distal edge of your stent. You might.
Yeah, but I'm not going to stand beyond this, even if
As
I
long
need
as
to.
you're
So this
comfortable
is
of
it.
where you are. Or maybe, I guess the
yeah.
point I'm making is maybe you don't have to go that deep.
But I'm already sort of committed based on where the previous stent is. So. Go on. Does Ajay have anything to say or add? He's quietly just watching, or is he left?
So we are covering the entry site of the distal hematoma, right?
Yeah.
So
Yeah.
I think even after this, distal looks small. It's okay because hematoma extends.
Yeah.
It'll grow. Correct.
But
correct.
that's why he took the 2.5 balloon up front
Yeah,
as well, right? Is
because
to try to
already
decompress it.
cover the entry site,
Yeah.
so that's it's here.
Yeah.
And I was in the first picture in the very distal is super normal, so I
Yeah.
think it should heal.
Yeah, that's great.
Yeah, there it is. Seems like
there it
it's
is.
better. Yeah, it's better. There it is. That's
There
the
it is.
branch.
There you go.
Yeah,
There's your
yeah.
PDA.
Yeah, exactly. So,
Yeah.
all right, I'm going to put the IVUS back down to look at that mid segment that Co was talking about.
Mm-hmm. We're all excited to see what that mid segment will look like because it's such a difficult problem to solve.
Yeah.
So for the audience, I guess everybody can see what looks like under expansion in the mid segment because that's the segment where he has extra plaque and around a very calcific segment of vessel. And the question is the MSA good enough? And even if it isn't, what do you do about it?
Yeah, that's the question. What if it's not? If it's
I
3.5,
gotta say,
then what?
You haven't. Hey, you didn't sneak in a post-deal balloon on us, did you? Not yet.
On the proximal, I did.
Proximal, he did.
But
No,
but
the
not
subintimal
distal.
space. All right.
No, not all the way where that is. Nope,
All right.
I have not.
I think the challenge is even if it's under, what are you
What are
going
you going to do about it?
Right?
But I think if he just using the stent balloon, we should post dilatation reasonably.
Yeah, no, I'm going to. But I just want to make sure.
Let's see. It's going.
Another disaster there.
Okay. Yeah, this is under, but I think.
Yeah.
Wow, that's super
Wow.
under expansion.
Very under.
Yeah.
Okay, so I think you should measure the even vessel to media and.
Yeah.
Okay.
And take 80% of that and go with the balloon.
Yeah.
Is that what you?
I think I expect you should be able to at least 3.0, right?
Yeah.
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 You have to.
Yeah.
And I mean, the RCA shouldn't taper all that much proximal to distal, right? So, so you have a reasonable idea even from your proximal vessel what the balloon's going to be.
Are you able
you
to
took
get?
a 4.0
Okay, so we'll take a 3.0 NC.
So yeah,
Yeah,
if
we've
you go
taken a
80% of that, a
4.0
3.0, 3.25 is going to do a good job.
Yeah, exactly. That's what I'm aiming to do.
Yeah, I mean, well, I think at this point he's just got large segments that are underexpanded there.
It's so crazy how it did not look like that at all on, again, like as we all see every day. The angiogram is such a
so Ashish, I think we're going to switch over to our subsequent presentations, but we look forward to coming back to you once you've got a final to show us. Though we, as you point out, we've seen most of it. And Joe, just once you're done, let us know, and we'll flip back over to you to see your final result.
Sounds good. Thank you.
Beautiful case. Thank you very much.
Appreciate
Great
it.
job, Ashish. I'm Dr. Srinivas Kumar here. A big round of applause
Oh,
to
hi,
all of the
Srinivas.
people.
How are you? Nice.
Thank you for all the help extended during the tough times of arrangement and all that. And at night time coming, we really appreciate it, Ashish. Thank you. We'll be with you if you want us to be back after these presentations.
Yeah. All right. Sounds good. Thanks again.
Beautifully executed case.
Yeah. Bye. Bye.
Great. Thank you.
Bye. Thanks again, Sanjog. Thanks. Bye.
See you in
Bye,
a few
guys.
minutes.
Bye, Arun. Bye, Arun. Yeah, bye.
Bye, Ashish. Great job.
Bye. See you.
Next two are going to be. Well, go back to the I know, right? Okay, so these are two of our live case inboxes. The first one is one that I did for a meeting called CAN CTO, which is a Canadian complex PCI meeting some years ago. Meaning last year, October. This was a 76-year-old with a history of a missed anterior MI. In 2023, he was treated in the Middle East at the time with ADHF therapy and ongoing medical therapy. Has the usual cardiac risk factors and came in with CKD stage 4. So his creatinine in Canadian units is 351. So his creatinine is roughly 3.3 here in India or in the United States with a GFR of less than 15. On the usual medical therapy, admitted with abdominal pain that was found to be ischemic in origin from a squeezed bowel. As a result of an inguinal hernia, they reduced that. He had acute decompensated heart failure, and then while in hospital, once he had recompensated, was getting chest discomfort, doing very minimal activity. His echo demonstrated a left ventricular ejection fraction of 12%. His anterior wall was thinned and akinetic. There was moderate RV dysfunction, mild AI, moderate MR that was posteriorly directed, and an RVSP of 63, with a viability PET done that demonstrated viability in the inferior wall and the infralateral wall, but no viability throughout the anterior segments. And so these are the angiograms. So this you'll see on the right was our target. This is the RCA. Okay. And oops, I'm trying to get it to show you then. This is your left system. Oops. It's always challenging with cases in boxes, right? So that shows you your left system. So this entire segment of the anterior wall is dead. The circ was alive but unobstructed. The inferior wall was ischemic and viable. There were retrograde septals into a PDA that gave an RPL system. And there was a proximal diagonal branch in a patient with an extremely poor left ventricular ejection fraction and the presence of pulmonary hypertension with an RVSP of 63 and a GFR of less than 15. So this was the hemodynamic support algorithm that we wrote for the Asia Pacific region a few years ago. And so in this gentleman, we took the time to define what his needs would be for hemodynamic support, whether or not we really needed this or not. So just calculating that together, his LVEF was 12, so he got 2 points there. His systolic blood pressure was actually about 100. As you'll see during the case, it gets pretty soft as soon as he gets any sort of medications. His cardiac index was less than 2, so we got another point there. He has renal dysfunction, that's 4. His age was, I think, in his 76, so he got 1 point there. So that's 5 already. He has neither severe AS nor severe MR, so he didn't get any points there. He was a surgical turn down, so that's 6. And then he's got a large area of myocardium at risk, that's 7, and he's got a complex CTO with a retrograde approach to the last remaining viable segment. So he was well into the strongly consider hemodynamic support range. I think objectively, the patient had very little reserve. We were going to obstruct his main retrograde conduit, and he had a long segment of RCA that was going to need to be addressed. We thought about doing this antegrade, but as you'll remember, we recognize that losing side branches in the setting of CTO PCI is really costly. And his RV function was okay, and this was the main RV branch supplying that territory. We really didn't want to lose that, and so going antegrade at this point was not our primary plan. I don't know if, Arun, you have any comments about that. Try that one on the table there. Yeah, there we go.
This is a really challenging case, to state the obvious. I think you'd be out of your mind to try and not use MCS for this case. I mean, pretty much meets all criteria, right? All the check boxes. The other reason was like this guy's one step away from dialysis. So one of the things, and when you're going through the whole decision-making algorithm, using that retrograde is going to really, really, really minimize your need for contrast.
That's right.
Besides all the points that you said, I mean, I would preferentially, I mean, you would work antegrade, obviously, but the ultimate strategy is going to be a retrograde approach for this.
Correct. So our plan here was retrograde CTO PCI, primarily using the septal as a retrograde conduit, using the diagonal as a marker for where the septal entry was. And to do this with an ultra low contrast approach, our contrast target was less than 10 cc's for the entire case. So we didn't take any antegrade pictures to start. We used the previous pictures from these angiograms, which were done weeks prior, to define what our targets would be. This is the CHIP score, the BSIS CHIP score that was published some years ago that defines sort of the upfront risk of in-hospital MACE in patients like this. And this gentleman's BSIS CHIP score was 9, so it gave him an in-hospital MACE rate of about 10%. So I'll just move forward here. This is the access for the Impella that we used. It's a single access approach. And this has some ups and some downs, right? So that's the 14 French Impella sheath, through which we use a micropuncture sheath to create a hole at either the 2 o'clock or the 10 o'clock position, put a micropuncture sheath in, and then put an 035 wire in. And then along that, you'll see this 7 French Trumeau destination sheath that we placed on that wire so that it goes directly into the Impella sheath, right next to the Impella, and allows you to limit your procedure to this access point plus one additional one. This guy didn't have much in the way of radial, so we ended up going bifemoral for this case. So you'll see that there's no bleeding with the wire out, right? And when you're putting this in, you have to put a little bit of elbow grease on it, but then once it goes in very nicely. And you've got about a 10 centimeter segment of the end of the sheath that is not hydrophilically coated that sits outside the Impella sheath. This unfortunately means you lose a little bit of guide catheter room though. And as you'll see, that becomes relevant because it's actually very hard to get adequate support when you have a guide catheter that's even on the borderline short range when you're in this sort of a situation, because you're losing a lot of length from the tip. And that's something that we tend to have to think about when we do these types of cases. So this is into the case now, where we've got a wire in the diagonal branch to tell us approximately where the septal is. And this septal, as you can see, was retroflexed. It was very difficult to get into, and because we weren't able to take any pictures, this took some time. And ultimately what we required was a Supercross 120 catheter, right? An angled microcatheter to be able to direct our wire tip retrograde into this retroflex, down this retroflex septal, but across that very noxious sort of 290-degree bends. And that was arguably one of the most challenging things to do. And as you can see, it was very difficult to direct the wire. And so from a sort of access point, Arun, do you have any particular preferences of wires that you use to get into these retroflex septals that are challenging, particularly when you can't take pictures?
I like the cyan blacks for this. I get good torque control. I generally prefer the hydrophilic polymer jacketed ones. And truthfully, I think we underuse Supercross. The traditional thing before it came about was you would use dual lumen catheters and try and do this. It's actually it's a lot easier for you to at least get access, get enough purchase, and then swap it out. So I tend to use cyan blacks. Do you have a choice of
so my usual one here is a cyan black. The only thing that's worth mentioning is the construction of a whisper wire is a parabolic grind on the curve, where on the core, where the core is thicker and more supportive towards the back. And it parabolically grinds down towards the tip. As a result, the further back on the wire you go, the less the wire will flex. At the tip of the wire, it's particularly well suited to go around nasty curves, though you want to switch it out shortly thereafter. I think that was my go-to in these situations prior to the cyan black. Now the cyan black with its Act 1 core polymer jacket is so good that that's usually what we end up using. And so as you can see here, we've sort of entered the septal that we expect to be able to access, and now we'll switch it around and bring your standard antegrade, standard retrograde 150 centimeter microcatheter in. This was a 150 Turnpike LP, and you can see the various curves being navigated. So bring that in, and then, and as you can see, this was a live case that I did. So it was a little bit of time pressure on this type of a case because you can't take pictures, and so a large part of the hemodynamic implant and such was done prior to going on camera. Because it's awfully difficult. What you'll see is I have a cardiac anesthesiologist helping me with this case, and so you'll see the vitals up on the screen. So you can see that we're monitoring the PA pressure as we go, and even on a hemodynamic support device at full flow, his PA systolic pressure is 63 on a PAD of 24 with a CVP of 8, and he's on sevoflurane at this point. He's on an inhaled anesthetic, which dramatically vasodilates. Despite that, he has very little reserve. So it sort of speaks to how these types of cases really do take a village, where trying to bang in with a single operator to try to just get the case done, I think is a good way to get your patient in trouble. So here's your sort of retrograde. Doesn't take much time. It's mostly a septal approach. I think I was pretty comfortable with where I was as I went down, and as you'll see, there you go, you're up into the RCA. It really doesn't take very much time to do that. But this is where the fun in this case started, where it looked like the septal segment was quite big, and getting the microcatheter across the septal was easy. It was what do you do after that's done, because that was the most challenging part. Once we got into the angulations that you were seeing, there was an awful lot of calcium down there, and so tracking the retrograde microcatheter became a problem. And if you look at the retrograde guide catheter, you'll see that it's pushing out, and that's because it's through the single access, right? It's through the single access. I've got the antegrade microcatheter completely disengaged, and that's because I do not want to encumber flow into that antegrade RV marginal branch, right? This is one of those reducing hemodynamic load strategies. Keep your guides disengaged if you don't need them, because all you're doing is introducing a fixed stenosis during that time. And so this was quite a challenge, getting this microcatheter down. And ultimately what we chose to do was, you'll see, we'll take that diagonal wire, push it down, and we actually put an anchor balloon into that diagonal, which is what allowed us to push this forward. But that's not without its jeopardy. And what we found was, as you'll see, when we put the retrograde, or when we put that anchor balloon up, we started getting a fair amount of pressure dampening and reductions in systolic pressure with reductions in pulsatility. And that just sort of speaks to how dependent this gentleman was on every single vessel that was open.
So could I ask you just a quick question as you're showing that? So typically, right, I mean, given his precarious hemodynamic status, yes, the patient was on an impeller. So, and you knew this was a septal, and you're pretty sure there was not an epicardial course. I'm assuming it's a turnpike?
Yeah, it's a turnpike
LP, right? Yeah. What is your threshold? So I'm sure you were thinking about the whole algorithm, right? Hey, wire across, my microcatheter won't cross the collateral. So something that both of us know that we often do is dilate with a super low profile balloon.
Yeah.
Why did you prefer to put in an anchor in the diagonal rather than just take this out, balloon, and then go back in?
To tell you the truth, it was at the time because I was already down with a microcatheter and I was in a live case, so I didn't want to go back and forth. Having said that, that's an excellent strategy, and I do it all the time. Right? I think, arguably speaking, in this type of a patient, I would probably do that before I would use an anchor in regular circumstances. Right? And I think eventually we did end up doing that.
That's right.
Yeah, we did end up doing that. So as you'll see, we've come to a straight RAO view because it's really easy to see exactly where the microcatheter is, where you can sort of lose it in some of the other projections. And you'll see that the retrograde guide is pushing out yet again. So this is when we started getting fed up with it and started putting anchor balloons down to try to get everything going, because it was just so difficult. But what we did was pulled the diagonal wire back, and we decided that we would try to put an anchor in. And initially we had considered anchoring in the circumflex. The challenge is that this was a relatively normal vessel. And the jeopardy is that your anchor balloon will dissect your normal vessel. And in this type of a patient with absolutely no reserve, we were increasingly uncomfortable doing that. So ultimately what we ended up doing, as you'll see, is I'm just going to push this forward, is putting the anchor balloon up initially in the diag. And then eventually we actually pulled that balloon down into pulled that wire down into the LAD, which was a largely non-viable territory. So we weren't really worried about hemodynamically encumbering the patient, and then put our anchor balloon in there. And that's where we ended up anchoring everything to be able to get the microcatheter across. You know, and admittedly, looking at this, Arun, would you have worried that microcatheter transit would have been a challenge? No,
No.
right? So I didn't think that either. So this just speaks to the importance of how your retrograde guide actually should fit.
I was just going to
This
say,
was all
I
a
think
guide
this is
support
all about
problem.
guide support issue here.
Yeah.
But guys, I do want you to pay attention in particular to how Sanjak's kind of manipulating this the torque and the transmission with one hand and with the other. I think India, predominantly the microcatheter that's used is fine cross, and that's more of a push thing. People don't necessarily torque it. So when you're using Corsair or Turnpikes, the way Sanjak's kind of using it is a much more efficient way of transmitting than just push the microcatheter. I know it's kind of basic, but I think that's an important point to note.
Yeah, the other thing is that this is a single operator maneuver, right? There are some people who will hold the wire at the back, and what that invariably ends up doing is just pulling your wire back, because you need the tactile feedback and you need the movement feedback and control of both segments as you transit the microcatheter down, because it will pull back on you as you get any sort of resistance. So this is that diagonal wire down the LAD now into that non-viable territory where I was a lot less worried about encumbering the patient hemodynamically. And here's where we ended up stuffing an anchor balloon down there, and everything started to move forward, right? So there's our balloon, and we push that across into the mid LAD, and initially I guess we anchored in the diag, and then later on you'll see that it anchors into the LAD there.
If you had to do this case all over again, would you flip the guides? Would you use your left femoral?
Yeah. No, so the reason why, this is a good question. The reason why I went this way is because I did not have the right guide to reach the RCA through that single access. That was the problem, right? The problem was actually, I remember this was at 6 o'clock, 7 o'clock in the morning on a Saturday for a live case. It was challenging, and we of course were super lucky in that the one guide that we needed for this, it had been used the day before and we just didn't have it in the lab. So it was a real pain. So as you can see, we've sort of transited our microcatheter, and there's our retrograde Xi'an black. And interestingly, it's sort of flipping back and forth. You'll see that with the ability of or with the microcatheter in that position, it's actually really easy to manipulate that retrograde wire. And the nice thing is here that over the course of this case, so far there has been 0 cc's of contrast used. Right? There's just no need for it. You have wire structures with the wires in front of you. You know exactly where you are. You have the previous pictures, and you have hemodynamic stability, relatively speaking. So you just match the views and off you go. So this is in an RAO view. And you see now with that anchor balloon present, the guide catheter is not the happiest position. But there's my retrograde wire. And it's always nice when you get lucky. Oops. I'm just keeping an eye on the time, which is why I'm advancing us forward.
Take all the time that you need. My case is a short one.
So this is just a Xi'an black, and there we go. We're out, right? So there is no antegrade guide in the RCA at this point, because again, we were trying to reduce the hemodynamic load, and when we would put the antegrade guide into the RCA, his pressure would start to drop. I think Akiko might or might not remember the live case at CTO Plus that I did there, where we had the same problem, where we touched the RCA with the antegrade guide. You'll remember that as well, actually, right? Where we basically lost pulsatility completely. My case had a left main LAD, occluded circ, diseased right with an EF of less than 20 in a post-bypass patient, and we just put the antegrade guide in and his pressure would tank. So we had to keep it out. So as you can see right at the top of the screen, just under the word January, that's where my antegrade guide has been sitting the whole case. So we'll bring that forward now with a J-wire, try to engage it, and then try to wire out retrograde. And this you do have to be a little bit careful of when you have an impella in the aorta, because as the antegrade guide comes down, you can hook the end of the impella, and that can knock it out of place. So you do have to be at least reasonably aware where your wire is going, and try to make sure that the wire doesn't actually wrap the impella, because if it does, then you will create forces on the hemodynamic support device that will get in your way, and that you don't want to do. And so my usual setup for the antegrade is very similar to what you saw with Ashish a few moments ago, where I'll put an antegrade trap liner in. That's also been recently introduced into India. Has anybody in the crowd had experience with a trap liner here? So it's effectively the same as the guide liner, only it has a trapping balloon on the shaft, right? I know, Arun, I think you probably launched that device here, did you not? Yeah, this is a very useful device. It was invented by Chris Buller, whom I had the privilege of training with as a fellow. He's now the chief medical officer of Telflex, but it was a very simple invention. The idea of putting a trap balloon that we all know how to use just on the shaft of the guide liner, so you don't have to keep transiting in and out with a trap balloon. And that works extremely well to be able to trap and exchange microcatheters and other equipment without losing wire position. So here I have this antegrade wire, or the antegrade microcatheter engaged, and the idea will be just to create a glove into which I can throw the retrograde externalized wire. Right, and that's effectively what we're doing here. So I just put the antegrade microcatheter down, pulled the retrograde wire back, which is currently out in the aorta. We'll pull it back, and then we'll just throw it into the antegrade guide extension catheter. It allows us to get the whole deal done. Now, unfortunately, in this situation, we had externalized and actually pinned the retrograde wire inside the trap liner. So we had a really solid system, but surprisingly, we were unable to breach the distal cap of the microcatheter. And we tried and tried and tried, and I actually took this microcatheter out and replaced it with a new one, and it still did not want to transit, which is why at the bottom you see there sort of failed microcatheter transit. This is one of my colleagues, Dr. Vlad Javik, who's a well-known operator, I think, in India as well. He's done a lot of bifurcation training here for some of the people here. And this is the benefit of having two operators in some of these cases where, your hands get tired after a while, right? So you swap out with somebody and allow them to try. And unfortunately, Vlad also tried to get this microcatheter up. And as you'll see, we weren't having much success, even though there is an anchor balloon up in the LAD. Right? So really struggling with a variety of different strategies. So Arun, what's your strategy in these sort of situations, recognizing that you're trying to preserve the RV marginal branch that's basically coming off right there?
I mean, you already have the wire you have the externalized wire, just come antegrade. I mean, just.
Yeah. So what you just heard was you've got a retrograde externalized wire. Ideally speaking, you'll be able to transit your retrograde microcatheter up. The challenge is if you're repeatedly having difficulties doing that, you have the perfect marker and a track formed to flip antegrade and try to just use the retrograde kit as a guide to get your antegrade wire down. There is jeopardy in that you don't, Kiko was there when the CTOs were collected for that paper that defined your in and out, so your true, false, true a quarter of the time when you think you've gone true to true, right? So recognizing that there is that danger of going across the subintimal space with that RV branch that we've been trying so hard to preserve, we have a reasonable guide here and we know exactly where to go. So as long as that wire can transit through effectively the same segment, your risks of that are going to be relatively low. And that's exactly what we ended up doing, where we ended up bringing this antegrade wire. And that's a Raider wire, right? So core to tip, polymer jacketed, mid fours, I believe, tip strength, and directable. The core on a Raider goes right to the tip, so it's a slightly larger knuckle than you will get with a Pilot 200, much larger than you would get with a Mongo if that's what you chose to use, but it does a very nice job of wiring antegrade, as you'll see. right? And so here we brought a turnpike spiral down antegrade so that we were fairly close to the retrograde microcatheter. And then it was just a matter of directing the antegrade wire down the pathway that we were trying to select for it. It's with a lot of care, trying to make sure that it doesn't buckle and that you're not pushing yourself to go into the subintimal space, because that's going to cost us. And that's effectively what we ended up doing, where we wired just past the retrograde microcatheter, as you'll see in a second. And there's your radar wire starting to get close to the antegrade, or the retrograde microcatheter. And here it comes going past. And are you a torquer guy? Do you usually use torquers with polymer jacketed wires?
Polymer jacketed, generally not, but
Generally
I sometimes do it, sometimes
Yeah.
I don't.
It's sort of one of those things where, like, I typically don't, unless I'm in one of these situations where you really don't have a lot of room for error, and then you're using more than just the properties of the wire to be able to get the wire down. So here is that bit. And it's a lot of disease there, right? So the wire wants to take a variety of different pathways, which I was not particularly happy with. And then you see the wire now start to enter the space that's parallel to that retrograde microcatheter, and there's your wire going down. And this one just sort of flew across. And so now this became an exercise in doing IVUS guided PCI, right? There was nothing all that complicated about this. And once we had an antegrade wire down, we IVUSed and confirmed that we were antegrade, and we're very aggressive about getting the retrograde gear out, because once again, we wanted to reduce that hemodynamic load. As you can see, the patient's PA pressures are still pretty high, though they're a little bit lower. And it's, a lot of times doing these long cases, you think that the PA pressures are coming down. That's a good thing. It's actually not necessarily a good thing. It just means the patient's getting a SIRS response and getting vasoplegic, and that's why your pressures are coming down. And usually the hallmark of that is that the CVP starts to come down with it. The other differential that, that one always wants to consider when an Impella is in place is that you're bleeding. And if you're bleeding, you do get into a lot of trouble. Your PA pressures will come down, but so will your systemic pressures. And here we were encouraged because we weren't on a ton of vasopressor support, and our systemic pressures were about the same, with a heart rate that was about the same as throughout the case. So just tracking that forward for you. At this point, we had done the IVUS. We did some ballooning. And I'll show you the IVUS towards the end, unfortunately, because of just how the video has been edited. And there isn't a whole lot of magic here at this part. It's just simple IVUS guided PCI. You see that the technique that we used to define the ostium, which we needed to stent, was a cusp wire, and a fluoroscopic co-registration of the IVUS lens, which I'll show you towards the end. And every so often we'll clear the guides with saline to make sure that, as there's not a lot of back and forth, that we're not allowing clots to form within the guide. There's your sort of cusp wire, post-dilate. And then when we did the IVUS, we saw that distally we had a good amount of plaque. We did not want to stent that distal edge. And so what we actually ended up doing was choosing to put in a drug-coated balloon distally, and using the IVUS to size it. The EEL to EEL diameter was just over 3, so we actually sized down a little bit with our DCB, because we did not want to run the risk of dissecting the distal edge, recognizing that with DCBs, type A, type B dissections tend to heal larger than with a non-dissected vessel. We just couldn't use that much contrast, so we're just not willing to do that. And so the only picture of the case you're about to see, which is after everything has been fixed and reconstructed, and that is here.
Nice.
That was your
Strong
final
work.
That was your final result. And the total amount of contrast used for the case was just under 10 cc's. It was 6 cc's, and it was that final picture. Right? And I think I gave him another, I don't know about you, but I gave him, because I did the inflations for anchor balloons, I gave him another 3 cc's to look at the left system to make sure that there were no injuries in the left system. And I have a Kiko here, so I would be remiss not to show the IVUS. So this was after the case was done, as we were presenting the final results to the group. This was the IVUS. Sorry, Kiko, I'm going to show you the final edge there. I don't know if it got edited out, but there.
There you go.
So this is the distal vessel. This was all the DC bead segment right here. This was all DCB. And you can see that there was no substantial injury there. It was actually a really nice DCB result. It was very circular, very well behaved. And you'll see that the stent, this is the stent distal edge. And these were a bunch of synergy stents that we put in that were conservatively sized distally, but then we expanded proximally to a reasonably large size. You can see proximally there were a little bit undercooked, so we did make that bigger before we ended the case. Right there. And this was just to show the final result. And so that was our ultra low contrast retrograde CTO. Right. Thanks very much.
It was a fantastic case, very well demonstrated.
Okay.
We have Dr. Kaparthi. Any comments at all? Like so, just. Oh, Dr. Akiko. You guys should just come up here. It's like just feel
please
lonely.
just sit here.
What's happening afterwards in the patient?
The patient did well ultimately, but you bring up a very good point in that I was actually, this was a Saturday, and I took over the ICU on Monday. So I had to take care of him, and he was in the ICU for 6 days before he went. And that, we have some data actually to talk about that. So this is about the number of loss of pulsatility episodes while on hemodynamic support devices during high-risk PCI, where when you go past 3 loss of pulsatility episodes, that is 3 episodes where you lose pulsatility and you actually flatline out where you become device dependent on that side, your ICU length of stay goes up, it doubles. And so we ended up having to keep him in the ICU. He was in the ICU for almost 7 days. And there was one point at which we were worried he would actually end up on dialysis because while in the ICU, classical ICU complications, he got an infection. And so it took a few days to get him out of that. But thankfully, he managed to get up onto the floor after about 7 days and got out. I don't have a follow-up echo, unfortunately. But the nature of these cases is they're never done until the patient leaves the hospital. And the ICU course almost uniformly for these high-risk PCIs for the first 48 hours is rough.
That's a fantastic question. I do have an add-on to that. Like, so typically with protected PCI, right, the general mantra is like, okay, finish the PCI, get the thing out. Especially, I would say in India, where you know you then have to send them to the ICU. Not all the staff are comfortable managing Impella. You're trying to avoid like 1 a.m., 2 a.m., 3 a.m. calls. What is your weaning protocol really? Like when do you take it out? I mean, this case, I assume you left it in, right?
Definitely
for a while. So what are some parameters that you use and how do you?
Yeah, great question. So the truth is, if you're in a center that does not have a critical care doc or you are not able to support Impella weaning while the patient is in the ICU, don't do the case. Don't do the case. Refer it somewhere else where they do, because you'll kill the patient. They uniformly, like the first 2 days are very bumpy. You're riding right atrial pressures of 0. You're giving them 3-4 liters of fluid to manage their fluid status for those first few days while their heart doesn't pump, where you started with an EF of 12 and you left with an EF of 5. But they do roar back after about 18 hours is when their SIRS response goes away. And with the pump still in, all of that extra fluid that you've given them to buttress their vascular tone, as their vascular tone comes back, you end up reducing that. And uniformly, the creatinine actually, when you go in high, it comes down because they've got much better forward flow and you've managed to flush the kidneys with cardiac output that it hasn't seen in months. When you're weaning, what you're looking for is low to no inotropic support. Typically, I tend to keep them intubated during that period, though there is arguments to extubate them early because we've all been bitten by VAPs in the ICU. The reason I keep them intubated is because I'll remove the Impella at the bedside and that hurts. And so when they start bearing down, it becomes hemodynamically tenuous. So you're off inotropes, you're on minimal vent settings, you're at P2 or P4 for at least an hour with no rising lactate and no dropping PA saturation. And now with a CP Smart Assist in place, you go to the LV EDP and CO output trends, and what you're looking for, so on that screen you have 5 curves actually. The top curve is a red line, that's your mean arterial pressure. You want that to be fairly consistent. That's sort of 10 minutes of data, and that's a lot. You have an LV EDP that will give you an idea of what your intracardiac pressures are, and you have a total cardiac output. The total cardiac output is the machine's output plus the native output. And so when you turn down the device, what you want to be able to do is look at those trend lines. And what you should see is that as your pump output comes down, your native cardiac output should go up, not stay the same, go up. Because these types of pumps work on something called the HQ curve, where if the heart failure docs in the crowd will understand this, right? Where if you are removing blood from the same place as your LV is pumping it, the less functional the ventricle is, the more function the VAD does. So if your LV is pumping well, your VAD is not going to put out very much blood because the LV is doing most of the work. So as you reload the ventricle and give the LV back volume by reducing your VAD flow, your native heart should be pumping more and more. If it's not, it means that it is failing to keep up with the load of blood that you're giving it, and you're still stunned, which means you've had a wean failure. So you go back up, you wait another day, and you come back the next day.
Brilliant. Thank you. Dr. Kapar.
Thank you. Thank you,
Dr.
Dr. Sanjog, regarding your excellent presentations. But retro collateral entry point, how you have taken the supercross and how you crossed this one, and what is the need of this backup support of the guiding catheter for the retro, and then anchor balloon technique you beautifully demonstrated. So your routine workhorse fire for retrograde is cyan black?
I like Xi'an blacks. This is, sometimes I'll use regular Xi'ans, but honestly speaking, I shouldn't admit this out loud.
Cyan
but yeah, most of the time I use, I mean, I started CTO PCI like you did before Xi'an black was available, right? So my epicardial wire of choice, my retrograde wire of choice before Shuo 3 and Xi'an black was all just a regular Xi'an. Right now with septals, I use a Xi'an black because it, generally speaking, is very easy to surf with or deliberately wire with. But admittedly, every so often the Xi'an blue will go through, and you're not going to take it out, right?
Well, what is the incidence of that injury to the collateral with cyan black?
Yeah, so with a Xi'an black, I think when you're using a surfing approach, there is a danger of injury to the retrograde collateral. Generally speaking, in the septum, those are inconsequential. You don't surf epicardials ever. Okay. With these types of cases where if I'm not getting success fairly easily and quickly with a Xi'an black using a surfing technique, I'll take a tip injection through the retrograde microcatheter, define the collateral, and then wire it. But I typically use the same wire.
Okay.
Because it's the same Act 1 core, it's the same tip strength, slightly less actually, with a polymer jacket. So there's really no downside in using it in that circumstance.
Okay. Thank you.
Again, Sanjog, thank you so much for that. We're going to go back and see what Ashish has done.
Hello and welcome to TCT South Asia 2024.
Just before we do that, let's jump back over to Ashish and see if he has
that's
a
what
final
we're
result.
doing. Yeah.
Huh?
Yeah, we're going back to Ashish.
Yeah. So can we see, can we go back to the Zoom link, please, to Dr. Prasad?
There.
Oh, awesome. The fact that the clothes are off is a good sign, Ashish.
Welcome back.
Welcome back. We can't hear you, though.
It's almost good. Yeah, so this is our the inflation within that portion of the stent that was all underexpanded and not looking that great. And this is a 3.5 balloon. Then this was just an injection in the retro to make sure that there were no collateral damages or any issues with the septal before I got out of there.
Is there something up in the LED?
This was a picture after the guideliner was taken out, and
Nice.
you can see that there's some proximal haze, and there was still pressure dampening. We never really IVISed that segment because we had the AL1 in, and the guideliner was there as well. So I wasn't happy with the way that looked. So I put in a 4.0 stent proximally. You can see that in this view as well. It's clearly pressure dampening. And this is that other view that now looks at the segment in the mid that had that stent deformation, but it looks like it's just expanded and spiraled, and you can see we're in and out. But the vessel itself looks okay, and the repeat IVIS looked like the adequate CSA was more than 4.5 throughout the whole segment, and at almost 5 actually. And then this was after we put a 4.0 stent proximally to cover the ostium. And you can see flow is good. Vessel looks pretty good. This is the other view. and you
Akiko,
can see that the
you
PV is
mentioned an important point about the distal vessel in this situation. Can you make that again?
I can't hear you, Sanju.
Yeah, Akiko is just going to make a point about the distal vessel that she made before, just to reiterate.
I think like when you finishing the mid stent, we see the decidual disease, and actually we didn't entirely cover the hematoma which you make in the antegrade wire. But third stent which you put in the distally, you cover the entry site of the hematoma. You didn't cover entire because of this, distal looks like funny. But I think those are normal segment and those are already entry site was sealed. So I think that's going to be healed and grow up more. And additionally, you make a very good point for the proximal portion. Whenever you do the CTO, many times I see the proximal portion was almost like the strange or like the dissected. So checking the ostium at the end of the right CTO is super important. And what you have done, additional stent in the proximally, is perfect.
Thank you. That's beautiful.
Thank you. Guys.
Congratulations on a great case.
Congrats.
And fantastic demonstrations, Ashish. Thank you so much to you, to your team, for coming in so late at night on the weekend, and we really appreciate you being part of this group for us.
Thanks again, and wish everybody well, and give my regards to Srinivas and all the organizing team.
Thank you.
And thank CRF as well for organizing this in India. Thanks again. I appreciate it.
Thanks so much for joining us.
See you, Ashish. Bye.
Have a good night. Bye.
Okay,
Ready?
and so for our second live case in a box, Dr. Arun Kalyanasundaram, who requires no introduction for this crowd, will present to us his case of ADR.
Okay, so a couple of disclaimers. You guys saw a really complex case. Here's something that I'm pretty sure most of the interventionalists here probably do. Yeah, let's just go. So this is pretty much a short case. We wanted to do a...
Hello and welcome to TCT South Asia 2024. We're honored to be part of the conference, and I'm Dr. Arun Kalyansundaram from Promotional Hospital. This is Dr. Anand Manjunath, our very seasoned associate interventional cardiologist, who's kind of like my right hand. This is a 44-year-old female patient with diabetes who had an anterior MI about 4 years ago that was taken care of percutaneously. And
you can mute it. I'll just talk. I think the audio isn't particularly clear. So this was kind of a young woman in her 40s, essentially, who had an anterior MI about 4 years ago. Came to the hospital, had her LAD taken care of, and then just disappeared. I had actually emotionally invested a lot in this patient because this was right when I had started my hospital. She didn't have money, so we did all this stuff. Got her husband a job, but then she wasn't there. And then, of course, lo and behold, she came back after she had a lot of symptoms, and there was she had a diagnostic angiogram done, which showed, thankfully, the LAD stent was still okay, but she had progression in a circ. She had a tight ramus, and she had the RCA CTO. And until we did the dual angiogram, it appeared to be a longer CTO segment. And that's the first thing that I really want to emphasize on is on your angiogram done through the radial, and then they ended up really messing up the radial too. It really didn't appear that the CTO segment was that short. Turns out that it actually was. So I went in prepared for, okay, this is going to be war, and we have to do I need good backup. She was kind of a smallish woman, so I went bifemoral. And so I went with my usual amplats, and I think it was an XP35 on the left side. I couldn't really engage it because anytime I engaged the left main, it was dampening. It just seems like it was a smallish woman. The ostium itself didn't seem diseased. So my plan was this was kind of the day where Ujjwal and the team were coming. So it's all right, I'm going to do an ADR case, hopefully, and then ensure that she is going to take her medications, etc., then bring back and address the left side system, etc. They also had severe financial issues. So actually, I did say that on camera here, but I just muted it because the echo part. So I have a lot of appreciation for what people in our part of the world do, just because I think money many times is a real concern. So my plan was to essentially get this going with with an anti-grid approach. So the usual stuff: take a microcatheter, take a workhorse wire, get to the proximal cap. And I'm going to stop there because my case is like super short, like I said. So, number one, let's just go to the basics. Your choice of guide. In general, with ADR, what is your guide of choice for the right?
Yes, the antegrade guide of choice for most CTO, I think, in the right is an AL. So you have some back wall backup. The exception is when you have osteal lesions, right, where you really have nowhere for it to sit, in which case sometimes you just don't have the ability to do that. In which case you can take a JR and then Amplat's a guide extension catheter. You need a little bit of push to be able to deliver re-entry balloons and such as well, so an AL is helpful.
Yeah, I don't think it's a good idea for you and me to be talking because we pretty much think alike. So no, but like anyway, I think the point is very well taken. My go-to is the best AL guide that I can for the RCA because guide support matters. I still tend to do a fair bit of ADRs, and from it's you live or die by your guide support, and you saw that even for Sanjak's case,
that's really
the
true.
guide support comes back to bite you, right?
Yeah.
Had a turnpike, got to the proximal cap, and I'll just play that first image. I guess this was a dual angiogram. So, what would be your initial wire of choice?
Interesting. So looking at this dual angiogram, I see your proximal cap is right at the level of an RV marginal branch.
Right.
Right? And you don't want to lose that branch. That's a decent sized branch. So I would probably put a wire in that branch. And then I might have considered 2 or 3 different approaches. One approach could be a side base to get into the subintimal space, given that my upfront plan is probably going to be an ADR here. One plan is to just IVUS from that branch back to see if I can actually define the proximal cap. In this view, it looks like you can actually see just a tiny lip. And if you can, then you can even use a Gaia to try to cross antegrade if you're lucky. If not, you do a side base or an IVUS guided proximal cap puncture, get into the CTO segment, dissect, and re-enter.
Again, fantastic points. And I think Akiko is going to hate me because this was a day also when our IVUS, which is actually integrated. So we're there with the recording and everything. They were like, "Oh, we this needs to be serviced today." So I don't have IVUS images for Kiko. So just also saying that for the record. But I thought I could see, I actually took the second approach, which is, I was kind of debating if I should protect the RV branch, but I'm like, nah, I think I can probably penetrate. I thought I could see the proximal cap, so I basically went in with a turnpike and Gaia. I think Gaia 2 next. Why Gaia 2 next? I could have gone with Gaia 3 next. I mean, I just picked it because it was there.
Do you use a lot of Gaia 2?
No, I don't.
I basically don't have it on my shelf anymore because the only time I'm ever going to use it is.
Here's the thing: we had some supply, and usually my go-to is like when I take wires. Like for example, I don't have Conquest Pro. I have Conquest Pro 12. I have a lot of Gaia 3 necks, but sometimes it also means that the Gaia 2 necks don't get used at all. And here, I didn't think I needed a lot of
that much.
So it's kind of like I think I can do.
I almost took them off my shelf actually because I just don't find them useful anymore. Either I'm going to use a Gaia 3rd or I'm going to use a different strategy.
Yeah.
Right, and we use a lot of Judo 6 as well, which is a more difficult wire I think to get here. It's not introduced here, but it's a similar 1-to-1 torque control fused core to the tip wire, which gives you the same sort of effect as a Gaia, but you get some tactile feedback because the tip is fused to the core.
We don't have it here yet, so
it'll come.
So let's go back. So initially, Gaia 2 next and a microcatheter. Oh, that was the workhorse wire coming out and the Gaia getting in. And I'll just let this play. I thought it was making progress, gonna sail pretty fast. Oh, that might, okay. I might need the audio. Okay, hold on. I'll just see this picture and then tell you what wire I did. okay, this is a different wire. So what I did was the Gaia 2 Next wasn't making a whole lot of progress. I was kind of like, was getting some resistance towards the distal cap. So I jumped from there to a Conquest Pro 12. The issue with the Conquest Pro 12 and going long distances is that you have no idea. It's like, oh yeah, it feels really good. No resistance. It goes, right? It goes. But it can go anywhere pretty much. And that's what happened here. So what I did was I got, my plan was, okay, this is a short enough segment. And again, just because it's a live case and I was asked to do ADR doesn't mean I should do ADR. I should do what's right for the patient. And that's something that I, think we got into trouble enough for live cases and all this other stuff. So I redirected to the CP12. I thought I was in a more favorable position at this point. And again, check in an orthogonal projection before you move your base of operations. So generally, your wire can move. Just don't move your microcatheter until and unless you're sure about the position of the wire. So assuming that your wire is where it needs to be, and then advancing the microcatheter is a bad move because you're just going to create a much bigger hole following the wire. Okay, so here seemed okay, and I'm trying to advance it, and boom, I just lost it.
Oh, dear.
So I had to make the case a little bit interesting. So then I select, okay, ditch this guide. I actually went back to it. I actually took a JR4.
That's exactly what I would have done. That's exactly what I would have done. Just because the way it was sitting, your AL was not providing you what the AL is supposed to provide you, which is back wall support.
The AL,
yeah, the aorta sometimes are small.
Didn't do what the AL was supposed to do. So once again, workhorse wire, same microcatheter, and I took the same wire that I used initially, which was the Gaia 2 Next, went back. This wire was a bit beat up. I tried first with just my fingers, couldn't really get it to go, so I actually ended up using a torquer for a little bit. But then here I was, it was actually, I think, doing a much better job of intraplaque tracking as it ought to. Pressures were fine, life was good. She was a bit anxious, but it's all good. Advancing your microcatheter, something that you can do, right? Like, see, oftentimes when we say, okay, I don't have enough penetration, one option is to take a wire with more penetrative force. Another option, and actually a cheaper option, if you know for sure all you need is penetration, is to move your microcatheter further down towards the tip of the wire. That will increase your penetrative force significantly. And that looked pretty good. So yeah, I mean, this case, like I said, was...
You know what they call a short CTO? A good CTO. There's just no good reason to make these cases longer than they have to.
Yep, no, it's
great.
Thank you. Yeah, the other reason I muted was I kind of said some stupid stuff on camera. I'm like, man, I hope it goes subintimal. But then again, it's what's right for the patient, really. That's what it's about. And even with the JR4, initially the microcatheter was stalling a little bit, but, I could just advance. You can push your wire further down. The key is, if you know for sure you're within the vessel, don't keep spinning it and pushing it, just push. And if it's tracking the vessel, generally it tends to stay inside and not go intraplaque.
What was your antegrade? What was your microcatheter antegrade?
Turnpike.
Regular or spiral?
This was LP.
LP.
And so you just advance your microcatheter. Once again, you'll notice that we tend to torque these. And with Turnpike, clockwise actually works a fair bit, but again, you can go both ways. Exchange for a workhorse wire. And now, honestly, the rest is not even as interesting as the last case from a PCI standpoint. There's no IVUS images. So the key is what you do at this point is a couple of things. How much do you stent? What do you do, right? So you want to prep it. And in this case, I was like 99.99% sure I had not gone subintimal. So I did take an antegrade image. Also, the fact that I didn't have IVUS at this point. So I said, all right, let me see what I'm dealing with. And so what essentially I did was pre-dill, one long stent, This is a 48 Synergy XD. It actually delivered really well. Stented it, and now it's like, what do I do about the distal part? And again, this patient, yeah, the issue with this patient was I really wasn't sure how adherent she was going to be, how good she was going to be with follow up. Said all the right stuff, like, I'm so sorry that I didn't come, blah blah blah. But I was worried because the more metal I put in, and then let's say she stops the medicines for whatever reason, I was a bit worried. So basically, what I did was kind of a hybrid approach. I said, okay, so I balloon dilated the distal part, and I think I used a 2.5 NC, and still had some lesions. So I just ended up using a DCB. I should thank the sponsors because I got the stent in the DCB free of cost. So that was good. So it's like, okay, getting a free DCB, might as well use that for this patient, right? So ended up,
good for the patient.
once you prep the vessel, so the key with DCB, again, I think most of the operators here are pretty familiar with that. Definitely prep the vessel. Your DCB, although it's a balloon, but it's really not a balloon, right? You want to prepare the bed pretty well so that you have good uptake of the drug, and don't try to cut corners there, and don't say, all right, I'm just going to take the drug coated balloon directly without prepping it. Tip at least a 1-to-1 NC. I've also done many times cutting balloon prep, and then here I didn't. I just used an NC and it was okay. And then I think I put in a 2.5. Once again, the same thing that Sanjog said, like I wanted to avoid a dissection. So even though the vessel was probably a 3.0 at least, I just used a 2.5 long DCB. So I think the DCB comes after this. So this was the post balloon. And the DCB was from the distal edge of the first stent to wherever it goes. I took the longest 2.5 I had. There, that's the DCB. And that was the final result. So my plan in this case, really, like in terms of what happens later, is hopefully she's going to take her medications, she's going to keep up her follow-up appointments.
Gorgeous.
And then we'll deal with the ramus, and she also has some moderate circ. At that time, hopefully, IVIS the left main distal part just to ensure that there's nothing there. I didn't think it was high grade for sure, but at least before we start messing around in that part, I think imaging is critical. So that was that.
Lovely case. Okay.
So yeah, this is just me kind of going over the case, but that's pretty much it. Any questions? I'm sure like most of the operators here can this is not a difficult CTO. Right, we went in with option A, which was antegrade wire, and that thankfully worked. Didn't have to do anything fancy, and whatever works for the patient.
Great case, man.
Anything?
Congratulations. No, it was a lovely case.
Okay, good.
Thanks, everybody.
Thanks,
we'll
and simple.
This session
Bye.
Here.
Thank you. Hope you like that interesting live case and then live in box cases. And Sanjog is good at it, and moderation was excellent, and the case result also was good. Now we go on to this interesting. We have wanted to have mix of both structural and coronary things, and that's how I mix it up in both halls. Now we are mixing both structural and coronary as such, because this session is TAVR and coronary artery disease session, where you find patients with AS as well as coronary artery disease, and how to tackle such scenarios. We wanted to present 2 cases, and we requested Dr. Sai, also is an authority in TAVR and has experience in coronary, also to be talking with me in this session. I think Dr. HICC Gokhale sir was supposed to come. I don't know whether he's stuck in surgery theater. Dr. Rath is not there. Dr. TNC Padmanabhan, Dr. Trupti madam, please come. Dr. Padmanabhan sir, please. The other panelists in this, Dr. KMK Reddy, Imamuddin, Gaurav, Satish Kanumuri, Pratik Chaudhary, Bhatia, Shobha Zaman, whoever is there, please feel free to come over. And Dr. Aditya Kapoor sir is here. think we are going to present in this is tell you briefly about interactions of coronary artery disease as well as aortic stenosis, which I'll present. Then after sometimes now it becomes more and more common post-TAVR patients coming with CAD. What are the tips and tricks to do PCIs in that, Dr. Sai Satish? Sai, can you come over the stage? Dr. Sai was here. Okay, I'll start my talk by the time I think he's loading his slides. Yeah, good afternoon, friends. Basically, what we wanted to do was to give you various scenarios of coronary artery disease and severe aortic stenosis. So presentations basically sometimes could be ischemia based or sometimes could be heart failure. That is predominantly what we decide upon. But you could have left main disease, you could have different type of diseases presenting with heart failure, and something could be also single vessel disease. I wanted to present 3 scenarios and we will have some discussion. We'll have very brief presentation followed by about 5 minutes discussion interaction and then tell you finally what we did. This is a 69-year-old male patient, diabetic, hypertensive, dyslipidemic, hypothyroidism, and then had a severe degenerative aortic valve disease. But if you see the history is post AVR 2009. Sai, can you come onto the podium? So we had a bioprosthetic valve degeneration and presented with severe AS and LVF initially. And we also had STD changes. We thought it could be atrial fibrillation induced associated ischemia. Patient was stabilized later. Then LV function improved better. So it could be ischemia or it could be of AF related. And then we thought it may not, because coronaries were normal in 2009, we thought it could be all severe AS. We got a CTA by TAVI protocol. Then as a protocol in those days, definitely we used to do angios also. So angio revealed left main bifurcation disease. So once we had this sort of disease, see this, these are the dots of the previous bioprosthetic valve. The distal left main stenosis tight. This is another view shows in elevocaudal. Then this is again long segment disease in LAD. Then when we found this is tight disease, so we rediscussed with the patient, and because he has both elements now, both CABG and valve replacement is required, but he was pleading us for TAVR. This is one scenario by which we will find. Another case scenario is a 65-year-old gentleman, diabetic, hypertensive, and had history of anteroval MI, PCA done in 2010. Now presents with exertional breathlessness, angio done outside, in Maharashtra state, and he was referred to us with the advice of CABG plus AVR. But by the time he reached the hospital, his heart failure worsened, BP was low on inotropes, 70 millimeters Hg. Creatinine, which was 2.1 before angio, worsened to 5. Then current admission, we stabilized it was 3.1. So dilemma was what to do. These are ECG presentations like left bundle branch block, and also echo see that severe renal dysfunction, severe aortic stenosis. A lot of hypokinesis in multiple areas. Then see this echocardiogram, also some mitral regurgitation, what we noticed. Sometimes we have also seen severe mitral regurgitations also with AS alone regressing. So gradients were actually significant. So that is this is the angio presentation of that patient when we worked up. He has, as we said, LAD also a tight stenosis. L6 is occluded. And then RCA again is a critical stenosis. So this is a second scenario. We find critical TVD with severe aortic stenosis with CKD. That this is a relatively simple one. 81-year-old female, risk factors evaluated, has just a proximal LAD disease. This is the right picture. This is a left picture, which again has a critical stenosis of LAD. So we'll stop here and then take some discussion points how to proceed with these patients and take opinion. Then finally we'll show you what we did. So what I presented is one was a degenerative bioprosthetic valve with critical left main. Second patient was a critical TVD along with CKD and heart failure presentations. Third patient is a straightforward single valve disease presenting with AS. I think we can discuss and on whoever is there, probably Padmanabhan sir or Sai, who can just briefly talk about this, and madam, and then any questions or thoughts from audience also we can take.
The first case which you have shown with the critical left main along with the severe aortic valve stenosis. Would you like to do the PTCA first, stenting for the LAD, for the left main, or in the same sitting, both, or sequentially, like first TAVI and then
Yeah, that's what
PTCA?
we need to discuss.
Yeah.
Presented.
So I would suggest that if patient is having ischemia-driven symptoms, then probably the PTCA should be done first. Or if the patient is totally asymptomatic and more of a dyspnea and the failure symptoms, then probably we have to go according to the patient clinical scenario. That would be, I think, could
Correct.
be done.
In the presence of a bioprocesses already, first will be PCA, then only the
Okay. Sai, you want to say anything?
All three great cases, Srini. Brilliant academic cases. For the first case, if the patient, since the patient already has open heart surgery and has aortic valve in place, I just missed the age of the patient as I was walking in. How old was the patient?
70.
70. So in my practice, I have a rule, less than 60 surgery, 60 to 70 we decide in the heart team. Actually, everything is supposed to be decided by the heart team, but I'm cheating a little. And more than 70, they usually go for TAVR. This case is interesting. Patient is 70 with an aortic valve that requires intervention with left main. I would still be inclined to offering left main PCI with TAVR as the first option.
We pleaded the patient actually to undergo surgery because he needs both CABG plus AVR now. But patient, these are words of patient I'm telling. Though it is done in a good institute, I'm not saying it a small center. I had terrific experience in post bypass. Please, sir, I don't want post valve before. Please don't subject me to that procedure again. Do something. I said there's more chance of recurrence, left main bifurcation, all that we explained. He said anything is fine, sir, but please avoid surgery. That was his request. So then we have to do a good job if you are doing such patients. So see this ischemia being followed by then what we planned is because of requesting, this is a critical left main. Presentation was also ischemia, so you have to tackle coronary artery disease first. Then we did, these are the serial steps. It's out of purview of discussion. Wired both, and then we did first kiss. This is the Briga crush technique which we did. Because LCX osteum was also diseased here. It is important to cover that and do a two-stent technique. And then finally, we did a final stat and did OCT. And then again, for sake of time, I'm edited all that. And finally, we had good areas in OCT, and the LCX osteum was also covered well. Left main area, what we obtained was also quite 12.6. And happy to say that procedure went well. And then later on, after this initially, we planned, we waited for about 4 weeks and then planned this tower also with self-expanding valve, and everything went well. And then patient is doing fine on follow-up. He came for follow-up in the times of online also he's doing well. So in other words to say, if patient has critical ischemia as presentation, we tackled that first, and then you could have also, some could argue that CABG plus AVR could be done, but patient was requesting. That's why we tackled, but we are doing the procedure, such sort of complex DK crush and all, take help of imaging, do a right job. Otherwise, it is likely to come back. Patient, fortunately, in 2 years, is doing all right. The second case, if you recollect, so again, difficult case, not very old like before, but about 65 years patient, diabetic, hypertension. Added problem here was CKD. And patient has presented with the old interval MI, and also, sir, you came, Dr. Kapoor, sir, please join. So also presented with LVF, and then creatinine was worsening. So when we evaluated, he has that sort of disease, a critical instant restenosis type of problem in LAD, and LCX totally occluded, and RC also had a critical disease. So in that scenario, because the patient is predominantly presented with heart failure, for sake of time, I'm just proceeding, presented with heart failure, then low cardiac output state, that's where probably doing of LV evaluation also be done. Significant myocardial viability was seen in SPECT. So it is all, we thought it is a hibernating. Surgeon felt it is too high risk for surgery because the BP was low. It's easy to say surgery, but operating in 70, 80 years blood pressure, and patient had severe dysfunction, we can't blame them also. So then because of this, we worked up, and then with a low
protocol in CKD patients is we just image only the aortic annulus part with 30 cc contrast and then decide on that. People are doing with TE also. One of the technique covered, I have shown that. But this is the hemodynamic data. In spite of patient having severe dysfunction, had a 70 gradient. So we did the edited steps. We did a self balloon expandable valve because I thought it was single go without wastage of much time. It would be good result. That patient improved slightly on day 3, day 4 because his critical blocks was there. On day 3, day 4 monitoring creatinine. We tackled coronary artery right. This is post is the disease result. Then this is the LAD, which was very ugly looking, but fortunately with multiple steps I edited. This is a post-procedure LAD result. And this is LCX, which was occluded. And after that, it has opened up well, though there is some diffuse disease because of diabetes and CKD. So immediately, the beauty of this TAVR as well as procedure is LV improved, though it didn't become totally normal, but immediately it had a dramatic symptomatic improvement first of ionotropes, and the patient became all right. MR also was slightly decreasing. Then creatinine improves. That's why we keep telling TAVR is not a procedure only for aortic valve, but LV function improves, systemic perfusion improves, and the creatinine is also improved. That's why we felt very happy, and patient could go back to his bank manager about to retire. He would go back and with very nice rest, and people couldn't recognize him that he was such a sick patient. That's the beauty of TAVR and taking care of the heart failure presentation. So we tackled TAVR first and then treated coronary artery disease also. The last case I think is a relatively simple one. This we could come across. Some people could argue that you may avoid doing anything, but it was proximal LAD. We thought we could do it. Otherwise, if it was more distal, we could have left it. But proximal LAD and critical, then we thought we can do PCI in both sitting, both in same sitting. But it was slightly challenging in elderly. What we thought is simple. It was little complicated, calcium and all that. It needed post-dilatations. And by the time we finished this procedure itself, it was about half an hour, 45 minutes. And then successfully, as God's grace, this took some time, but at TAVR we could finish it sooner. And finally, we did both proximal LAD stent as well as TAVR. The TAVR steps are regular, which all of you know. We did pre-dilatation, then balloon expandable valve, and the procedure was done well, and patient did not have any residual gradient or regurgitation. But generally, they could have some slight problems during this thing, and if you stent in the same sitting, sometimes you can't reverse heparin. That's why it's preferable probably stage unless it is a financial constraint or something where you tend to do both procedures together. If you, without a proximal LAD, if there is branch vessel disease, small vessel disease, people are leaving it also because it didn't make much difference. On the other hand, if you address together, it had slightly increased bleeding risk in some of the trials. This is what this trial showed. And as we're nearing time, I don't want to go into details of these trials, but timing of PCI in TAVI, basically we decide by presentation of patient. If patient has acute coronary syndrome type presentations, like what we have seen in the first patient, you tackle CAD first and then also do TAVR later. On the other hand, if a patient has heart failure presentations, you tackle severe AS first and then probably stabilize a little, especially when the patient has high creatinine. Then probably plan the procedure in a pre-discharge. And the single vessel disease, straightforward. Sometimes people are recommending combination too, but I would prefer avoiding it unless there is some particular reason for doing it together. So those are the case scenarios, and I thought different type of presentations, how we dealt could be explained case-based. I think I'm up at the time. If any further questions or comments, the take-home messages are what I've mentioned here. Thank you for patient hearing, and final comments by any of the chairpersons, panelists, then I will go to next presentation.
I think we should be discussing about the coronary access now.
That's my next talk, sir.
Next is that we put after how to do.
But before we go on to that, excellent cases, Srini. And I think with the number of TAVRs exponentially increasing in India, we are going to be more and more put in situations where we have to decide. We are going to see patients with coronary artery disease and TAVR, and we're going to have to decide which to do first. Do we do it together? Do we do it separately? Because cost is also such an important concern. And Srini summarized it beautifully. There is no one glove that fits all. First, you identify what is making the patient sick. If it is coronary artery disease, treat the coronary artery disease. If it is the aortic stenosis, treat the aortic stenosis. If the patient is too sick, then you have some via medias where you can do a small balloon just to stabilize the patient. and then do the coronaries and then wait for him to stabilize and then go back and do the TAVR. But it is a patient-specific approach, and that was a beautiful presentation and very well summarized by Srini. Thank you, Srini.
Thank you. And sir, if you don't mind, I wanted him to be chairing. Dr. Aditya Kapoor, head of this department, Sanjay Gandhi, please come onto the podium, chair. And sir, Sai, you go for the next presentation.
So I move it forward by.
You can use this,
okay.
or you can use this one.
Okay, perfect. My fingers are too big to fit into that. I'm just gonna. No, don't worry. I got it. No, don't worry. I got it. I just need to settle in. Good afternoon, everyone. Before I begin, I'd like to thank Srinivas Kumar and the organizers of TCT India for having me here. Quickly, moving on to the presentation. India's TAVI journey. 2012 to 2015, about 90 cases only special access. In 2016, we did about 85 cases by the time TAVI was approved in India. 2017 was about 200 cases, then 315, 18, 600. The number didn't jump because of COVID in 2020. 2021 was around 800, and then you can see that we are here in 2024, and we're expected to do about 2,500 cases this year. It's important to understand how many TAVIs that are going to be in the pool so that we will know how many of them will come back for us for coronary access. And it is important now. It wasn't for the last 10 years, but we are going to be seeing more and more cases with TAVIs in place with coronary artery disease. Now, any procedure which involves a technology in place has to be broken down into three parts. First, understand the anatomy, understand the technology, and understand how the technology interacts with the anatomy. So here we're talking about the core valve, and what you need to know is first the waist diameter for the various sizes available in the market today. You have the 20, 22, 23, and 24. Then you need to know the height of the skirt. It's usually around 13 millimeters for the core valve because you cannot go through the skirt and access the coronaries. And then you need to know the commissure height. See, the skirt is not a fixed skirt all around for the core valve. It goes as scallops, and there are certain areas it rises to 26. So if this 26 millimeter portion is front of your coronary ostia, makes it more challenging. Not impossible, just more challenging, as I will show you. Then you need to understand the anatomy where this core valve sits, as I explained earlier. And as you can see, you have the core valve in place. You have 1, the STJ, 2, the height of the sinus, 3, the leaflet length, because sometimes in bicuspids you have huge scallopy leaflets, and even though your skirt is lower, your leaflet can come nice and high and prevent you from reaching the coronary. And then you have the sinus of Valsalva width, and you have your coronary height. So for a diagnostic angiogram, the first tip is use a J-wire, get your Judkins catheter all the way down as you can, as far as you can, do a non-selective shot first, then get to the coaxial U. I really like this elevocranial because you can see the side of the valve frame and the left main, and then you just push it in and the rest is just routine. Now, once you get comfortable with this, you can see from the fluoro on the left side that it's as quick as this most often. That's the J-wire going in, the catheter going in real time. And once you know where the C-tabs are and where your skirts are, you just pop it right in. So I think the amount of apprehension towards accessing a coronary through the core valve is more in the head than in actual reality. So that's why I've had this run to show you how quickly we can actually get in there. Similar drill for RCA, catheter to the lowest point with your J-wire, then pull up until you're opposite the right cusp. Sometimes because of the way the valve sits and how the cusp is, you don't have to selectively engage. you can just fill the sinus and you'll see a beautiful image of the RCA. So summarizing the tips for diagnostic. Make sure that you're entering through the center of the crown and not around the frame. Use smaller catheters, that is JL3 and 3.5. Use the JY to help you get to the desired frame and then move it in. And depending on the angle of the aorta, especially in horizontal aortas, the RCA, your life will be much easier if you use a multipurpose. If it is difficult to engage, just do a pigtail to understand the anatomy because this is new for you. And if it's an elective procedure and you find it challenging to engage, there's no point going and fidgeting around there with the valve in place. Get a CT. The CT will tell you where the anatomy is, how your access is, and make your life a lot easier. Moving on to PCI. The first patient I present is a 78-year-old who came to our ER with chest pain and cardiogenic shock. As every second counts, quick pigtail injection to see the RCA. Then get the first wire in and take wherever it goes. Wiggle it back and forth to make room, get some shots, peep where you want to be, and get another wire in. And once you get both your wires in, move the guiding into place a little more to engage. And then everything else is just routine PCI. This was all the way back in 2017. Now, sometimes when there's little space between the frame and the coronary, I like to bring the stent all the way to meet the valve frame. It makes life very easy the next time you want to go in. But in this place, the sinus was really roomy, and I stopped with the left main stent at the coronary ostia as a routine PCI. So these are your final runs. The next patient is another 86-year-old with unstable angina and NSTMI. Am I going too fast? It's okay? Okay. So it's another, instead of just giving theory, I thought it's best I show you some of my cases because you can see the cannulation and you can see how repetitive and reproducible it actually is. So 86-year-old with unstable angina and NSTMI, ostial left main disease, short contralateral guide. It really helps in ostial left main disease. When stenting the ostial lesions, bring the coronary stent frame, as I mentioned, back to the valve frame. First, disengage. So the key is that you have a stent floating between the left main and the valve frame. So you don't want your guide to kink it, dent it, or dang it. So the most important thing is leave the wire in, move the guide back, then take your wire back last to prevent interaction between all these. So this is an 81-year-old with chest pain and EKG changes showing acute MI. So you've ended up a diamond too high. All you do is take the stiff end of the wire. This was radial. All you have to do is take the stiff end of the wire and just pop it out of the top diamond, go down one diamond, and then it enters beautifully. So you can just look at the image on the right. Once you're there, gently push to engage. It's quite repetitive for me, eleocranial to engage the left main. And then it's just routine PCI. You have the guide in, wire in, aspiration, drugs, stent, and you're all done. So post-TAVR ACS, another patient, but sometimes the anatomy is not as favorable as in all the previous cases, and it's just difficult to enter. Even if you see a previous stent, even if you see that there's commissural alignment, sometimes it's just difficult to engage. How many of us have struggled to engage a left main sometimes, even without a TAVR valve in place, right? So no patient is alike. No two patients are alike. So this is a nice technique called air mailing, where you take a JR4, so you have place in inside the core valve frame, and you can turn it left and right to angle it how you want to. Get a guide liner, get a microcatheter. In post-TAVR coronary PCI, your two best friends are your microcatheters and your guide liners. Your guide extension, guide extension, guide extension. Because even while I'm doing coronary protection, I don't like parking the guide in the coronary. The guide liner is far more safer to leave in a coronary. So I find the biggest vessel, I leave the guide liner in there, and then I pull the guide back. So just like that, your guide liner, microcatheter. So you can airmail the coronary, wire supported by the microcatheter and guide liner. And you can see once you enter the coronary, then you move the guide liner through the valve frame. And that is the most pivotal step that you can do to engage the left main. You don't even have to move the guide. And once you're there, then it's just another LAD PCI. So this was another patient in 2021. You can see in real time engaging the coronary on the image on the left. And then it's not commissurally properly aligned. So you can see I'm twisting the catheter because I don't have commissural alignment. I'm wiggling it left and right. What I'm trying to do is I'm trying to go around the scallop. And once I'm around the scallop, see, you can see the commissures are not aligned. Once I take the hard end of the wire, I pop the guide out, I twist it, I enter from the side. And once I enter from the side, you can see the lesion which is causing the acute coronary syndrome. The same thing I do, the exact same thing with the guide. So not only it is reproducible. I did it with the diagnostic, took the diagnostic out, knew where I had to go in, went in with the guide. And here you can see how clearly I'm entering from the side in one of the most unfavorable or so-called unfavorable coronary access situations. And then it's all routine PCI, bifurcation, cutting balloon, stent, and that's before and after. So Medtronic has a really cool device called the Heartroid. And what you have to see here is you can see the scallops and you can see the anatomy of the valve, and you can see that I actually entered from the side here, if you can see the pointer. So these are the ideal scenarios and the not so ideal scenarios. So an ideal scenario is when you have the lowest point and the coronary right in front of you. You have the coronary lower, and the worst case scenario is when you have this huge scallop and the coronary in one of these three places. But even with this, you saw the previous PCI. It was quite straightforward. And this was a Heartroid where you can see that we took a heart with a bicuspid anatomy with a long leaflet, intentionally implanted a valve with commissural malalignment or unalignment. I was trying to figure out what's the right word there. And you can see the scallop right in front of the coronary ostium. And then we tried engaging the coronary. So go forward, go left, enter the sinus, wiggle a little, and you can still cross. And once you enter, it's just routine PCI, right? So to summarize, coronary angiography and PCI after TAVR with a cold valve. Initial non-selective injection followed by selective. Use a J wire. Use the stiff end of the wire to get to the right diamond you want to. For left coronary, use half a size smaller, so 3.5. If difficult coronary, rail towards the ostium. Use your guide wire, balloon support, guide extension catheter as freely as you can to make your life easy. For the right side, JR4 guide. Use an AR2 or an MP depending on the horizontality. If skirt is high, use MP to enter from above, and you can rail it towards the ostium. Again, your coronary guide wires, your balloon support, guide extension catheters are your best friends. These are the data of coronary access and incidence of coronary artery disease post-TAVR from some of the registries. You can see 35 in 1,000, 17 in 296. But even in almost, this is about 10,000 patients, you have a very high success rate of PCI post-TAVR. So to summarize, angiography and PCI in post-TAVR patients has a high success with both self-expanding and the balloon expanding TAVs. For self-expanding TAVs, reduce catheter size by 0.5. Leave wire in while retracting your guide to avoid interaction with the prosthesis. Use guideliners and microcatheters to freely facilitate your PCI. And before I finish, don't forget to block your dates on January 16, 17, 18, 2025 in Bangalore for Sentient 2025. Thank you so much.
Thank you, Srini, for showing us. Thank you, Sai, for showing those excellent cases and how we can access coronaries. Even in many of them think that self-expanding valve is difficult to access. You've shown it well. I think latest modification of FX has wider cells more, which makes it more easier. And some of you could argue that short, straight, framed balloon expandable walls also okay. That's also fine. But we wanted to show even with this you can access. I think that's what live case Atizani also demonstrated yesterday. And today we are going to have the Peter demonstrating the same combinations of these, I think.
Perfect.
Thank you very much for showing
Thank you so much.
cases. But one thing, you did it very easily, but the time also matters, and the did acute MI, but you did so well and patients are saved. That's how I think it's important to know. And once you get the confidence that it's possible, then all of us can.
It's just a mindset. We're all excellent coronary operators.
Yeah. Thank you. But one word of caution I wanted to tell before I always keep telling is, don't equate this again with doing crazy stuff with chimney, other things in young patients.
Yes.
Many of them started doing this business. They want to do as a prestige, TAVR only. And even if their left main disease is there, the passing very low coronary heights, They pass the SIMNIS. That is it. Patient is totally high risk, not fit for surgery. Surgeon refused. That is the life-saving measures. You should know those techniques of how to prevent coronaries getting occluded. If at all gets occluded, immediately tackling. Basilica and other procedures also you can learn for patients not suitable for surgery, but it's not advisable to do. Patients, young patients, 55 years has both low coronary arteries, taking, risking sometimes. That I don't advocate. But otherwise, great cases. I thank you.
Thank you so much, Srini. Thank you.
One quick, excellent talks, and the best carry home message, as you said, it's the thing is uncommon but feasible.
Correct.
One quick question or a comment. I mean, you mentioned about femoral versus radial. So, what is your preferred approach, and any experience of using debulking devices through this process?
So regarding debulking devices, once you get the right size guide in, it's just routine PCI. But before I used to be young and old-fashioned, now I'm old and old-fashioned. I am very much a femoral operator because of my 16 years with Dr. Matthew. So it's quicker, it's faster, it's less radiation. But I think radial also is equally doable. We did do some. Yes, we did.
Sir, nicely demonstrated. My small question is that in newer self-expanding devices or the balloon expanding device, they are with some large cell sizes.
Absolutely.
So do you prefer any specific device? So in case which we are expecting that we need intervention in future.
So there's a beautiful saying by Seneca, okay, and he said, we suffer far more in our imagination than in reality, okay. So what I'm trying to say is the reason why I specifically showed the older generation valves is to show how easily doable it is. Now, there are cases, like while in 90% of the cases you can get an excellent result either with a balloon expandable or a self-expandable valve, but with the way data is now, we are fairly certain, we know that there is a small 10% cases where self-expanding is better. If I have a valve area of 300, I'm not going to put a 20 Edwards valve in it. I'm going to put a 23 Evolute in it. Or if I have a young patient, I'm not going to put a big cage in him. I'm going to put a short balloon expandable valve in him so I have coronary access and less metal. So while the choice of valve should be more dependent on the durability and on the case specific selection, I don't think coronary access should be a criteria, which is what I was trying to show. Excellent question.
One more small question, sir. If we have any strut size in front of the left main, sometime accidents happen and we could not able to engage this patient again. So is there any way to deal this patient?
Yes, you can actually go around it, but all this is becoming a little obsolete with the new FX Plus, with huge cells, with Abbott, with the big diamonds. So you will find things only get easier for us, not harder.
Thank you. I think it's all encouraging, both TAVR and coronary artery disease. The data, whatever we see, it always comes positive. And interventional cardiologists and very highly skilled operators like Sai, then data will come more and more positive. With this positive note, we will end this session and go for lunch and request all of you to join back at 1:45 p.m. Because we have interesting live inbox cases followed by live cases coming up from Hungary and Bangladesh. So please do assemble back at 1:45 p.m. Thank you.
Hey, good afternoon, friends. Welcome to the post-lunch session of the last, it could be last session, but we have very interesting things to be presented in this. And after these live in-box cases, you also have a live cases coming up again from Bangladesh by Fazila Malik. And the most interesting could be in the end, we thought we would have interesting case of combination of severe ASI and CAD by Peter Andrika and Giza Fantos from Hungary. With this, I think the chairpersons for this post-lunch session, yeah, some of them have left, I think, for the sake of flights. Dr. Girish Navasindi is here. Dr. Tripti Dev, madam, she will be joining Dr. Arun Mohanty, Dr. Praveen, and Dr. Jimmy George, Dr. Sanjay, Thomas George, Pramod, Varghese, Dr. Hanumanta Reddy. I think Dr. Raja Ramesh. I think I saw Raja Ramesh, Hanumanta Reddy, and Tripti madam. Please come, Raj. And they have two interesting live in-box cases presentations. One by Dr. Suhas Haridas with left main bifurcation purpose-built stent. And the second will be like a complex case of calcified lesions rotablation by Dr. Sanjeev Sharma. Thank you both. And request Dr. Suhas to come over and present his first live in-box. Please, Dr. Akiko can join. It's always a pleasure to have you, madam. You give such interesting comments and we learn a lot from your things. And when she's there on the other side of the podium, live case, lot of easy things happen to the operators because you tell us exactly what is the problem, what to do, and you execute there, that will be done. Thank you for joining, madam. Please.
Good afternoon, ladies and gentlemen. I think as Srini rightly said, it's a privilege to have Akiko on board on dais here. Ladies and gentlemen, I welcome you all for this live. This is 4 minutes of audio, and after 4 minutes, I'm going to mute the audio. And I will only have the case continuously running. Center, Pune. Along with my team, Dr. Satish, Dr. Salina, Vikrant as cardiac technician, cardiac anesthesiologist Dr. Gaikwad, and Julius as scrub nurse. We have a 48-year-old gentleman who presented approximately a week back with unstable angina, ECG changes, and enzyme leak. He is a non-diabetic, a hypertensive with mildly elevated serum creatinine. He had the coronary angiogram in a center out of Pune, which is being played on your screen right now. A couple of days later, after this angiogram, he decided to move to another center in the same town to have an angioplasty. But the operator at the time of angioplasty realized and felt that there was some indeterminate left main stenosis at the ostium, and therefore the angioplasty was deferred with a view to offering him coronary artery bypass graft surgery. Now we have this gentleman and we have decided to evaluate. So these are the views taken with the guiding catheter by the second operator, which shows that there is a possible significant, you can see that ostial left main disease. About the further plan of intervention. Thank you. At this juncture, do you want to make any comments about the angiogram? Do you want to say something?
Sir, is there any pressure dampening with the guiding catheter?
There was a pressure drop, yes. I think that was reported, but this angiogram was not done by us. And we came into picture after this angiogram. The patient decided to move. We have decided to get the femoral axis, and we're using a 7 French EBU 3.5 guiding catheter, and plan, as I said, is to do the IVUS assessment, 2 pullbacks, LAD to left main and circumflex to left main. Whenever there is a lesion and it's an indeterminate lesion and we want to assess and find out the severity, find out the plaque morphology in the left main, it is imperative, it is mandatory that we do 2 pullbacks from LAD to left main as well as from the circumflex to the left main, because that gives us a better idea about the carinal angle, whether it's a spiky carina, the plaque load at the carina and on the opposite wall of the carinal angle. And these things are very important in taking the decision about choosing the strategy for the bifurcational stenting test. Any particular comments from the panel about whatever we have done so far? So we have a guiding in place. You can clearly see that there is a disease which is seen at the ostium. Left main is fairly longish.
The left main is very long and there is an osteoproximal LAD disease.
Yes.
And there is a huge size mismatch between the left main, which is almost 5 millimeter, I feel.
Absolutely. I think we will have the IVUS pullback pretty soon. And there are some interesting findings on the IVUS. So this is, we will have to go through all these steps, or we can fast forward in case we are not, I think we are running fairly well in terms of time. The angle is quite favorable for a mini crush in case it comes to doing it. You see that critical lesion in the proximal part of the LAD with a diagonal involved in that. The vessel caliber doesn't seem too big. This is the wiring of the LAD. I think we used a run through hypercoat. If you have a looped wire like this, it is okay to push it, but if the wire loops from the translucent part, it turns into a missile. So it's not a good idea to push the wire if it bends at the translucent area. This is the wiring of the circumflex. Now, I think a lot of new operators feel that IVUS takes away a lot of time, and that's a big limiting kind of a point in younger operators to do the coronary imaging. But I can show you here that the entire catheter is prepped in about 2 minutes, and the IVUS pullbacks, both the IVUS pullbacks can be accomplished in another 2 to 3 minutes extra. So all that it takes is additional 4 to 5 minutes more, and the post stenting assessment can take another 2 to 3 minutes. So additionally, you probably spend close to 7 to 9 minutes, but it gives you humongous information about vessel morphology, the plaque morphology, the plaque burden, the diameters, the post-dilatation balloons to be selected, etc. So we decided to pre-dilate the LAD because it was very tight and probably the IVUS catheter would not have passed, or it would have had a lot of difficulty in passing. And when you have that, there is a possibility of kinking the catheter, which can damage the imaging apparatus and will not give you beautiful images. So that's when we have just started. You can see that we started prepping the catheter at 540 seconds. And for newer operators, should know that you should not create turbulence in the hyperinized saline because it leads to formation of microbubbles. And these microbubbles are absolutely enemy to imaging by way of IVUS. So very gentle aspiration, and the smaller syringe is always in line with the injection port because it has to be a gentle injection. The syringe is connected on the side port, the big syringe, and then to pull it out of the sleeve, you connect to the side port and flush. Once again, the flushing has to be gentle because if you do a very aggressive flushing, it can lead to formation of microbubbles inside the catheter, thereby not giving you very good quality of images. So this has to be gentle. That's exactly what we are trying to show here. So you should not get a spurt of the saline through the distal port. It should be very gentle trickle, slow trickle through the distal port. You can see that the catheter is almost prepped and is ready to be attached to the pullback device. And it has taken us exactly 2 minutes. We started at 540 and the catheter is now prepped and ready to be inserted.
you prefer a fast pullback or a slow pullback? And whichever speed you get for the pullback, which is good, which is bad, and which situation you would like to have fast or slow?
I think fast pullbacks are fairly all right if you know where you have to land angiographically. The quality may suffer a little, but overall it gives you a good overview of the morphology even in the quick pullbacks. That saves time also. So I think this is the finding in the LAD to left mid.
Yeah, this is a mid LAD, and it's not much calcium, and vessel diameter is only 2.5.
Yes.
And this is mid LAD, still distal to the diag, I guess. And we don't see any balloon. Okay, so that's a branch, one and the other.
Yes.
I don't know which is what, but probably this is septal, I guess.
That's the septal because we know the orientation that we are.
Okay, so you
the circumflex is coming from the right
this is some
top corner.
dissection, but that's tiny.
That dissection, you are absolutely right. That's because of the balloon
That's a
dilatation that we
diag,
had.
and that's a second diag. And now vessel much larger. This is almost like 3.5. That's the other branch.
Yes.
Okay. It's actually not much calcium as seen by angio. Angiographically doesn't look like calcium. It's more likely soft plaque, right? Okay, still this is in the much more LAD. Not much dissection, which we see. This is probably good landing. Okay, so that's probably the diag, I guess.
Yes.
And still this is in the LAD.
That was a large septal actually.
Okay.
Now, can I stop here?
Okay, I
And
see.
do you want to make a comment here? You see a lot of attenuated plaque here. You don't see a lot of calcium, but there is a big acoustic window.
Yep.
And attenuated plaque of this type means there is a possible lipid pool, possibility of a lot of macrophages loaded with lipids, which can absorb the ultrasound and cause the acoustic shadowing. You see that
Okay,
there's a
so that's
significant
a
plaque.
circumflex via the sarc. So we
Yeah.
are in
That's
the left domain. This is a distal left domain. Remember, left domain very long, but you see this caliber is very big, meaning like the good room area, and plaque was not too much. This is very regular, like 40%. And we are coming to most interest, that's ostium.
Yep.
Looks okay for now.
The lumen is now getting smaller
Yeah,
and
nothing.
smaller
Okay,
and
that's
smaller.
the ostium. And ostium was, I think it's okay. Yeah, maybe around 6 or borderline, I'd say.
Let's get the measurements.
Yeah. Not much plaque. So that's main interest, right? So what is the measurement?
MLA.
We will have the MLAs and the plaque burdens very soon. We have the assessment. This is the pullback from circumflex into the left mid.
Okay, so that's probably very important point. Meaning you see the circumflex is more straight compared to the LAD. We may see more coaxial onto the entire artery. So whenever you see the two different type of the measurement, you have to picking up the lower number. Because if they're not coaxial, we are overestimating the lumen. Anyway, this is a circumflex.
Once again, you see that there is some attenuated plaque. There's no significant calcium there.
Yep.
But a
You're
lot of
right.
acoustic.
Yep. Okay. So
shadowing.
that's a small branch of the sarc. Still, we are not.
That's the branch of circumflex.
Yeah, that's the proximal sarc is super big compared to the LAD.
It's almost
Yep.
4.2.
And that's LAD from the 9 o'clock wired. And this is a distal left domain.
Is once again, do you think, Akika, that there is likely to be a lipid pool in the inferior quadrant?
Yeah, yes or no? Because you see the catheter and vessel wall is almost parallel. This is so-called tangential signal drop-off we see in the OCT. And I don't think a lot of plaque. Yeah, there is some lipidic plaque, but not too much. That's my opinion. Okay, so we are in the almost same place. This is the body of the left domain. We are looking again the ostium. So it's similar or smaller? That's the main question. And plaque burden was not too bad. That's the ostium. Yeah, looks smaller than the other pullback, right?
Yeah.
That's many times happen. And if you have the different number, you have to picking up the lower number.
And I think that's the reason why I said that the pullback must be done from both the vessels. And this is the overall assessment. In the LAD, the distal reference diameter is approximately 2.5 millimeters with a healthy segment MLA of 4.14. LAD ostium, it's a largest area. The diameter clearly seems in the range of 3.5 plus. And there, the MLA is 3.62. The distal left main has a MLA of 9.08 and mid of 9.3, but at the ostium, it is 4.9.
That's from which pullback?
This is probably the LAD pullback. So the circumflex pullback will probably give us even little lesser than what it is. But do you want to make any comments about this, Akiko, about 4.9? Before that, you have the tightest mid LAD, which is only 1.9 millimeter squares. And the proximal LAD diameter is almost 3.5 millimeters. And the total length from the LAD ostium up to the healthy segment is 47.6 millimeters, which means we could probably, if decide to go for a mini crush, go for a 48 millimeter stent. Any comment about that value of 4.9? Significant, non-significant, should we address, we should not address?
Maybe we have to do image physiology also. It is 4.93, again it is about.
Yes,
so
yes.
we can fix the LED and we can do the imaging.
My contention here was that if you looked at the ostium, it clearly looked like an attenuated plaque there also. With an attenuated plaque and the area which is absolutely borderline. In fact, one school of thought thinks, and that is PARC, that anything below 4.5 should be considered as a significant stenosis.
The patient was female or male?
Male.
Okay.
Male,
So
big male, weighing almost 110 kgs and fairly youngish, 48 years only. In view of this, we decided to address the left main lesion, and I will now proceed with the
Could be the percentage.
This is the
between the left main ostium to the distal bifurcation area of the left main. I didn't see that. Is it a less than 40% difference or?
so the left main distally was 9.6, and at the ostium, it was 4.9. So it is falling in the range of 50%, almost 50%. You're right.
Sir, should we look at only the absolute number of MLA, or should we look at the plaque burden also in case of left?
I think for left main, Akiko, you can comment on this, but I think it's important, as you rightly said, to look at the plaque burden and to look at the plaque morphology. It is possible that it was a very vulnerable kind of a plaque because there is so much of attenuation in the distal left main as well as at the ostium that addressing this becomes probably important when you have a borderline stenosis. If it was clearly above borderline, probably we could have managed with a lot of lipid lowering drugs, etc., and stented only the LAD. But with so much of vulnerable plaque with a borderline left main dimensions, it is probably a good idea to make sure that you tag the plaque.
Yes.
Okay, so but what is the MLA from the circumflex side? You didn't show yet.
No, not yet.
For the left main.
Not yet. We haven't included that here. So this is the circumflex pullback. And the circumflex is approximately 4.2 millimeters. The left main is about 4.6 millimeters. Now we put a wire in the diagonal, which was coming out of the diseased segment in the LAD, balloon dilated that, and then balloon dilated the left anterior descending artery once again, serially from distal end to the proximal end. And then we took a stent because we had now by this time made up our mind to go for double stent strategy and doing a mini crush. So this is a 2.5 by 48 millimeter synergy stent in the LED, and another 4 millimeter by 20 millimeter Megatron from circumflex to left main. Now this is the positioning. At this juncture, you expect some hemodynamic changes, certain instabilities, electrical instabilities, hemodynamic instabilities. You can see that the patient is breathing rapidly. There is some degree of tachycardia. And I like to keep the proximal marker just into the main vessel, because then you know that the ostium is well covered. We'll probably take one more test injection to make sure, and then deploy the stent in the LED. I think this is quite satisfactory because the stent is just beginning to bend towards the left main, and we would have definitely covered the LED ostium. This is the deployment of the stent in the LED. After this, we pulled back the balloon, and with the same balloon, we did a higher pressure post dilatation. After this, the wire and the stent balloon are removed. Before deploying the circumflex stent, we wanted to pull the diagonal wire. This is when the guiding catheter is likely to get sucked in, and one has to be a little careful. The LED stent seems very well positioned, and on deployment of the circumflex stent, you can see that it is maintaining a good contact with the LED stent, and we probably have accomplished a mini crush, but we'll find out on the IVUS.
Do you want to combine OCT and IVUS in this case for certain reasons?
Here we were limited with the amount of contrast that we could use. That was one thing. And since it's an aorto-ostial lesion, OCT may not probably be the best imaging thing to be used. So IVUS is actually good enough. You can save on the contrast, and you can do the imaging of the ostial areas pretty well.
Sir, sorry to interrupt, sir. There live case is coming off. Can you speed it up a little bit, because one more case is there
Sure.
in between.
Okay. So this is rewiring through the distal part of the strut. It wants to go in the diagonal. This is once again through the stent strut dilatation. And this is the SKS 4.5 millimeter balloon in the circumflex left main, and 2 millimeter balloon in the LED. This is only to open it up, because we know that we have to do the post dilatation of the LED with a 3.5 millimeter balloon. After this, there is proximal optimization with 4.5 millimeter balloon, the entire stent length, and this is a very good image of stent boost, which clearly shows at the ostium of the LED, the stent is not very well flared, and therefore we took a 3.5 millimeter balloon and post dilated the entire length of the LED stent. This is called a snuggle balloon dilatation. So you don't get an excessive stretch of the POC, where most of the stent, most of the balloon in the side branch lies in the side branch and does not come in the main vessel. And after this, we have done the IVUS pullback once again.
This is from the LED, right?
This is from the LED,
Yep.
yes.
Okay.
Yes. So the distal edge
Yeah,
looks okay.
distal edge is fine. No edge dissection, landing nicely in the normal site, and stent looks okay. But this is more main lesion, so looks okay.
I will fast forward this because of
That's the main reason, and actually okay expansion, because this is not super calcified. That's a proximal segment. It's okay too. Oh, you jump to the left, that's proximal LED maybe.
Yes. I want to see the Neo Carina here, and if you would want to make a comment about that, please.
Circumflex is coming soon. That's a circumflex from the 3 o'clock. Yeah, that's a New Carina. We see that. And then, can you show us the left domain?
I just went back,
Yep.
and we'll see that Neo Carina again. Is the circumflex? That's the Neo Carina. That's the distal left main.
That's a circumflex pullback, right?
That's the circumflex pullback, yes.
Okay, this stage is fine. And that's a Carina, 9 o'clock, that's a LED. And this is a distal left main. And we see some stent Carina. And the left main looks fine. It's well opposed. But I think the region was left main ostium, which we didn't see yet. And we have to disengage to see the enough ostium.
Yes.
Coming soon.
Now you see the aorta opening up in the right upper quadrant, and then the stent disappears.
Okay, yeah.
So the
okay.
ostium is well covered.
Yeah, I think landing is perfect. You protrude like 2 strat and then no deform. But why did you put the stent from the circumflex to left main? Because ostium the circle is normal.
Sorry, I didn't get your question. Sorry.
You put the stent from the circ to the left main.
Yes.
Right?
Yes.
But by IVAS, I see the osteo circ was clean and LED was diseased. So I thought you should stent the other way around.
The concern was once again the disparity in the size. That is number one.
Okay.
There was more parity of diameters with the circumflex, number one. Number two, that is probably another approach that we could have just done the provisional stenting and not done anything for the circumflex. But when I looked at significant attenuation at the origin of circumflex, I was a little concerned, because I'll tell you, whenever I have done left main bifurcational stenting and not done the imaging for whatever reasons, we have had restenosis coming in circumflex. And sometimes you wonder, with a very good angle, with a very normal looking angiographic ostium of the circumflex, why did you still get circumflex restenosis within 3 months, 4 months? And that's probably because you have not dealt with a very vulnerable plaque which was there at the ostium of circumflex. So we thought that it may be safer to do it this way. But of course, as you rightly said, provisional stenting could have also worked. Quickly go to next few slides. These are the comparative slides, pre and post. Distal healthy reference in the LED increased from 4.1 to 4.9. Tightest mid LED increased significantly from 1.9 to almost 7. And the LED ostium, which was 3.6, increased up to 8 millimeters. Likewise, the LED ostium, the left main ostium, which was 4.9, had a gain of very significant 12.43, which is once again in line with whatever Excel data says. Then we will go to the next slide. This is pre and post of the circumflex, all diameters around the range of 11 millimeters. The areas. Now this is a few words about this stent. It has a 12-peak design, and this 12-peak design was designed after a lot of AI simulatory models which were developed, looking at 10-peak design, 14-peak design, 12-peak design, and it was found that a 12-peak design gives the best radial strength, and this was the bench testing which was done, and it had absolutely unmatched expansion and uniform vessel scaffolding. The first 3 segments have extra connector, which is there are 4 connectors, and this gives a very good axial strength, and therefore whenever hardware is put in and out of that particular segment of the stent, there are very few chances that you will have stent deformation. And that's the reason why you have extra connectors in that proximal segment. It is platinum chromium, therefore the overall visibility is pretty good. And it is pretty safe because it's only 4 micron abluminal coating of the polymer. The side branch access is very good once again because distally there are only 3 connectors, and you can dilate the cell to a maximum expanded cell diameter of 5 millimeters, whereas in proximal you can achieve 3.8 millimeters. But of course in the proximal segment normally the dilatation of the side branch does not arise, this question does not arise at all. So thank you.
Thank you, Dr. Hardas, for such a nice demonstration of how to salvage the left main ostium, which is the most important Achilles heel during the post-operative period in follow-up, as you have told very clearly that we do get these patients with the plaque rupture and acute coronary syndromes. And you have, like in the prevent data also, they have given that most of those vulnerable plaques has to be stented with long-term benefit of the, post this thing results. The
One last tip I want to give some of the newer operators if they are here.
Hello everyone.
You should cover the left main ostium barely with just a strut hanging into the aorta, because in case you have to re-intervene, it is easier for you to make sure that you are properly engaged into the left main. Thank you.
Now we call upon for the next page.
Good afternoon, everyone. It's a great meeting.
Image guided rotablation to calcify.
After a very nice case by
Rajiv Sharma.
Dr. Hardas. Now it's time to move on to the next case. Greetings from Metal Hospital Cath Lab, Jaipur. Let me introduce my team first. With me is this is about Dr. Imaging Guided Kush Marota, our associate consultant, and Chief of Nursing Staff Devendra, Chief Technician Anand Trivedi, and Priyanka, and Dr. Ankur with me for this live in-box case. So it's an imaging guided complex PCI, rotablation, or if required, this scoring of cutting balloon for the instant wrist node lesion.
Neothrosclerotic lesion in the LED.
The plan is to go for the LMCA to LED because there is no landing zone at the ostrom of LED. And next, please. There are no financial disclosure. Let's come to the clinical history. This is a 57-year-old non-diabetic, non-hypertensive, non-smoker male patient who had a history of underlying coronary artery disease.
Past history of infial underwent primary PCI in 2019,
followed by stage PCI underwent primary PCI, and subsequently the stage PCI to LD circumflex with the 3 long stents. And this time he presented with the history of recent onset effort angina, and for that he presented to us. His ejection fraction is normal, and hemograms and biochemistry parameters are okay. Next, please. These are previous PCI details. Invent primary PCI to RCA with 3.5 to 48 long DS, 3rd July 2019. And subsequently stage PCI to circumflex 3.532 on 6th of July. And also the PCI to proximal to mid LAD with 3 into 40. So 3 long DS, 148, another is 32, and third one for LAD is 40 on 6th of July. Yeah. Next, please. The ECG is more or less okay. Sinus tachycardia, no significant. So ECG is showing sinus tachycardia, no significant changes. So angiography revealed a borderline lesion at the ostrom of LAD and with the ISR to the tune of 80 to 90% mid LAD.
And we had a FFR also to suggest that it was critical lesion. And next, please. So plan is we have taken a right radial vascular axis and venous 7 French glide sheath, and to do a coronary imaging with the IVUS to assess the vascular bed, pull back from LAD to left main and also to circumflex to left main, and then plaque modification with a rotational plus minus scoring balloon or cutting balloon if required, and followed by stent implantation and optimization under IVUS imaging. This old stand with the suspected new atherosclerosis in the stand. So plan is to go for the rotablation plus minus scoring or cutting balloon. And if there is a little plaque shift, we might have to do LAD and circumflex and then do an IVUS pull back from both the vessels. Now, this is the coronal view. Exact clarity, how severe is the. It's clearly showing the lesion starting right from the distal left main, and ostium of LAD is borderline, and the tight lesion in the mid LAD. And it's the instant restenosis, the long 40 millimeter stand. So going for the imaging first, this is run through wire 014. 5. So 3.5 guide is giving good support. Yeah, 7 French glide sheath, yeah, from radial axis. And this is the, we cross the LAD. And then the second wire into circumflex. Come to cranial. This is the distal 3 millimeter. The distal vessel is 3 millimeter in diameter.
So you see the nice myocardial bridge on the 9 o'clock, 12 o'clock.
Clean landing zone.
This is a myocardial bridge, tiny, 12 o'clock, and completely normal.
As we.
This is like 2.5. And still myocardial bridge on the 12 o'clock. You see the dark band, that's a myocardial bridge.
Yes.
Dark band, bridge. And then your stent is a little bit inside of the myocardial bridge.
The instant restenosis.
Yep.
It's a fibrotic.
But mainly right now is fibrotic.
Fibrocalcific.
So stent was okay expansion. We come back. That's more.
There's a calcium also.
Yeah, this portion was stent was under. You see the calcium behind, but also inside of the stent as well.
A lot of plaque burden and also calcium.
Yeah, main plaque burden is outside.
Yeah. A little underexpanded stent.
And this portion was not too bad.
So it's a diffuse atherosclerotic.
Okay, that's IVUS is a little bit hurt because of the air bubble, but somewhere surface was some calcium.
Lot of fibrosis.
So it is a neoatherosclerosis.
Yeah, neoatherosclerosis. Okay, coming here, you see, but not super clear. This is not super confident neoatherosclerosis calcium, but the 9 o'clock is hyper.
There's a lot of
and
plaque
here is
burden.
more like soft plaque inside of the old stent, right? Old stent was okay expansion, but still there is a lot of plaque behind. But this portion was not stenotic,
Here the diameter
right?
looks quite okay.
It's a combination of
Say
both
this-
the
okay, here
mechanical
the
and
proximal segment.
neoatherosclerosis. Some part of the stent is underexpanded
to
and
the
there is a
proximal part.
neoatherosclerosis.
A little bit, yeah.
And coming close to the ostium.
So yeah, that's
That is the
outside of the old
osteostenosis, and down is the left main.
and that's a circumflex.
You can see the wire from the circumflex in the left main,
Okay.
and this is the within the guide. Okay.
So I think the neoatherosclerosis
I will take a
is
pullback
not too
from the
bad,
circumflex.
right? Especially calcium.
Now,
It's
yeah.
a little bit under,
for
and there is a
HCA to
calcium behind the stent.
Yes,
right?
neoatherosclerosis and a little bit of calcium plaque burden beyond the stent.
Behind the stent.
Yeah, you can circumflex pullback. Circumflex, distal edge of the circumflex
So
stent
that
looks okay.
stent was very well expanded
Stent
and not much
well
tissue
expanded.
inside.
No significant ISR. No significant ISR in the circumflex stent.
That's a nice
proximal part
neoatherosclerosis
is
calcium, a little bit.
And
We just
this is
passed.
the left main. Second wire is from left. And AD is also visible. Stop. So with that, plan for the rotablation because of underexpanded and neoatherosclerotic changes with 175 burr, and to ablate the calcium and also the neoatherosclerosis, and make the previous stand little malleable to further expansion. This is the rota wire.
What do you think, looking to the less amount of calcification inside the stent, could we not
No, can remove the
handle it with
run
the
through.
either scoring or cutting balloon, preferably?
थोड़ी ठंड
Yes,
लगेगी वार्मर लगा दिया
balloon after rota and scoring.
आप जी as we go. One 50, 155. 150. Right. It's okay. Yeah.
It's a 175 burn. Proximal and then
within the stand.
fidelity.
What are the things?
And lesion was more at the band, just beyond the band.
Here the resistance and the change in noise. Now this is the area which has got a
bigger burr is just to ablate the lesion as well as to make the stent a little softer for the further expansion.
So we have rotated the
That was taken out. Then this is a balloon NC, initially with NC balloon at 18 to 24 atmosphere.
The pink for the stagger tight.
In the mid to proximal part of the LED. Lesion looks safe and way and good expansion.
No, we can get, and it doesn't give. Go please.
Did you use a scoring balloon also?
Scary for the ostium of LED and the distal left main. 3-5 scoring balloon. This is the NC.
You get pre-dilatation.
There is
we have
not
prepared
much
the
of
bed.
calcium.
Mr.
Can we
use
get away
ISR
only
lesion.
using the cutting balloon or scoring balloon in
that
this
is what.
case?
Yeah, we can.
Take a
Because with the
In
previous-
IMUS also
because
there
of
was
eccentric
not much
over
of
down,
calcium,
you can take
so-
Not more than 2 quadrant of calcium. You can manage with the scoring balloon also.
HyBiz correct.
And this is 3 into 38 synergy XD
This looks okay.
because
We can
better
take a
radial
cement.
strength.
Yeah.
And you can see that stent is nicely expanded.
Save.
Doshi, बात कर लो.
So it's the 338 synergy XD.
And this looks
In the-
quite okay. There's a further expanded with 3 NC balloon at 18
Yeah,
to
bro.
24 atmosphere.
So going with the
length.
NCs, where we see perforation also because of there is a stenosis which is very fibrotic even on ultrasound, intraocular ultrasound.
This is
So we're going with the
proximal
3 millimeter
out of
NC balloon
LED.
first and then we go. Go. Save.
I couldn't get you. Did you use a stent 3 into 38 inside the?
Because we are going across the left vein, so there
Did you
can be
use
a little
stent
bit of a
inside
compromise
the
for
previous
sometimes.
stent?
And this is the scoring balloon 3.5, 15.
Present scenario, what we think that go about less amount of metal and more vaso motion.
DCB or DV.
Yeah,
But
that's
there was a
what
lot of plaque burden
Scoring balloon.
in the.
could have done a
You can put the tag of scoring balloon.
No, I was. You've done later on.
could have prevented the second stent.
But there is a disease at the ostium of LED also and the distal left main plaque burden. So decided to ablate the calcium, prepare it well, and then 2 overlapping stents to cover the left main to LED.
So we can take a
And do
cine
complete job.
because there is the previous strand. There are 2 strands, so we cannot make it up. Which one is the proximal edge?
This is a scoring balloon 3.5 into 15.
We direct here.
This 3.515 balloon.
I will take care of the. We can
And
come
have
a
a
little back.
scoring balloon 3.515. And the idea was to keep it provisional, left main to LED
can-
and circumflex if at all required to a
we
kissing
can
balloon
inflate the
or
balloon.
one additional.
Save. I go with the. Okay. So now I can go with the stand. is looking nicely opened up. But it was very
Ostium
stenotic
looks quite good after the scoring balloon.
bifurcation. We can see in the cranial first.
This is 4 into 24 Megatron.
Yeah.
Overlapping with the previous Synergy XT 338. As pointed out by Dr. Hardas, this is quite good for the left main bifurcation, and because of its radial strength, and also because of side branch access. And after checking in the cranial views, epicranial and lower cranial, ostium was not very well defined.
Looks okay.
So it was deployed in the AP. Subsequently, the balloon was pulled out a little back and expanded at high pressures. And then made the guide little coaxial.
Let it deflate.
Over the balloon.
Go inside.
And the guide is being made little coaxial. Now it's a coaxial, and then first part was done with a 4.5 balloon.
Let us come back. Save, please, save.
This is the 4.5 NC balloon at 18 to 24 atmosphere.
Yeah. 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 You can, yeah. So the ostium part is also
And at
covered.
high pressures. It's very important to optimize the LM.
Fans, very well expanded stent. It has taken its diameter. There is hardly any significant plaque shift towards circumflex ostium, so it's very good.
The circumflex ostium looks
and LED also looks
okay. There was no
okay. So we are
significant
going with
compromise.
3.5 for the
And then
here
the
you
post
can-
dilatation of
I'm not going across the bend.
LED with the 3.5 NC balloon.
Yeah. Okay.
Again at high pressures, 18, 20 atmosphere.
No. This just a low pressure. Here is the proximal LED cross.
And the whole length was dilated. And this is across.
Same
to
deflate.
Optimize the osteoproximal LED at high pressures.
Distal, mid, and proximal. Looks okay. Looks good.
Okay.
Start
Now,
from here.
looking at the IVUS.
Okay, yeah. Yeah, IVUS.
Okay, so this
So
is
it's,
distal to the new stent. It's larger.
zone which is
Yes.
clean.
And you see the myocardial bridge on the top, 12 o'clock.
Yes.
12 o'clock.
So this is the
It's almost, yeah.
this landing
You
zone
are
with the
not
struts
super
visible.
extended. So your stent is fine, no edge dissection.
Very
But
well
I need to
expanded
say there is an inside of the
little
myocardial
eccentric
bridge.
expansion because of the
But
plaque
it's
burden.
Maybe okay.
There is a little
Abdominal
eccentric
gain is quite
expansion
good.
Yeah.
That's
from
the
11
overlap area
o'clock
with
to
the
4 o'clock.
previous
Yeah,
stent.
this is only single stent segment. Now we are overlapping all the stent,
Yeah,
right?
previous-
So
yes.
you see the two layer.
Yeah.
And looks okay, looks good.
Well opposed and well
Yeah,
expanded
I
stent.
agree. That's well opposed, well
Distal
expanded.
LED.
But the key was like under expanded
Visually we are
postwide
coming back.
segment.
Little eccentric
Somewhere
expansion.
here too.
Yeah.
This area
This
is being
stent area, maybe borderline, but probably okay because of the wire. Yeah, somewhere
CNC
here.
and
it's
then
under
3.5
expand-
NC.
Yeah, we have to see the measurement.
And that area is dilated with the 3 NC at 24 atmosphere and also with 3.5 millimeter.
What is the MLA there in that part of the study?
MSA was 5.5.
Okay, 5 point something.
good
Okay,
MSA.
good.
Well
So
expanded
this
in the
is a
mid
two-layer
LED.
segment, and you cover everything.
Here also the eccentric
Little eccentric expansion.
expansion of the stent because of
MSA looks
proximal LED
quite
plaque
good.
burden.
Yeah, that's approximately LED. Looks okay.
There's a hard fibrotic
Coming
lesion in
close
the
to the
proximal
ostium of
LED as
LED.
such. And coming close to the
Yeah, now
the ostium.
we are still two-layer.
Also opened up nicely.
Yeah, now
coming
we
to the
are one
distal
layer.
LMCA.
That's approximately LED. We should see the circumflex.
Yeah,
Here
this
it looks very well expanded, well
In
opposed.
the 9 o'clock.
Yeah.
2000.
And then we are left away.
And this is 4.5 expanded high pressures.
The port was working.
Where the post and ostium looks covered. Yeah, that's fine. The only thing is, should be directed with the 5mm balloon or not? But looks okay. Looking at the plug button. Show me the last one. LMCA. Show me the LMCA. LMCA area looks 16. That's pretty good. And show me the last. Yeah, LMCA. This is LMCA where we start. And this looks okay.
This is distal left main.
Here also is a total. Yeah, this is close to the proximal ostial LAD. Well expanded. Now we can see the circumflex arising here. And this is the distal left main. But there was a plug bud in the distal left main, but pretty well expanded. And yeah, looks good. And expansion of the stand. But
so this is the mid part of the LAD, which has eccentric under expansion. But further directing might have led to the perforation. So
this is all about
area was around 5.
To summarize, it was a multi-vessel PCI done earlier, had a long LAD ISR, fibrocalcific, neoatherosclerosis, 5 years down the lane, and also having ostial LAD and distal left main. So provisional left main 2 LAD, 2 overlapping, and good plaque modification initially with the rotablation 1.75 burr, and followed by NC balloon 3mm and the scoring balloon 3.5 to 15 for the LAD ostium and the left main 2 LAD. And 2 overlapping DS. Low down it was a 3 into 38 synergy XD. And further in the left main 2 LAD overlapping the previous trend is 4 into 24. And subsequently it was dilated. LM pod was done with the 4.5 at high pressures, 18 to 20 atmosphere. And the LED was post-dilated initially with a 3mm NC at high pressures, 1824, subsequently with the 3.5 NC at again 18 to 24. And we got a very good MSA in the IVUS and also the very beautiful or pristine pictures angiographically. With that, I thank you, the organizing team of TCT Plus India, Dr. Srinivas Kumar and the team for giving us an opportunity to transmit live. This is a complex PCI LMCA2 LED with plaque modification with rota scoring balloon under imaging guidance of intravascular ultrasound. Thank you very much.
Thank you. Very good.
Nice case, a good demonstration of neoatherosclerosis by IVUS and plaque modification techniques and provisional bifurcation technique.
But I think the calcium was not too bad.
Yeah.
And mainly underexpanded because of the calcium behind the stent. So you may ablate the stent.
Thank you.
That is the live case.
Yeah, I can announce the next session.
Next session chairpersons. Dr. Gobe, Dr. Sai Satish, Dr. Ramesh, Dr. Mantosh Panja, and the panelists Rakesh Gopal, Alok Singhal, Deepak Agarwal, Saurabh Mehrotra, Kuruva Madhu Krishna, Parminder Singh, and Vinod V. The live case is from calcified vein vessel disease to CTO PCI, Dr. Fazila Malik, NHC Bangladesh.
এখন কথা শোনা যায়?
হ্যাঁ, we can hear you, madam. এটা আমরা অডিটোরিয়াম থেকে শুনতে পাচ্ছি।
আচ্ছা, গুড।
আপনি আমাদের কথা শোনা যাচ্ছে?
হ্যাঁ, ক্লিয়ারলি শোনা যাচ্ছে।
ওকে, আর কনফারেন্সের কথা?
কনফারেন্সের কথা শুনতেছি না আমরা। কোনো কনফারেন্সের কথা শুনতেছি না। ওকে, রাইট। ছবি তুলো। বলছে না কেন ওরা?
You start.
Okay, it is, I think, the last session today, live, very important session. With me, Dr. Group, Sai not there, Ramesh not there. That is the important things. So today, the live case, I think, case number 8, and we'll start calcific multiple vessel disease with a C2 PCI, and Dr. Fazila Malik from Bangladesh. Yeah.
Good afternoon. Can you see us, please?
Yes, you are audible and seen.
Right. So good afternoon, and thank you for giving us this opportunity to present a case in your wonderful conference. We are really excited to be here with you. And let me first introduce our Heart Foundation to you. So National Heart Foundation Hospital and Research Institute, where we work, is a non-government, non-profit organization. It is a 565-bedded tertiary cardiac care hospital in Dhaka, Bangladesh, and we try to provide modern cardiac treatment to our patients at a very affordable cost. We started with a single cath lab in 1999. At present, we have 7 cath labs, and in 2023, we did more than 25,000 cases, and we started doing left main PCI on a regular basis in 2007, and by this last year, we did a total of more than 4,693 left main cases. We also do rotablation on a regular basis since 2015, and we've done up till now a total of 375 rotablation cases. So without further ado, let me introduce our case to you. So this is a 75-year-old male. He has a very long history of chronic coronary syndrome. His angina was getting progressively worse even with maximal anti-anginal therapy. And he had severe multivessel disease. Yesterday, 5 days ago, actually, we did his PCI to his RCA. He's a diabetic with CKD, creatinine being 2.8%. His ejection fraction is 46%, and this is his angiogram. Now you can appreciate that he has a severe distal left main disease, around 80%. The LAD is also heavily calcified, having 90 to 95% long segment stenosis, starting from the origin. Diagonal is a large size vessel, having 80 to 90% stenosis at its origin. LCX is also heavily calcified and totally occluded from its origin, and it is filled by collaterals from the right coronary artery. Now, the right coronary artery, this is how the right coronary artery looks. It has a 90 to 95% lesion, moderate calcification in its proximal segment, starting from the ostium, a bit of an anomalous origin of the ostium. So what we did is we decided to tackle the right side 5 days ago. For the right side, as we had no support from the left side, we did not go for rotablation in this side. And also our balloons passed, which was also indication that we could get away with balloon angioplasty. So we did predilatation, a very thorough job of predilatation with NC scoring balloons and cutting balloon for the ostia. After proper predilatation, we used drug-eluting stents starting from the ostia. We did post-dilatation, and this was the final result 5 days ago. Now coming to today, let us go to the case today. Can you show the case to us, please? This is the left side. Can you see the left side, please, today? So this is the RC. We just took a shot prior to doing the case. So you can see the right side looks just fine. And then This is the left side. You can see the heavy calcification visible in the angiography. And this is how it looks with our dye. Very severe distal left main disease, diffuse LAD, calcified, LCX or CTO, heavily calcified, diagonal also diseased. So we wired the vessel with the help of a fine cross microcatheter and a run-through wire, and we attempted to pass a 1.25 balloon. And as you can see, the balloon did not pass. So this was a clear indication, and we were pretty sure from the start also that we would be needing a rotablation here. But just to show that this was indeed very heavily calcified, 1.25 balloon also refused to go. So without further ado, we changed to a rota wire, and we did rotablation with a 1.5 millimeter burr. This is just what we did. And we did quite a few runs. And there was quite a huge chunk of calcium in the mid part of the LAD, which we struggled a bit with. But after 3 runs, we gave a polish run. And so that's us with our 1.5 burr. So after we did a rotablation, we changed our rota wire for our workhorse wire, which is the run-through floppy wire. And after this, as you can see, we wanted to do IVUS, but our IVUS machine didn't work. So we had to take our OCT. And as you can see, when the OCT went very easily, and we just took a shot. So this is when you came to you joined us. So we've just taken the shot with the OCT. And we can go to we've also not seen what the OCT showed us, but we can have a look together right now. So this is the OCT run. Can you hear us?
Yes. Sorry.
OL audible and OL seen.
Right, great. So as you can see, it's a very long, diffuse, calcified lesion, which we have managed to rotablate. The patient has tolerated the rotablation quite well. And you can see we are going to the tightest part.
I think the 12 o'clock, there is a nice rota effect. You see the very nice round shape, that's a rota effect. And around the rota, we see the platelet-rich thrombus as well. So this is a distal segment. This is okay, no rota effect. Coming back, that's some thrombus. More, this is like 180 degree of the calcium in the 12 o'clock, 3 o'clock, 6 o'clock. That's some thrombus, but that's okay. Come back proximally, and that's like the 6 o'clock, nice rota effect, it's Polish, and then go more, and calcium fracture, you are right, 6 o'clock, and then more. This is nice rota effect. You see the nice Polish surface? Yeah, that's nice Polish surface, and calcium fracture on the top. And this probably calcified nodule in the 6 o'clock we just passed, yeah. Then the proximal portion. So it looks like, yeah, here is the best picture. It's 12 o'clock. You see the nice round shape that's really made by the rotablator. So quite significant calcium and calcified nodule and some fracture and good rota effect.
How will you recognize the difference with the calcified nodule versus nodular calcium? Could you please explain?
So this case, I do think, yeah, this is not the nodular. Come back to the.
Yeah, here. Can we go back?
Okay.
Yes.
Yeah, that's perfect. I think this is eruptive type of the nodular, eruptive type of the calcified nodule. So typically they can fracture or redistribute without too much, but I think underlying calcium is a lot. So not only the eruptive calcified nodule, but also the underlying calcium has to be treated together. And then that's how ROTA worked. Yeah.
So you will agree that in this kind of heavily calcified vessel, the only tool that would really work was a ROTA, and it's done a brilliant job, I think, because we could even take our wire. Now we plan to do a more preparation of our lesion, and we are planning to do it with scoring balloons, NC scoring balloon. And so we are taking a 3 by 10 NC scoring balloon, and we will prepare the lesion further.
Erupting nodule is easy to break, but the outcome is very poor. Non-eruptic is very difficult to break it, and of course, outcome is better. Do you agree, madam?
I'm sorry. Yeah, eruptive calcified nodule is even we have the good expansion, they can be deprotrude later on. So that's bad. But for now, that's a different story. We have to take care of the other calcium together. So I totally agree doing the additional treatment to make more fracture and then making as much as big stent area. That's what we should do now.
So erupting nodule, because of the macrophages, inflammation existence, that is why the outcome is easy to break, but the outcome is bad.
Yes, but not everybody coming back. So still, we need a good expansion. And because we have the large calcium burden behind the calcified nodule, so that has to be break.
Correct.
Can we use IVL to break that calcium now? Or should we use scoring balloon or cutting balloon for the remaining calcium?
Here we, as you can see, before this rotablation, we were unable to take even a 1.25 balloon. Now we have managed to take a scoring balloon, which is rather bulky, a 3 by 10, and it went very easily. So I think we can do it a bit more here. Yeah.
Fajila,
So
Dr. Panja here. I want to question, why not use the Bulverin? I routine practice 90% cases Bulverin is very effective rather than the scoring balloon. Why you are choosing this scoring balloon in this case rather than the Bulverin?
Well, one fact is Wolverine is a great balloon, but I think it's a scoring balloon is more easier to maneuver than a Wolverine. And also I'm doing it for quite a long lesion. And for me, a scoring balloon works very well. That's why, I mean, it's personal preferences, isn't it? So I usually get away with using a scoring balloon, and it's easier to handle. And it's also a lot less expensive. That's also another thing that, but Wolverine is a great choice. And I mean, I also use Wolverine, but today we decided that we've already used the Rota, so we'll go for a less expensive balloon, which is a scoring balloon. And as you can see, the balloon is opening up very nicely, and we hope that it's doing a pretty good job of dilating the vessel.
I think whether should we use the IVL or scoring or wobbling for this case, in terms of the imaging standpoint, I think scoring balloon seems to be perfect because calcium is multiple, but none of them was circumferential anymore. So that's, I think, very appropriate. And actually, it was confirmed it's opening well.
Thank you. That's a great insight that you sort of told us. Yes, I think that, and the imaging in this kind of complex cases, I think, is really changed the way we do procedures, and it did help us guide what tools to use, as you write. Because if there was, if required, we would have had to use an IVL, and obviously the cost would have gone substantially. So the vessel looks like this right now. So the bed looks fine. Now the question is about the diagonal. So I was, do we wire that vessel and try to open that up? Because it's quite a large size diagonal, isn't it? But the challenge is that the ostia of the diagonal is quite severely diseased.
Yes, definitely we need to wire the diagonal at present because Rota is done.
Right. So we'll do that. Let's see how the wire behaves.
I think even below, before the scoring balloon, probably we can put the wire. Sometimes dissection flap, something is there. Maybe it will be difficult to wire the diagonal. Sometimes it can happen.
Yes, that's a very worthy observation. Yes, because sometimes if we do too much of dissection, it might be a challenge to wire the vessel. Can we? Can we have a spider, please? Can we go to a spider view? So we'll go to a spider view. Check, please. Check, please. I think I need a micro. I think I need the support of a micro, please, because as you can see, the wire is buckling up. If I have the support of a micro, it would be easier for me to go because the ostia is very significantly diseased and it is not allowing the wire to enter. So what I'll do is I'm going to take a micro. Okay. I think a micro would have been a much easier thing to take here. It would have allowed me to check, please. I'm not getting any support, so the check, please. We've got a lesion here also. Huh? In the diagonal, in that segment, there's a tight lesion, which is just sort of pushing my wire into a smaller branch and not allowing it to go forward. So if I had the micro, it would have given me the necessary leeway here also to go forward. Maybe I'll take the micro now. Can I have the micro, please? Or we can dilate the ostium and that might allow me to, can I take a 1.25 balloon then? Just a 1.25, please. So we'll just gently dilate the ostia of the diagonal. This will allow me, I think, more room to maneuver my wire because the diagonal is severely diseased in the ostia as well as in that segment where the wire is being deviated towards the smaller branch of the diagonal. So I'm taking a 1.25 by. Okay. So let's see. So actually, this is not a 1.25. This is a 2 by 10. Let's see how it behaves. It didn't go in. I think a 1.25 would have been a better idea, maybe. Yes, now it's in.
Yeah. Which balloon is 1.25?
No, it's 2 by 10.
Okay.
So with the support of the balloon,
yes,
I was able to negotiate my wire into the diagonal.
Big, large branch of D1.
There's quite a significant angle between the diagonal and the LED as well. And the balloon has sort of stuck.
D1 osteoproximal, there is some calcium also.
Yes, there's quite a bit of calcium, and that's what's preventing the balloon to go. Can I take a 1.25, please? 1.25, please. I'll take the 1.25 instead of the 2. The calcium is quite substantial in the diagonal, and but I don't think the diagonal is of the caliber that we should chase it with a rota. It would be counterproductive. So we are trying to take a 1.25 balloon now, and let's see how this behaves. The 2 did go, and we did manage to pass our wire effectively. So the 1.25 is going quite easily, but it still again got stuck in the calcium here. So we dilate here. So 10 atmospheric pressure. With the scoring, we went up to 16, 18. Here we've gone up to, but we are unable to cross our balloon here.
Yeah.
The ostia has been nicely opened with a 2, but this part is proving to be a challenge.
Whole entire artery is a medium-sized calcium is there.
We can. I think this vessel is so heavily calcified. We've managed to open the ostia of the diagonal. I don't think it's going to be worth chasing the mid diagonal with too much aggressive dilatation. This is a 75-year-old gentleman. He's got a very long history of chronic stable angina. He's got CKD, diabetes. So we want to be gentle with him. And that was one of the reasons that we did a staged PCI during the RCA 5 days ago. So here we've managed to open up the LED nicely. The diagonal, we've managed to open the ostia. So let us take a angiographic shot now and see how things go. And then we can take the opinion of the panel about how to proceed further. So
yes.
So the diagonal ostia, we did do predilatation with a 2 millimeter, 2 by 10 millimeter balloon. That mid diagonal lesion, we are unable to cross with a balloon. It's a balloon uncrossable lesion. But I think we are quite happy with the fact that we've managed to open up the ostia of the diagonal. Now, we've done quite a reasonable job of preparing the LED lesion. So my idea would be to do stenting of from the left main to LED right now. We don't want to be too aggressive here.
Would you please try the proximostial D1, same angioscalp as at least 2 sides. You will try for the angioscalp to opening the osteoproximal D1.
For the ostia of the diagonal, we can do that. For the ostia of the diagonal, we can do that. We can do a scoring. That's a good idea, I think. Thank you for the suggestion. So for the LED, we had taken a 3 by 10 scoring. Here we're taking a 2 by 10 NC scoring to open up the ostia of the diagonal.
Yeah.
Let's see. No, it doesn't go.
Very difficult to
So
negotiate on those
even
terms.
a 2 by 10 scoring is not passing into the diagonal. Because there's severe calcium there, and also there's quite a angle, which is not allowing, even a scoring balloon is quite bulky compared to a normal balloon. And so, and it's not that flexible, so it's not budging there.
Prior to that, you should try to open by NC balloon 2.5.
I'll take again the 2 by, I can take the 2 by 10 NC balloon, or I can go for a 2.5 by. So I'm taking a 2 by 10 NC balloon.
Any suggestion from the floor? Or
I have a crazy idea. So I would check the OCT one more time and how it looks like the ostium of the diag in relation to the LAD lesion. So if that is not too close, we can put the 2 separate stent, not jailing the diag. Maybe nobody like, but that's one idea.
I think
we have opened by 2 the diagonal, and we are thinking about a 1 stand strategy, not 2.
2.5.
So I think with 2, it is less likely to get blocked with a stand to LAD. So in 1 stand strategy, if it is an open diagonal and we are going just TIMI3 flow and with a 1 stand in the LAD, I think it would be fine.
Open, that case, they want a single stent strategy to be maintained.
Yeah.
So if the calcium proximus is very difficult to open, whether you can try for the rotor 1.25 may be effective also.
Yeah.
Of course, it's difficult to open.
So the thing is, at the end of the day, what we want is to relieve our patient of his angina and also to have a safe procedure. So my take on this case is that I would like to just stent from left main to LAD, and if the diagonal, we don't lose the diagonal, I'm quite happy with that result. Obviously, this is a very severely diseased and heavily calcified diagonal, and I'm not too keen to take a 1.25 burr into this vessel. I mean, it can be done, but the challenges are that it's not that large sized a vessel. And is it worth chasing? And is it worth taking the risk of getting this amount of myocardial territory, but the consequent risks are quite substantial. So as I've opened up the LAD, the RC has already been taken care of.
Yeah.
And actually, after the RC opening, the patient also has said that he has had this quite substantial improvement in his symptoms over the last few days. But let's see, with the LAD opened up, I think he should be fine. So I think I would rather keep the diagonal like this and hope that it doesn't get closed. We've opened the ostia, and I'm quite hopeful that we won't lose this diagonal. So I'm taking a stent right now.
Yeah.
So we are taking a 3 by 38 synergy.
Yeah.
One
I
more
will give him the
point,
GTN.
if we
I
want
will give
to
him the
use,
GTN and Nicoran.
If we want to
In
use
the meantime.
1.25 burr into the diagonal, we need to remove the LED wire again.
Yes, we need to do that. And are we do we want to do that?
Switch.
So I'm taking our synergy stent, a 3 by 38 synergy stent from left main to LAD. And I'll remove the wire from the diagonal because It's such a calcified vessel, and I'm not too keen to keep a wire there. And then once I've deployed a stent, to pull and push the wire.
You are correct decision. Otherwise, you try furthermore, so it cause the deleterious effect on the side branch. It ultimately close. So better to abandon it, and your right decision taken. Put the stent on the LED.
So the synergy goes beautifully in this calcified vessel, which was treated with rotablation. I'm removing the wire from the diagonal.
So I think we have to watch the time because Hungary is waiting. And this is obviously...
So you can go and...
yeah, this is more work to do, and this is
So
complex.
yes, I will finish off, and you can see the end result later.
Yes.
Right,
great. It's been a very, very informative session. You're teaching us a lot. Obviously, this is a very challenging and complex case. We thank you for doing this on a Sunday for us. But Europe is waiting for the valve implant. So thank you very, very much.
I totally understand. Thank you.
Thank you so much, and good luck on your next steps. Okay.
Right. So if you can come back and have a look at for the final results, that would be wonderful.
Okay, we'll try to do that.
Okay, thank you, Fajila, and your
Thank you.
Thank for your team.
Bye. Thank you.
Thank you very much indeed.
Thank you very much.
I think now we're going to Hungary, to Peter.
Hello, Eberhard. Can you hear us?
Oh, yeah, we can hear you. We can even now see you.
Okay, very, very, very good. We are
Well,
trying
thanks
to
for
look
joining on a Sunday, Peter, with your team. Looking forward to having you for the next 30 minutes or so. Thanks for the effort to teach us a little bit more than we used to know here. And we're looking forward to an interesting case, okay?
Okay, Eberhard, it is our definite pleasure to be able to transmit this case from here to Hyderabad. How is the weather in Hyderabad?
It's always nice in India, so no worries. We're sitting in here safely.
Okay, so please let me introduce you our team. So as you can see, Geza is standing right next to me, my friend. My friend, please the camera, please show us Geza. My friend, and a very important member of the team is Balaj, who is standing right behind us. He's a heart surgeon. He will have a very, very important and significant role, you will see. But at the moment, I want to keep it in secret. Why? We will discuss the entire case, and then hopefully you will understand why he is here with us. So Anna is our scrub nurse, standing here. Keva is the anesthetist because it is general anesthesia. You will understand why it is important. Monica is our imaging guy. She will be the echocardiographer. As you can see on the monitor, we are going to be using the transvaginal echo because the patient is intubated anyway. And we have an electrophysiology fellow because the patient has a pacemaker. And Noemi, our young cardiology fellow, will explain the patient to the audience and to you. Noemi, it's your turn, please. Would you please fix my mask? Thank you.
Link. These are our disclosures. Can you see our slides?
Yes, we can.
Eberhard, can you hear me?
Yes, we can.
Okay.
So this patient is 79 years old. She's a female. She has hypertension and type 2 diabetes. She also has a permanent atrial fibrillation and an end-stage kidney disease. In 2014, she underwent endarterectomy due to the significant stenosis of the left internal carotid artery. And then in 2016, a permanent pacemaker was implanted due to a third-degree AV block. Her aortic stenosis is known since 2020. At the end of last year, in 2023, she was presenting symptoms of heart failure, and her aortic stenosis became significant. So she was hospitalized here. During the hospitalization, anemia and positive stool blood tests came back. We ran some diagnostics and we found gastric ulcers. In the CT this year, in January, showed a left atrial appendage thrombus. So on the echocardiography, you can see that she has a good ejection fraction of 75% with a calcified mitral annulus and a mild mitral regurgitation. We also saw a moderate tricuspid regurgitation. The aortic valve was heavily calcified with barely opening leaflets, and the peak to median gradient was 88/47 millimeters of mercury. The AVA was 0.2 centimeters squared, and we also saw a mild aortic regurgitation. On the CT scan, we saw the mild sclerosis of the right coronary artery and the circumflex artery, and we also saw a moderate to severe LAD stenosis. Here you can see the CT scans of the left atrial appendage. The yellow arrows indicate the thrombus. So as per our institute's regular ways, we brought the patient in front of the heart team.
Okay, so that is the case. To be honest to you, this patient was our second patient in line because we wanted to show you a coronary patient together with the TAVR implant, but due to logistical issues, she became the first patient, and we think it's also a very, very interesting case. So there is actually a big question at the moment. I mean, what we should do is very obvious, that since we are unable to anticoagulate this patient, we need to close the left appendage. But there's a thrombus sitting in the left appendage, so which is a clear contraindication for the percutaneous closure. So that's why we decided to close the appendage surgically. And of course, the TAVR is also indicated. It's a very, very tight aortic stenosis, as you could see. I can see the gradient. Please show us the hemodynamics. So we can see the gradient. The gradient is pretty high. And the aortic valve area is 0.2. So it's really, really tight. So we decided not to close the appendage first in the OR, but let's fix the aortic stenosis first, and in the same setting, let's close the appendage surgically. So that is the plan, Eberhard, and what do you think? Is it a good plan or a bad plan?
I would never dare to say this is a bad plan anyway. So, you know, now we understand why the heart surgeon is in the room. It's actually a quite interesting approach. Because you know, you do the TAVR first, and then then you close surgically. So the question is, if you are doing surgery, so why not replacing the valve? But I understand the approach. I wonder what the panel is thinking. Any thoughts on how to proceed in this case? This is a very interesting case to discuss, actually, Peter.
Yeah. So just let me give you two more sentences. Why don't we, go for a surgical, aortic valve exchange, right? So that's what you ask. It's a pretty frail lady. She is 80. She was 80 yesterday. So yesterday was her 80th birthday. And this was the very obvious decision of the heart team that they shouldn't go for a surgical aortic valve replacement, but a TAVR.
Yeah.
And the appendage closure will be surgically. Balazs, do you have a mic? Would you please explain what you're planning to do? So it's going to be kind of a semi-invasive surgical closure.
Yeah, that.
So it will be a total endoscopic left appendage closure. So we will have two parts, and it's a total endoscopic way with a 3D endoscope and with the AtriClip Pro V device because of the presence of the left appendage thrombus. So we will clip the left appendage.
Yeah.
So we want to be as non-invasive as just possible. Yeah. Eberhard, it's your turn. I'm sorry to interrupt you.
No, that's well understood. I think that's a very, very reasonable approach because the damn thrombus in there, you can't ignore it. Mm-hmm. You know, you have to deal with it. So this is very interesting. I think I see. Yeah, go ahead.
High risk of wall thrombosis is also there after tower with this LA clot and LA clot, and it would be a problematic after tower. I think so.
Yeah. So Peter, I know that you know we have 30 minutes. Oh no, 15 minutes left. So I know that you are a fast operator with your team, but we would really see something, and I wonder, you know, what the next steps would be as far as valve choice and.
Yeah.
And, I'm not sure. Did we see the calcification of the?
Not yet. Not yet. We will.
Okay. I'm sorry.
The next slide, please. The next slide, please. Okay, so as you can see that it's going to be a 26 millimeter Evolut Pro Plus. That is the plan. And as you can see that the minimum diameter is 19.6, and we plan to pre-dilate this valve with an 18 millimeter balloon because it's a very, very, very tight anatomy. Show us the other slide, please, the next one. So as you can see that this valve is pretty calcified, but there is a very calcified bridge around the edge of the non-coronary leaflet. The other leaflets are not that calcified. The next one, please. So these are the coronaries, pretty good coronary height, and nice and patent coronary arteries. The next one, at least the orifices. We are planned to have some femoral issue. We decided to go for the left femoral. So the large sheet is in the left femoral. It's a 14 French sheet. It's in the left femoral artery, and we have a 6 French sheet in the right femoral artery. The anesthesia is using the left radial artery. And the next one, please. So the TAVR first and the thoracoscopic surgical appendage closure will be in the next one, the next slide. So the Evolut 26 Pro Plus and Balaj will be using an AtriClip Pro V for the closure. The next one, please. This is the team when we were much, much, much younger. It was in 2008. Right after our first TAVR implant.
You haven't aged.
Thank you very much. Yes.
You haven't aged, Peter.
Oh, well, thanks. At least I'm trying not to. Would you please fix my mask because I'm talking too much? Thank you. Thank you. So, please, and please show us the angiogram, the first angiogram.
So can I ask you
see
a question?
The angio?
Can I ask you a quick question, Peter?
Oh yeah, please.
The calcification, at least in one image, I had the thought that it was reaching down into the outflow tract, or was I wrong?
No. The alveoli is free.
Okay, good.
The alveoli is free, and as you can see, there's the sentinel device in place.
Very good.
The appendage thrombus is definitely not a contraindication for a TAVR procedure. That's what we all know. But we are going to use rapid pacing for the pre-ballooning. And there is a very, very, very slight chance that when we change the heart rate, the thrombus will move away from the appendage. And we don't like that. So that's why we decided to go for the sentinel device.
Yeah, this is very good. And I'm just wondering when you're pacing, I mean, the patient does have a permanent pacemaker, but if you're pacing and you rapid pace, supposedly 180, and you stop pacing.
Yes, that's the plan, yes.
Yes, so that would be something, all of a sudden the heart kicks in and that might move actually the thrombus. So
yes,
I don't know what your plans are, but in this situation, I would probably slowly reduce the pacemaker rate and then let the pacemaker take over. But it's very interesting. But I'm glad you're using the Sentinel, Peter.
Yeah, that is the plan. As you can see, well, would you please take a look at the bovine arch? So it was not easy. It's not impossible, but it's definitely not easy to properly position the Sentinel device. But I think it's a pretty good position for the cages, for both cages. Anyway, what about putting the Landaquist wire? We are going to use Landaquist wire because we are prepared for the femoral iliac difficulties. So let's do it.
While you're doing your job there, any comments as far as the valve choice is concerned? Because at least there's some good news in this poor patient that the coronaries are at least okay. But the access seemed to be feasible, right, Peter?
Yes, the access seems to be feasible. It is calcified, but since you always go for an ultrasound guided puncture, with the ultrasound, it's just easy to avoid puncturing the calcific plaques. So we don't, to be honest to you, we are prepared for the difficulties, but I do not expect any significant femoral difficulties during going up with the device.
Yeah.
The puncture is ultrasound guided, I think so.
Yes, definitely. Both are ultrasound guided. It's a must. Yeah. Definitely. So I think that nowadays, I mean, we are a radial center, but even if we have to use the femoral artery as a bailout for a PCI, it has to be, it's mandatory for to go for ultrasound guided puncture, even for PCIs.
Yeah.
Okay. So the balloon in place. Próbálom majd lassan csökkenteni. Christian, can you, we can start the placing, but please go up gradually and please come down gradually, okay? Yes, please start. Okay, so we have started the pacing. The device, of course, needs some time. The balloon, please. Very good, balloon down, and please decrease it gradually, okay? And the pacing rate is coming down. Okay. Okay, Gesa is coming out with the balloon. Perfect, stop pacing because we space the patient.
You can increase the heart rate, no problem by the...
Yeah.
What was the balloon size?
Yeah. The balloon size was 18.
I see.
The minimal diameter is 19.6. So that's why we decided to use an 18 millimeter balloon.
Yeah, that's great.
So, okay. Good. So the sheet is coming out, as you can see. Would you please show us? Oh yeah, you can see my hand. Very good. So the device is coming. Very good. I've just plugged. Okay. So the flash port is towards like 3 o'clock. So please show us the groin, Anna. The groin, please.
Yeah. So that's
very good. We're going up with the design. Show us the wire in the LV.
Alignment.
Very good. It's a good LV position. Go down to the valve. Very good. Right, please. Okay. So I stopped here because we are still in the descending aorta, and this is the last and safest point when we can check the position of the flash port. So the flash port is still towards 3 o'clock. So then we can proceed. It's very important for the commissioner alignment.
Yes.
Okay.
Yeah.
So we are in LAO. So we are going through the arch, and please concentrate on the head marker, okay? The head marker is in the outer curve.
Yep.
So it means that the commissure alignment, hopefully, is pretty good. So please come back to AP Anna, please. Okay.
Head marker at the outer curve and flush.
Yes, head marker is at the outer curve, so that's good.
Yeah.
Okay, so we are crossing the valve. Very good. Let me see whether the pigtail is free. Yeah, the pigtail is free, so it's in the non-coronary cusp. And we are going to the cusp overlap. Would you please fix my mask? Thank you. Thank you. Thanks. Again. Yes.
So you put the marker.
Eberhard.
Yeah, you put the marker at the pigtail.
Yes,
right?
yes, I'm going down to the mid pigtail level.
Yeah.
Yeah, that is the plan. It's a Lundquist wire. So let's go for an aorta. Anna, please, a bit more caudal. Stay because we need to kind of modify the cusp overlap. Please come caudal a bit. Because it's a ring and not a line. So we're going to align the ring. Bit more. That's perfect, Anna. Thanks. So let's go for an aortogram and let's see where we are, okay?
Yep.
Let's do it. So
nice.
I think it's pretty good, right?
Very nice.
So it's nicely aligned. The coronaries are open. So let's go for a pacing, okay? 120, Christian, please. Geza has started opening the van. No, not start. I will tell you why. Okay, so please start the pacing. Wait a second. Yes, okay, let's go. So Geza is opening the valve. Some contrast on a place, just to. Very good. Okay. See, okay, stop pacing, please. There you go. Okay. So let's see what we have got, what we have done, okay? Some contra. Okay, we are going to LAO. Please concentrate on the non-coronary cusp. There's an infolding there. Okay, let's do it. Eberhard, what do you think?
It's a little bit hard to see, but I think the position is actually
This
great.
is the right position.
It's high, although it doesn't make much difference, the depth here with a permanent pacemaker. But I think you've done a really good job, Peter, as far as implant depth is concerned.
Yeah. So would you put it down? I would.
Yeah.
I would. So let's do it. Let's do it under like controlled pacing, 120, and let's give us something again. Geza suggested me to pull out the pigtail. Yes, I will.
Did you mention an infold? I can't see this from here.
You cannot see it from. Go to cusp overlap on a place.
Don't worry about it. Just finish it.
Oh no. Let's see. The patient is stable.
So this tells you Peter and his team are very experienced. They're looking at the infold with the cervic calcification. Many patients overlook this, but it is an important aspect.
It disappeared, Eberhard. There's no infolding.
Yeah, because it's Peter that's doing it. The valve.
Okay, so Geza will replay it for you.
Very
Please
good.
take a look at that.
Eberhard, I think you always stress to see it in both views also, because sometimes.
Can you see that? So it's pretty suspicious that there is some infolding. Can you see it now?
Yeah.
Non-coronary cusp. There are the bridges.
Yeah.
The calcified bridges, but it disappeared. So it means that the valve kind of worked out itself. Okay, so let's put it down, okay? Menj nyugodtan vissza, Anna.
So you release it, right?
Yeah, so we went to LAO. So Geza, please pull the wire. Geza has pulled the wire just to ease the tension. Pacing, please. Christian has started the pacing.
Peter, this is Dr. Srinivas Kumar here. Some people have the habit of just before releasing, leave the valve in position for a few minutes and allow it to expand. Do you practice? Anyway, you have released it. That means you don't do it. But whatever do you
Actually, since I was talking too much, stop pacing, please. Since I was talking too much, basically I did it. Normally we don't do it, to be honest. Too. So let's check whether the valve or the catheter has detached or not. So I just pushed the system a bit, see, and it got detached. So now it's safe to pull the wire even more, just to centralize the nose cone, and then we are
That's a
coming
very
out.
important step.
Keep the wire in.
Get to the nose cone back while seeing it.
Yeah.
Sometimes it could catch.
So we are out. So Geza is closing the valve. So just give me a second. Would you please fix my mask again? I'm sorry. Thank you. Thanks. You can tell that I'm talking too much. So since there is so the patient is intubated, let's go for a transvaginal echo just to see what we have done so far. Okay, let's go for a sheet exchange.
Yeah, maybe you can pull the wire a little bit, but
yeah,
only minor.
We will in a minute. Yes, I'm gonna exchange it to a pigtail.
I think I mean, from what I see here, the implant depth is perfect, Peter.
Oh, thanks.
As Srinivas said, you know, before you finish, I think it is good if you would verify the expansion into orthogonal views of the intensifier.
We will. Let me just exchange the Olandaquist to a pigtail.
Yeah.
Because it will cause some leak anyway.
Yeah, you have the TE in place.
Yeah. So normally we don't have it, so we just check the valve with the transthoracic echo, but since the probe is down anyway,
yeah.
So let's just use it.
Interesting that the fold went away, no?
Yes. Yeah. So it means that it's a pretty good valve.
Yeah.
So it has a very, very good radial force.
Yes, coronary
Sorry, I'm just
visualize.
Okay, let me just flush the system. Okay, zero it, nulla, let's see. Okay, let's add some pressure. So can you see the hemodynamics?
No. We see the echo now.
You can see the echo. Okay.
Yeah. Okay, now we see
you
it.
can see the hemodynamics.
That looks
okay,
good.
There's
though.
no. Okay, so it looking pretty good, and there's a pretty good diastolic separation.
Very good.
So, so I think it's fine. Anna, please, let's just stay here. Let's just wait for the echo, and then angio after that.
Srinivas,
Monica, what do you think about the depth?
Looking good, no?
Actually, I took not come.
Yes, there is no gradient.
No gradient at all. You can't have anything better than this.
Thank you. So let's just take a look at the echo leak, because we haven't had a chance to go for an aortogram.
It's a good practice to check on the echo also once I feel so. Many of the centers they don't have, and they don't even check echo, but it's all.
So what we do while Monica is working, and I don't know how much time we still have, but what we do, so we exchange the wire to a pigtail, and the first is to go for an aortogram after like 5, 6, 7, 10 minutes. And then if there is no much paravalvular leak or any leak, then we go for a transthoracic echo. It's mandatory. And then if there is no question, then we stop. If there is question, we put down the transvaginal echo. The patients are normally consciously sedated, so we can just deepen the sedation with some propofol, and then we just go for a quick transvaginal echo. But since at this time the probe was down, I just wanted to check it. Monica, what can you say?
The position is perfect for the TAVR,
And there is only a trace paravalvular leak.
Trace paravalvular leak.
Just
Thank
to
you.
remind.
And I don't know whether you can see that there is a remaining kidney shape. Can you see that? Now you can see it.
Yes.
And they're short axis. But luckily there is no significant paravalvular leak, and we don't go for cosmetic procedures. So I think that gives up what this thing. Shall we stop? Yeah. Eberhard?
Yes, I think.
Yeah,
I
think
think
so too.
considering the age of the patient and
Yes.
the complexity of the case now, I think I wouldn't be overly aggressive with a trace paravalvular leak. I mean, what he's done actually, the implant depth is perfect.
Okay, so let's go for an aortogram just to see.
No, just don't disappoint us.
Actually, self-expanding valve might expand a little also.
So much
Shall I
comorbid
do it
conditions
from here?
is excellent result.
So please let me remove the picture from the LV. Kis drótot adjára, akarom mag csak úgy kihúzni. And what we could do, we could add only like 5 ml and then we will not see anything. What do you think? Just not to disappoint you. We would never do that. Anyway.
Okay.
So, here's a... Okay, let's do it.
Excellent. No
Whoa.
paravalvular leak, really.
Very, very nice, Peter. Very, very nice.
I think that this is the end of the first step, if you agree with us.
Yeah.
And thanks a lot for having us in Hyderabad. It was our definite pleasure to be with you virtually.
Thank you, Peter, for the great
So,
demonstration.
Peter, thank you very much. Obviously, I'm only chairing this together with my friends here, but Dr. Srinivas has the last word. Excellent demonstration. Your team is, as always, superb, and the judgment was excellent. And we wish you, the team, and the patient, of course, best of luck now with the next step. So, Srinivas,
Thank you.
you want to?
Any questions or any doubts from anybody in the audience before they close? I think that's shown very well. Thank you, Peter, and
Congratulatory once again.
I think
Excellent.
Everard, Fazila, big round of applause for them. Dr. Fazila Malik wants to show her last pictures in Bangladesh. We'll just go for 2 minutes. Can you? Thank you, Peter.
Thank you very much. Thanks. Have a great time.
Yeah,
in
Madam
Hyderabad.
Dr. Srinivas Kumari here. We are back with you. Wanted to show the final shots. Are you able to hear me?
Yeah, can you hear us?
Yeah. Go ahead.
Audible.
So we took a 3x38 synergy, and after deploying it, you'll be happy to see that the diagonal is flowing fine. And then we did post dilatation of the proximal part with a 4x8 millimeter balloon. NC balloon went up to very high pressure, and for the rest, we did it with a 3.5 by 10 millimeter balloon. And after post dilatation, let's have a final. So this is the final angiographic view, but the OCT showed that there was some malapposition and under expansion. So we did further post dilatation again, and after that, it looked a lot better. So we went and did post dilatation again, and this is the final result. And the OCT is also showing that it's just fine. Can we have another AP? Yeah, so this is the final result.
Yeah.
Angiographically, and OCT looks also fine.
Yeah,
so after we did post dilatation.
Thank you very much.
So that's us done.
You should not be worried for the diagonal, because at least 2 to 3 diagonal is there.
Yes, it is there. Thank you. So thank you for giving us the opportunity of sharing this case with you. We are truly grateful. Thank you so much.
Thank you, madam. Thank you.
Are you closing?
Yeah, that's the conclusion. Thank you. Thank you.
think the other hall is also closed. Did they come to this, or is something going on there? Yeah, I think we come to the end of this year's TCT Plus India meeting. We thank all of you for all the cooperation. I think we're extremely happy to see a good number of doctors responding. Many of them message that the content lectures were very good and the faculty was top class. See, a person like Everard Grube is staying with us till end means a lot for us, sir. Thank you. And Ajay is CRF staff and others are there. I request Ajay to come on to stage and say a few words about this meeting. Then I'll express my final vote of thanks.
Thanks, Srinivas. I didn't have anything prepared to say, but I can just say that, we were all thrilled by the conference and how the participation, the speakers, what we were able to accomplish this year in terms of our goals is something we feel happy about, but we only feel that this can get better and has some momentum in terms of a lot of the teaching, the practicality of the course. There were some inspiring data talks as well, but throughout all the sessions, you really saw a lot of practical-based focus, which is I think what the folks in India really need. I felt strongly for a long time that the physicians in India are among the smartest physicians you'll ever meet. They read voraciously. Gary and I talk about how people are reading late at night. They stay up at night looking at webinars, etc. But a lot of it is just trying to put things together in an experiential way and understand when to do things, how to do things, and that was what we tried to aim for this course. So once again, we're really thrilled with the collaboration. It's been a true testament to the work of Srinivas. He mentioned Sanjog Kalra yesterday in terms of all the work he did with the program. Really impressive, makes me happy as one of our former fellows. And we just aim to keep continuing doing it. So thanks so much for everything and for everybody. Thanks to all the staff who put it together as well. We know these meetings can never happen without them too. So thanks again.
Thank you, Ajay, for all the encouragement and support, and it means a lot to our Indian community and cardiologists and all of us here. And as all good things had to come to end, now I thought I'll just present a brief memories of that intro video and also concluding small brief clippings of this meeting. Can you play that intro video, what we made first? You have it? Then as it gets started, we wanted to inform you that this is a concluding video. It's okay, play it, no problem. Next year, we'd all meet in July 25th, 26th, the same July last weekend in Delhi. Yeah, this is the introduction video about heart team concept we made on the big screen. I wanted to enjoy this once. Then we'll go to concluding.
Larry Page and Sergey Brin brought the internet to our fingertips. Leander Paes and Mahesh Bhupathi elevated India to global prominence in the world of tennis. James Watson and Francis Crick illuminated the structure of life. Together, the heart team of cardiac surgeons and cardiologists have brought brighter outcomes and results to patients. Cardiovascular Research Foundation, USA, and Facts Foundation have forged an incredibly successful partnership in interventional cardiovascular medicine. This decade-long synergetic collaboration has bridged the gap between research and clinical practice. Coming together is the start. Staying together is progress. and working together leads to success. TCT Plus India 2024.
Working together further, I assure you that a lot more good things are about to happen. We were just discussing with Ajay and Juan regarding how to take this meeting forward. And a lot of good news is yet to follow to our country people, be it in the form of attending the main meeting, a TCT there, or having some of the presentations from there coming to here, and mailing coming from the CRF. And I'm happy to share that TCT CRF has agreed that all our presentations will be there on the TCT MD site, so that all of us could have the access. Many of the doctors were requesting me for the lectures, links and all that, so that way it will be available to all. Thank you again for Ajay and for putting all this together and making CRF accepts. I think, as I told before, again I keep telling it's pleasant duty of me for happiness. Ajay has now taken over the role of Marty Leon there. He is Chief of Interventional Cardiology in New York Columbia Presbyterian University. I think you should all congratulate. This happened last year, but I keep telling it. Thank you. We're proud. We make India proud, Ajay. I think, can you play this concluding video now? This is done a little in less time, but please watch. Sound? That was the photo booth which many doctors enjoyed. And then we had clippings of the various programs happening. I don't know what happened. It's okay. Then this is, are you doing it? It was playing before. Anyway, already many of them have to catch flights. Not delayed further. Thank you again. And before I close, it was the inaugural function. Inauguration, that sand artist did wonderful things. So many of them liked that too. It was TEMI India session. This is a Tower Advanced Deep Dive session.